patient. Several operations, as we all know. We have, of course, the Mueller's muscle resection, the aponeurosis advancement, levator resection, which is for children, usually not for cosmetic surgery, frontalis sling, which we might use in adults for bilateral procedure in myogenic ptosis, frontalis flap, which is more or less for the same indication, but used in children, and the conjoint fascial sheath suspension, which I'm not very good at, but has gone viral in the Far East recently. But basically, when we see these patients that have a slight ptosis and need upper lid blepharoplasty, so have dermatochalasis, what they complain of usually are these ladies in middle 40s. And they usually say, okay, I'm not happy about my left eye, in this case with an excess skin. And, but if we have a look at the face, there is something more going on. So of course there is the excess skin, which is different in both eyes, but then we see the skin crease, which is higher on the right side. So this suggests something, of course. And there is the brow height that the patient like. They say, okay, I like the height of my brow. Can you do something to my brow on the left side? So we get some information. There is a slight involutional ptosis on the right side. The frontalis action is normal. And so we know that this lady didn't have Botox on her brows. But what should we do in this kind of patient? Basically, when we want to correct ptosis and upper lid blepharoplasty, our choice is between these two operations, as we all know, the Mueller's muscle resection or the aponeurosis advancement. What would we choose? Of course, when we want to do an easy operation in a lady in her late 60s who doesn't want that much, we can do a bilateral aponeurosis advancement. We can try to mobilize her pre-aponeurotic fat pad, if any, and we get a reasonable result. Then we send the patient to Milland to get some fillers afterwards or fat injection. But we can have a nice contour and readjust the lash ptosis during an aponeurosis advancement. And the typical indication for a posterior approach conjunctiva Mueller's resection is when we have, of course, the positive phenylephrine response, like in this lady. We put a drop, we see the pupil is dilated, and with an easy operation, which is easy, anybody can learn it, and is very quick, we can have a very good result. But when we can use this also for more subtle indication, again, there is a positive phenylephrine response, and we can do simultaneously a Mueller muscle resection together with a subtle operation to reduce the brow fat pad. So we can combine the two and get a subtle, nice result, avoiding the fullness of the brows. And what else do we have to consider? Is that over? Of course not. There is the Herring's phenomenon, which is very important. There is the problem of the eye dominance. There is the proprioceptive phenomenon to consider. There is the tarsal platform show, which is very important. And as I mentioned, the brow descent. You see what happens when my assistant raises the more ptotic eyelid of this lady. So we always have to consider ptosis as a bilateral disease, unless it's post-traumatic. And also the eye dominance is very important because the levator muscle tone is influenced by ocular dominance when we have ptosis. What does it mean? That we might find a case like this. So you see that there is a paradox brow elevation on the non-ptotic side due to the strong eye dominance. So what we have to do in this case, we have to have the courage to overcorrect a lot the non-dominant eye on the table to get in a couple of months, because that's how it takes the final result, a final result like this. And then, of course, we can do an asymmetric skin removal. This is another interesting case. There is an old lady, so she has a ptosis on the left side, but again, you see it is the right brow that is elevated. Why does it happen? For two reasons: a strong right eye dominance, and at the same time there is an asymmetric dermatochalasis. So there are two reflexes, one due to the eye dominance and one due to the excess skin, and this lady tends to raise the right brow. What shall we do? You see that even under local anesthesia, there is this still the elevation of the right brow. So we have to overcorrect the ptosis done for the posterior approach and do an asymmetric removal of skin. And you see that with time, in an old lady, you can have a reasonable result. Of course, the brow position is not perfect, but is much better than to start with. And we just did the operation and an upper lid bilateral blepharoplasty. Of course, we have to take care about the right skin removal, which have to be asymmetric. And we don't have to overdo on the left side. To get the things more complicated, let's have a look at this patient. These two are anophthalmic patients. So they have a prosthesis in their left eyes. And as you can see, there is a slight elevation of the brow. So why does it happen? So the visual stimulus is not the only one that raises the brow. There is also a proprioceptive phenomenon. So it might be the stimulus of the prosthesis, or some proprioceptive receptors have been identified within the Mueller's muscle that is obviously much more important than we ever thought of. So we have to keep it in mind, because if we have a look at your anophthalmic patients, you see that most of them have a raised brow in the anophthalmic eye, and we have a look of that. So which one would you choose? Would you choose an anterior approach, or would you choose a posterior approach? So these are the pros and cons that we all know about the two techniques. Of course, when you listen to the American surgeons, the American authors, there is a slight bias towards the posterior approach, because I mean, in the United States, when you perform an upper lid blepharoplasty and the ptosis from the posterior approach, the insurance company will recognize two procedures. So just beware of that. In my practice, a few years ago, I switched about 50% now I'm back, let's say 60% to anterior approach. So you have to choose very carefully between the two. So usually if the tarsal platform show is higher on the side where ptosis is present, usually unilateral ptosis surgery is enough. You have to overcorrect it a little bit, then in 1 or 2 months, let's say 7 or 8 weeks, you get, with just the ptosis, a nice result. But then you have to choose in these cases. So in this lady, this is the same lady that you saw at the beginning. She came to me 10 years ago. She didn't do anything at all, and she came back 10 years later. So you can see that the excess skin is much worse on the left side. What did we do? Just a simple operation. Don't overdo, please, in these patients, unless the patients request to overdo or to change their appearance. So if you see that if you do an aponeurosis advancement on the right-hand side and you do an asymmetric blepharoplasty, you have a reasonable result with a similar tarsal platform show on both sides and a nice brow position. And again, this is another lady who came complaining, of course, of the excess skin on one side, and she said, okay, I have a wrinkle on my left side and I have a left headache every evening when I'm working, when I'm in my office. So what did we do? Of course, we did the blepharoplasty, we did an aponeurosis advancement on the left side, and you see that the brow position improves without any action on the brows. And of course, there are different types. This is when ptosis seems not to be there, there is always a subtle ptosis. So what can you try to do in these cases? You advance the aponeurosis from the anterior approach. You do of course, the bilateral blepharoplasty. And if this is not enough on the table, you can either try to reposition the right brow very easily with a brow pexy, or you can choose which kind of Botox do at the end of the operation or within 3 to 4 weeks. And then you have a reasonable brow position. And of course, there are cases in which you have to do more things altogether. I mean, this is a very easy case, is an old gentleman, but you have to do 3 things altogether. So in a man with these big brows, it's very easy to do a direct brow lift, a lateral one, and of course, touch the aponeurosis and do the blepharoplasty. And this is the final result. So basically, how to manage both. Of course, think about the Harris phenomenon, think about the eye dominance, remember that there is the proprioceptive phenomenon, remember the importance of the tarsal platform show. This is more important than the height of the lid. And of course, the brow descent, because we have to think of the upper third of the face, not only to the lid height. And remember that additional brow procedure should be suggested only if ptosis correction and upper lid blepharoplasty are unlikely to improve the eyebrow position itself. And it doesn't matter what you choose, you only have to try to make the patient smile. Thank you very much.
Thank you very much, Professor. Now I'm very glad to introduce again Professor Yunia Arwati. Professor Yunia is coming all the way from Jakarta, Indonesia. She's the Vice President of Asia Pacific Ophthalmic Plastic and Reconstructive Surgery, President of the Oculoplastic Society in Indonesia. She'll be talking to us about helpful hints in reconstruction of mechanical blepharoptosis, correct? Yes.
Thank you, Dr. Khalid. Good morning, everyone. Today I would like to share with all of you with the title of helpful in to reconstruct the mechanical blepharoptosis. There is no financial in my presentation. I have a patient with a 37-year-old male come to our clinic with a droopy eyelid because the huge mass at the upper eyelid, right eyes. For the ophthalmological examination, the vision is normal. There was a mass in the superior part with the size 3.5 times 2.5 and 1.5 centimeter, well-defined nodular, soft and mobile. There was no painless. And for the eye movement, there was a mildly restricted at the temporal due to the chemosis at the temporal region of the conjunctival bulbi. There was no any RAPD. There was the anterior segment and posterior segment with a normal limit. This patient, I plan to debulking the tumor mass and do the pathology examination. I'll do the reconstructive of the eyelid. The distinction of the tumor, there is no infiltrate the levator muscle, and I'll do the transverse skin resection of the upper eyelid and the lateral cantopexy and cantoplasty. This is when I preparing the patient during the surgery. I make it the incision, the horizontal incision at the lid crease place, comparing with a fellow eye in the normal position on 5 millimeters upon the margin. And I make it the blended section, separate encapsulated the mass, and extirpation the tumor along with the capsule. During the operation, I identified the levator muscle as still intact, and I'll do the mold, the upper eyelid on the right side and comparing with the normal fellow eye. And I make it a dot in here. Okay. Dot at the central pupil, and then the medial part of the limbus and the lateral part of the limbus. And then I measure the height or the distance of the upper eyelid between the crease and the suprabrow. And this is when I already excise some skin. And then because the eyelid still looking droopy at the lateral part, and of course we should be make it a wide excision at the lateral part, and then we attach the cantopexy and make it the cantoplasty. This is after the surgery, and this is when we show the patient before and after surgery. I think now the patient have a good confidence, and the complication for the ptosis we can avoid because the tumor is synthesis. It's not an involved to the left or upper neurosis. This is my second patient, 8 years old boy, come to us with a droopy eyelid since 6 months. I think we all know this is a typical for the neurofibroma case. And with this, in this thing, it's of an immobile and tartal conjunctival with eversion. And for the eye, I think the eye a little bit hypoglobus, but he had normal eyes. This is for the MRI. We can see this is a typical for the neurofibroma, toes, and the temporal bone is a little bit thin. Yeah, in here we also make it reconstructive for the right eye, and because the mass until the conjunctiva, and then prefer to do the frontalis sling to make it reconstructive for the ptosis eye. And for discussion, I think the mechanical blepharoptosis is conditioned. The eye and the mass pull down the eyelid and resulting the infrared displacement. The most common cause is the hemangiocalazion, neurofibrom, and dermoid kiss at the of the eyelid. I think we already know the anatomical of the layer of all eye layer eyelid. For the epidemiology, I think I just find some institution that have 2% case with the mechanical blepharoptosis. In our study in my hospital is also found the 2% case mechanical blepharoptosis. Drooping the eyelid, bruise fission with the Dennis upper visual field, I think in common in mechanical blepharoptosis, sometimes the patient can find dryness and watery eyes. For the examination, I think we do very well examine the eyelid and then do the palpation to know is there the mass sticky to the all layer of the eyelid, or only mobile, or all stick to the orbital rim. And what about the ocular eye movement, visual acuity, and anterior and posterior segment? I think for the ptosis eye, we always do the examine for the ptosis measurement. And the management blepharoptosis, I think, is still Indian for oculoplastic because some problem we cannot done in the mechanical blepharoptosis to one-step surgery because sometimes difficulty to measuring the levator function due to the tumor mass. But I think the indication why we do the surgery in patient with the mechanical blepharoptosis, of course, because there is obstruction in the visual field or interferes with the activity or daily living or the caused by cosmetic reason. I think from the first, Professor Leone already talked about how approach in the blepharoptosis case. Yeah? And here, I think why we can choose mulerectomy or levator surgery, yeah, aponeurosis resection, or we can do the frontalis suspension surgery in the severe blepharoptosis. Yeah, for the objective, I think for the successful, we would like to make it a good cosmesis. Of course, we know about the fellow eye higher. Usually, the position is 1 until 2 millimeter of desire of the height of the limb of the cornea. And for the subjective evaluation, the patient appearance is very important, and satisfaction and level of self-confidence for social life of patient is very important. Also, the complication of surgery sometimes had under or over correction. We should be tell the patient, because we cannot promise for all the patient case can have good position in the first surgery, but we should be do very well for the patient, but don't promise to the patient, because sometimes if you do with the general anesthesia, we cannot predict how high the eyelid after surgery. And like the Professor Leone said before, sometimes we need a time to waiting the healing process for the patient. Yeah. Of course, this unsatisfactory or asymmetric eyelid contour can happen to the patient with the ptosis eye surgery. Scarring, infection, and the lack of thalamus can happen in a patient with blepharoptosis after the surgery, especially in the frontalis sling. And using the eye drop gel, I think is very important to educate the patient. For the take-home message, the management of blepharoptosis, I think, is still challenging. The correct diagnosis, planning, and understanding of the eyelid anatomy, our experience, and the good surgical technique, I think, is essential to oculoplastic surgeon. And the surgery usually cannot be done in one-step surgery, but we should be trying the best for the patient. And using the contralateral eye as a model, I think it's very important, because we are oculoplastic, always open both eyes to know how about appearance of the patient during the surgery. I think this is my presentation. Thank you for your attention.
Well, our next speaker is Dr. Hoseok Sa, who comes from Seoul, Korea, and he'll be talking to us on 3D reconstruction in 3D printing in orbital reconstruction.
Thank you, Milan, for kind introduction. So it's my privilege to talk about orbital reconstruction using 3D printing technology. Spanish architect Gaudi said, the straight line belongs to man and curved line belongs to God. It can be applied to human bone. And in human orbital bone, there is no two-dimensional plane. And when we do the orbital reconstruction, usually because of the blood fracture repair, so we can use various implant materials but these days, nowadays, usually synthetic one is commonly used. But when you see the synthetic implants, they are all two-dimensional plane. And Gaudi would have been upset if he knew this fact. So for successful blood fracture repair, so entire orbital fracture ring should be exposed and all bony ridge should be covered properly using the implant. So traditional method for designing an implant depends on defect measurement with visual inspection and manual cutting of two-dimensional implant. But the quality depends on the surgeon's experience and skill, and it is very time-consuming procedure. In addition, the two-dimensional orbital implant would not fit well the three-dimensional structure of the orbit. So there is a possibility of complication, including inophthalmos diplopia or implant displacement. So if you can use the three-dimensional patient-specific implant or PSI, it would be very helpful. So 3D printing technology can be applied to the orbital surgery as a patient-specific implants, virtual planning, or simulation or guide of the orbital surgery. Personally, I use 3D printing technology for orbital reconstruction as surgical guide or implantable device. I'm going to talk about them one by one. The 3D printing surgical guide is a method to print 3D templates or press to three-dimensionally press the two-dimensional conventional implant. For the process, the bone segmentation is performed to make a virtual 3D model of the segmented bone. And using the surface generation program, we can make a 3D model of the implant to cover the defect properly. So we don't want to direct printing of implant in this method. We want to print out upper and lower template and press a two-dimensional implant to make some shape and good size. These are printed out templates and press. And you can see a good size and configuration of the template. So we can use this to press the two-dimensional implant. During surgery, the two-dimensional implant is placed onto the lower template, and we can cut along the edge of the template. And upper template is placed, and all of them is inserted to the press to stencil the proper configuration onto the implant. And during surgery, after dissection, can you play this video? Yeah, could you click? Yeah, after dissection, you can just insert the PSI into the defect. So you don't need to pull it out again for further tailoring. So orbital tissue volume was measured for outcome evaluation, and we found that the orbital volume was well restored using this kind of method when compared with contralateral unaffected orbit or pre-operative orbit, which was published 4 years ago. So these are some examples, and right medial wall reconstruction was performed using the PSI. You can see the implant has a good size and shape. Another case of the left orbital floor fracture showing a good result. And right medial and inferior wall fracture, which was repaired using a PSI. This one is another medial wall reconstruction. And this one is a left inferior wall reconstruction. And right inferior and left medial wall reconstruction was performed using PSI. So when it comes to the advantage of 3D printed surgical guide, it only gives a very practical assistance about the proper size and contour of the implant, while we can use our preferred commercially available implant, and which was already tested for sustainability. And this method is not that expensive. But limitation, the cutting the implant along the edge of the template is also a hassle. And sometimes I find it's a little bit difficult to insert the large implant because of the implant rigidity. Moving on to the next method. So I'm going to talk about direct printing of the orbital PSI. So personally, I use polycaprolactam, which is a bioresorbable material to make a implant. So after segmentation of the patient's orbit, including the defect, we can make a 3D virtual image of the implant. It can be easily modified and confirmed by the surgeon prior to direct printing of the implant. You can see a 3D virtual model has a good shape and size. So these are printing. Can you play the left down video? So we can print out the patient PSI, which is malleable. So it is very easy to insert. And as you can see in the right down side, so you can easily insert the implant, which will fit the defect very well. These are some cases. We've been using this kind of direct printed PSI in more than 60 patients. We found a good result so far in the long-term follow-up. And this patient had a left orbital floor reconstruction using PSI and right medial wall reconstruction using PSI. As you can see, probably due to the bony repositioning towards the implant and remodeling, so you can see the reconstructed orbit cannot be distinguished from the contralateral normal orbit. And this patient had a left medial and inferior wall reconstruction, showing the good result. And these days we make a PSI, the radio opaque, by adding some material when we do the 3D printing. So it can be shown very well in on the postoperative CT scan, as you can see here. And this patient had a right medial and inferior fracture, including the bony strut. So in this case, I usually print out on one large implant, PSI, and cut in half and insert each implant to medial and inferior wall, respectively. So with this kind of method, you don't need to temporarily disinsert the inferior oblique muscle, which might be related to the torsional diplopia postoperatively. So this video shows this method. Can you play the video, please? When I do medial and inferior wall reconstruction, the inferior oblique muscle is intact. You can see the inferior implant and medial implant. There's a good opposition between each other. And so far, we found the good result without any intra and postoperative complications. And in-ophthalmos were very well corrected in all cases without showing EOM limitation after surgery. So orbital volume was well restored compared to prior preoperative volume. And we also performed the morphometric analysis to see how similar the surface of reconstructed orbit is to one of the contralateral normal orbit. So we found preoperatively there was kind of 3 to 4 millimeter gap between normal orbit and affected orbit. But after the surgery, the difference reduced to around 1 millimeter, which shows it has a good simulation of the normal orbit. So I'm going to share some other cases other than blood fracture repair. And this patient with bilateral enophthalmos, he wanted to receive the enophthalmos correction. So we decided to use a 3D patient-specific wedge implant for volume augmentation. This is a customized 3D wedge implant. And we inserted the implant under the periorbital using the previous incision line because he received a multiple session of surgery before and wound was closed. And this pre-operative and post-operative appearance and CT scan showed a good improvement. And in addition, as Dr. Millen said, so I added some filler injection to the superior sulcus. And this is the pre-operative and the final appearance. And another patient with large neurofibroma on his on her right face. So we designed the titanium PSI for periorbital reconstruction for her. During surgery, after resection, the neurofibroma as much as possible, I performed the periorbital reconstruction using titanium PSI, as well as eyelid reconstruction. It's not perfect, but there was some improvement here. So advantage of directly printed PSI include more precise reconstruction and convenience. There is no need for further tailoring, and it is easy to insert. And possibly it induces bony repositioning or remodeling, so it can be sustainable without any foreign body related complication. The limitation we have to overcome include it takes some time for producing PSI, and the cost is a little bit expensive compared to other methods. And I found it could be less sustainable for some cases with a large defect. So in addition, most patients like 3D printing technology, just like most people like custom tailored suit rather than the ready-made suit. And in conclusion, we believe the 3D printing technology could enhance the surgeon experience as well as patient satisfaction. This is my last slide. So someone might say, so why do we really have to do 3D printing? What is hassle? But I would say, so you can go wherever you want with this shabby little car, but probably you want to take a supercar like this because you are special, you deserve it. Probably our patients want the same thing. Thank you for your attention.
It is my honor to invite Professor Dr. Mahmoud Al-Salem, who's the Director of Oculoplastic and Orbital Surgery at the Eye Specialty Hospitals. And he also is the President of the Oculoplasty component of the MIACO. He's going to speak to us on combined and simultaneous approach to the surgical treatment of thyroid eye disease. So.
Thank you, Dr. Naik. Thank you, Dr. Khalid. It's good to be with you and share you some of my work. I have been doing oculoplastic surgery for the last 30 years, but this actually presentation shows how we develop ourselves and how we go over the years and changing management. Okay, I want to start. Okay. No, I want to click and change. This is it. Not coming. Okay. Okay, fine. Fine. So the classical teaching, this is the book teaching of how you surgically should deal with thyroid orbitopathy. That's you first deal with the orbital decompression, muscle disease, eyelid retraction, blepharoplasty, 6 months apart. I mean, they want us to do, if the patient needs these things, 6 months apart. And of course, the classical indication for thyroid decompression were asymmetrical exophthalmos, compressive optic neuropathy, prior muscle surgery, exposure keratitis, intolerance to steroid, and disfiguring ptosis. However, these guidelines are currently changing. So I want to share with you a few cases. One of them is this patient that I have seen some years back. He had actually spontaneous thyroid eye disease with the right eye spontaneous subluxation. His wife, he told me, his eye came out of the globe all of a sudden, and they thought that dreaming, whatever, and it was really frightening. Please, for God's sake, just get it back or do something. So I did 3-wall orbital surgery in his right eye, that he was 40 years old, and this is how actually he looked like after surgery. At that moment, actually, I regretted something. I regretted that I didn't do his eyelid flare. Why didn't do it? Because I couldn't dare. I was just book-minded. I mean, I started actually the orbital surgery the way they taught me, the way I learned that you orbital decompression and wait and see. But now I found this is not really helpful in many patients. Now, the thyroid orbitopathy, we see it commonly. People speak about stages. It's not staged. It's never been stage 1, stage 2. I mean, not every case will be stage 1 and comes to stage 2. But we better classify it into active disease, inactive disease. It's possible. Or say type 1 and type 2. And type 1 is that when they have fatty infiltration and no muscle affection. No muscle affection. That is soft orbit. These typical patients with type 1 proptosis with little muscle involvement, fat, only fat, and it is a soft orbit to start with. And where we say good compliance that is palatable easily. In comparison to these patients they have not active and inactive, but they have type 2 disease. Type 2 disease where you have this kind of muscle infiltration, which is very hard, like what they call it, the radiology people, Pepsi Cola or like sign and so forth. And these are with gross muscle involvement and inflammatory signs somehow, optic nerve. These patients who are likely to get the optic nerve decompression. And actually, this patient is typical, one of them, actually. And I remember the endocrinologist, and actually I had these cases from endocrinologist, usually. And he had this appearance. And actually, he was almost blind, this patient. And in the moment I did the ballotment test for him, it's very hard orbit. He had what you call it, concealed exophthalmos. The ophthalmos is not there because they're a taut orbital septum. And actually what I did is that I decompressed him. He had the thyroid orbitopathy that undergo orbital decompression, 3 volts orbital decompression in the same time for the 2 eyes. And he had the visual acuity in the right hand movement before surgery, and in the left was counting finger. And his vision improved to 6.18 in the right and 6.9 in the left. And after bilateral thyroid decompression, he had residual diplopia and eyelid retraction. So now, why should we wait for 6 months on 6 months? I did actually combined horizontal muscle surgery and blepharotomy. Now I broke the code. I broke the protocol they taught us to do. That was in the year 2001. I remember this case. He had residual dystonia, hypertropia in the right eye, and so forth. So at that time, 20 years back, I started to do what you call it combined surgery for this patient. And he had adjustable suture procedure afterwards. Now, in 2003, he had this patient with a 29-year-old female, and she was controlled thyroid patient. I remember her very well because she came and she told me it is now 29th of June and 29th of July, I will get married, my wedding. You will have 1 month to make the two eyes the same, look the same. And what she had is baggy lower eyelids and eyelid retraction in the right eye. So I did the blepharoplasty, transconjunctival blepharoplasty, and the upper lid retraction in the same time. Also, also what I said now, why not to do a review of these patients? And what I did is that all thyroid orbitopathy patients that have operated by the surgeon as combined procedure in the last 20 years were reviewed as indication, type of procedure, time of surgery, complications, and whether the patient needed another interference or not. The patients were undergone combined procedure for TED and with muscle surgery, eyelid surgery, and so forth. Now, in the year 2013, I had this patient with 58-year-old. He came from Saudi Arabia, actually, and he presented with a proptosis and double vision in the left eye. Clearly, he has dystonia in the left eye, proptosis, and so forth. There was no chance that you really only decompress him without doing his actually inferior rectus tethering. So before surgery, he looked had two problems, the proptosis and the inferior rectus tethering. And this is typical his CT in this picture. It shows a unilateral infiltration. And I did surgery for him. That's two-wall orbital decompression, inferior rectus recession in the left eye were combined simultaneous procedures. So we broke the rule. And also, this is a Libyan man. He came, and this is why actually he had in 2014, 43 years old, and he had bilateral actually proptosis and eyelid retraction. And I did him, and you see him after 4 days. He even didn't wait for a week or so, and they want to travel back. Another indication for this surgery, these patients usually come to us, especially we are working in the private sector, and they want kind of all solution. We came to you, please try to help us as much as possible. We are not coming again. This is what they say. So he had simultaneous procedures, the decompression and eyelid retraction in the same procedure. Also, a 50-year-old, this is a Jordanian fellow, that works as a medical technician, and he had bilateral exophthalmos with eyelid retraction, and his disease is quiet, but actually his appearance is really annoying to him. And actually, I started doing orbital decompression maybe 15 or 20 years back. But first of all, I didn't do it for cosmesis until really I realized that it's needed. Now it is needed. Now we're doing it for disfiguring purposes. For bilateral orbital decompression, he had, and blepharotomy as well. And this is patient, you see him in 5 years' time. Okay. This is a Saudi teacher. I remember him. He had bilateral proptosis, but asymmetrical in the left more than the right. And he came, he said, no, you operate for me the left eye. I don't know why this case I had to do a kind of external approach, and he had a bit of site of the cautery mark, you see, but I had the decompression and the eyelid retraction. My last case here, it shows this man is brought by the endocrinologist to me, and he actually thyroid eye disease, orbit, and so forth. And he has almost 6/9 vision in both eyes, but he's hanging all with the chin up elevated, and he was miserable. Look, he couldn't drive his car for the last 1 year, and he had asymmetrical proptosis, but gross dystopia and chin up position, and he was really miserable. And his CT scan showed infiltration of the muscles and mainly type 2 thyroid orbitopathy. He had bilateral orbital decompression with generous inferior rectus recession. I operated in him in 1 session, and I had a video. I hope it works. If there is a voice, he will tell you the story. عملنا عملية واحدة صح؟
نعم صحيح.
عملية واحدة. So we did 1 surgery so that we get him. Now, now from the 32 patients that needed further muscle surgery and ptosis correction, only 3 patients we had to go again and do vertical diplopia in 1 patient, horizontal diplopia in the other, and ptosis in the third. I mean, second procedures is possible, and it's might likely to be done. And no one can be sure that in 1 surgery that you will do everything, but actually it has a lot of benefit. Now, in 32 patients were undergone combined procedure. These were muscle surgery, recession of tethered muscle, eyelid surgery, whether it was ptosis correction or eyelid retraction, blepharotomy. We have to do this. We have to excel with this until we have Tabiza or Tobrotuzumab, which is not available in Jordan, is not available routinely in the Middle East. We have to excel in doing surgical interference for thyroid orbitopathy. Yes, now combined oculoplastic procedure make operating time slightly longer, yielded very favorable outcome. 3 cases needed secondary intervention. I'm very contented with my approach, which I started 20 years earlier and becoming more popular. This is Francisco Corantiglioni, publishing in Italia. I know that about 1-stage orbital decompression, strabismus, eyelid surgery. When you see your colleagues are doing the same thing, okay, then you feel that you are in the right track. So one of them. And also I came across the simultaneous aesthetic eyelid surgery orbital decompression in 2018. Also the people, San Francisco, but I don't know from where he is, from somewhere else, while doing the same procedure. So we are, as orbital surgeons, we are developing ourselves. We are kind of really changing the attitude, how to really manage these cases. As we have more experience, we see more cases, so we manipulate the way that we interfere with this condition. So combined and simultaneous oculoplastic procedures really were reported in literature. However, recently, very few reports addressed the issue, but with the main stress to the effect of orbital decompression of the eyelid retraction as aesthetic problem. Therefore, we conclude that combined procedure can be a cost-effective means of dealing with thyroid orbitopathy or who have various oculoplastic procedure. Thank you for your attention. If there is any comment or a question, okay. Very good.
I'd like to introduce my good friend, Dr. Habibullah Timadi, head of the oculoplastic unit at Sheikh Shakhbout Medical City. Please.
Thank you very much. It's a pleasure and an honor to be among the esteemed faculty, and I'm humbled with this and excellent talks, mashallah. So I'm going to talk about a couple of cases where we call that when all the measures fail. Next one, please. Oh, yeah. So without any introduction, we'll go into the case itself. It's a 46-year-old lady who present to another hospital with severe thyroid eye disease, decreased vision to 660, and the restriction of the eye movements for the past 1 month or 2 months. And the laboratory investigations indicates hyperthyroidism status as well as high antibodies to the TSI, the TSH receptor antibodies. So when he was admitted, his vision was 660, color vision was nearly 0. And he was admitted, he had 3 shots of IV methylprednisolone and then referred to us. This is on her presentation when she came to us. You know, within a week, her vision was further down, and as you can see in the picture, her color vision was already 0. And this is her Hertel exophthalmometry. She had bilateral severe papilledema, and she had bilateral choroidal folds, and this is in a bigger picture of the, and visual fields were completely nearly gone, and you can see the VEP was down as well, and this is her CT scan. So this was we involved the ENT team, endocrinology, and neurology as well. So they recommended that another course of IV methylprednisolone she had, but there was no improvement. Then we offered her orbital decompression. She disagreed, so she was discharged home on oral steroids. She came back a month later, condition was getting worse. Now the vision was hand movement. I mean, it was hand movement, or it's not no hand movement, it's hand movement. She had another cycle of IV steroids, 1 gram, I don't remember, it was either 500 or 1 gram. And eventually she agreed to bilateral, lateral, and medial orbital wall decompression. She underwent bilateral medial orbital wall decompression by the ENT team. And then we did the lateral orbital wall decompression. And, in these cases, we had a couple of them over the past couple of years. And we removed the bone completely laterally, and we tried to drill as much as we can. So I don't put the lateral orbital rim back. So I just keep it like that. I strongly believe that it can release the orbital pressure laterally as well as medially. So 7 weeks later, these timings are important. I think it's still, her visual acuity, color vision, and pupillary reactions will remain the same, as well as the visual fields. Decision was done to do further surgeries. She underwent total thyroidectomy, and later on, she underwent further left-sided medial orbital wall decompression, endoscopic by ENT team, and 8 weeks following the last surgery, so the repeat orbital wall decompression, still she wasn't getting better anywhere. So we started her on tocilizumab, 4 doses of 8 milligram per kilogram, 4 weeks apart. As you know, tocilizumab is an FDA approved for adult and pediatric rheumatoid arthritis, extremely safe, but not FDA approved for treatment of thyroid eye disease, but there are loads of publications from all around the world regarding its good results in thyroid eye disease. So, so this is, I mean, I'm going just through it's a bit of, we have been spoken about the pathology of the pathophysiology of the thyroid eye disease, that what will happen, and the role of the interleukin-6 in development of thyroid eye disease. 8 weeks. So the patients started slowly to improve with the tocilizumab, and we saw the results 1 month approximately after the first dose, and after the final dose, the 4th dose, the vision was in the right eye 618, 6.9 in the left eye. Color vision came back very nicely. Both optic discs improved beautifully well, though there was a remaining optic nerve paleness, and she went back to work. She's awaiting squint surgery, and this is post-op, and this is her visual field examination, and this is before the treatment. This is after the treatment, just to show. Here is the right and the left eye. This is another case which, let me see, yeah, she came, very similar story, but she came from another city where she had bilateral IV steroids, maybe possibly 8-10 grams, and then bilateral orbital wall decompression, not getting better. Then we tocilizumab her, and he improved very well as well. So this is him. He really didn't need any further surgery at all. I mean, I'll wait 6 months before I do any other surgeries in these people, possibly upper lid debulking a little bit, lower lid, and that's it. This is another lady who came from Sudan, and she has been to many other countries, and she was nearly counting her vision again when she came, possibly a bit better, 660, and I don't remember exactly. And this is after 4 doses of tocilizumab. She contacted me from Sudan a couple of days ago. My eyes are getting worse again. And just out of blue, I said, what are you using? And she said, I'm using a multivitamin with iodine. And I'm waiting to see. I told her to stop it and then come back to see. I mean, just let us know, how do you do? So thyroid eye disease, as was mentioned in the previous lecture beautifully, which is very complex surgeries Dr. Mahmoud, Professor Mahmoud does, is not easy. It's a dreadful surgery, and it's a dreadful disease, and now we are in the era of getting more and more medications. Teprotumumab is coming into the region slowly. We have found tocilizumab very useful in the treatment of the thyroid eye disease. And what we think is that, I mean, especially in this case, one could argue that, well, if you could have waited another couple of months, the vision could have better. It's an inflammation, natural course, blah, blah. Agree. But I think that it was a combination of the surgery and the tocilizumab which improved the condition of the patients. And if you notice as well that, I mean, I'm sure all of you have experienced this one, that many of these patients go months and possibly a year, and they have optic nerve compression. You know, one of these patients was 9 months when he came to us. And then you would think that, okay, if there is a vascular optic neuropathy, khalas, 20 minutes, 10 minutes, and then the patient is gone blind, ma salama. But there must be more than compression of the optic nerve, which is causing the optic neuropathy. And this concept, I don't know, I haven't heard it, but it came to our brain after after a couple of cases of successful treatment with thyroid with the tocilizumab. Not every tocilizumab becomes successful, but with a couple of cases, that is there an element of the chemical compression of the optic nerve, where it goes slowly smoldering, slowly the fire, it's burning, you know, the fire is burning, and it is blinding the patient, but it takes ages, you know, a year before the patient comes completely blind. And I strongly believe in that, and I strongly believe that there are more than interleukin-6 or more than the, you know, the insulin-like growth factor in the treatment, because not everybody responds, and there are many people who go back, and recurrence is quite high, 20%. We are waiting for the recurrence rates of the teprotumumab, but I strongly believe that there is other major mechanisms in the thyroid eye disease where I'm sure they will be discovered. So these are our references, and thank you very much.
We'll just do now the question and answer. If our panels can come forward to the stage, and then we can open the for the audience for any questions. If you like, at least some of us. Thank you. Anybody have any questions? Please, yes. Can you please bring the microphone?
Check, check, check.
So we can hear the question.
Check. Thank you very much. It's actually a hot topic, the thyroid Graves' disease. Actually, Dr. Salim divided the thyroid disease type 1 and type 2. Type 2, that means it's a hot case. When we deal with type 2, what we have to do first? It's not clear, voice. Yeah. You do classify the thyroid disease between type 1, which is calm case, and type 2, which is a hot case, as you said. That means the disease is not controlled yet. What to do first when you have a patient with a thyroid disease, which is not the case is not let's say controlled. You do a steroid first, or you have sometimes to do the radiotherapy if there's a compression of the optic nerve.
What I could understand from the question is that what do you do with an active case?
Yeah, active case. Yes.
The activity ushers by actually short history, chemosis, redness,
exactly,
hotness, and all these kind of. You have to actually give a steroid at least, or do something, whether systemic steroid or a bilivulvar injection, and wait till the case is, let us say, inactive, or it's quiet, operable. And you don't have to wait for long, but actually 2 weeks or 3 weeks, it depends. If there is signs of orbital decompression, optic nerve compression, you want to go early. But it depends on the indication for the decompression. If it's a vision threatening, you don't wait. Okay, you can give systemic steroids for 3 days, whatever, and then you do operation. But if you are doing it for cosmetic purposes, you should just really select the proper time when the patient is inactive. Inactive, that means it's much better, actually, results. And but whether you have the steroids available to you, or you have the Tabiza or whatever. the drugs.
Is,
I usually don't wait more than 1 month on these cases, but surely I would like the patient to be euthyroid, but not actually as our colleague mentioned that I insist on thyroidectomy, whatever, because the course of the thyroid disease doesn't go hand in hand with the orbitopathy. The cause is the same in both conditions. Yani what created disturbance in the thyroid, that one has created disturbance in the orbital disease, but they don't go hand in hand. You can have thyroid orbitopathy whether you have euthyroid, hyperthyroid, or hypothyroidism. But I would like the patient to be euthyroid for 3 months or so. I would like to have him quiet in active form as much as possible, so that I can really assess him better from extraocular muscle view, from the eyelid complication, and so forth.
is there any rule for radiotherapy in this case? Radiotherapy. Radiotherapy. In this case, is there any rule?
Radiation therapy.
Radiation.
I myself, I don't have experience with this. I know there is a place for radiation, but in a lot of countries, they have abandoned this because there is a risk for retina, the cataract, and it's not really a miracle. And it has a lot of side effects and disadvantage. I'm sure that it's good for the active disease. It might suppress it. Okay, some people are doing this, but in my practice, I don't really at least have this logic.
The last question. You said that you can do one surgery. You do the upper lid retraction, you do the decompression and the squint surgery at the same time. Now, how can you evaluate the upper lid retraction? We know that there are 3 types of upper lid retraction: 2 millimeter and below, between 2 and 6 millimeter, and more than 6 millimeter. So you always do the blepharotomy to correct the upper lid retraction?
Fine. The causes for eyelid retraction in thyroid orbitopathy are many. Okay, in early stages, it is just the molar muscle hyperactivity. In later stages, it is the kind of shortening and fibrosis for the levator and so forth. But actually, people were concerned of the effect of the decompression on the eyelid retraction or eyelid flare, how much really it is. And people who think that we should do stage surgery, they think that the decompression will improve the
exactly the upper lid retraction. So
a little bit, or we should just wait and see. But now the consensus is that if it is the eyelid retraction is minimal, you can do the decompression and it will improve. But if the eyelid retraction is a huge one, it's a big one, long standing, no, you should really do it in the same time. As I showed you, one of my cases, which I did the orbital decompression, very good result where I decompressed them, but I was not happy. As well, the patient is not happy.
But you always do the,
there is clear show.
But you always do the blepharotomy. You don't use the spacer, for example, the spacers, upper lid spacers.
Spacer?
Yes.
No, I don't have to do so far. Actually, in these cases, I do blepharotomy, and it gives very good results so far. Of course, in chronic cases where they are, when blepharotomy doesn't work or you think it doesn't work, then you resort to spacers and so forth. Dr. Francis would like to add to this point.
Okay, I mean, what can I add? I mean, you said everything. What to just summarize, when you asked about the active phase, of course, in the active phase, you wait. But there are, I think, three type of patients that you have to watch very carefully. First, when you have apical crowding at the CT. The second, when you have an increase in the superior complex, you have to watch, that means a very big superior rectus and levator muscle in the sagittal CT, then you have to watch this patient carefully. And the third type of patients is when you have a reduction of the palpebral aperture. All these three types of patients are very prone to early optic nerve damage. And so even if you are in the active phase and the steroids are not working, then you have to decompress these patients, in my opinion. The second question that you mentioned about the upper lid retraction correction, decompression won't improve at all upper lid decompression. I mean, it might a little bit, 1 or 2 millimeters, but it won't affect upper lid retraction. So there is always the question if you do it at the same stage or later. There are early reports. The first is by Serge Morax in the 80s. Then there is an interesting paper by the Bob Goldberg group in the 90s or early 2000 about simultaneous upper lid retraction correction and decompression, and that was as effective as stage surgery. What people always ask me, how would you measure? What would you do? Because you always do upper lid retraction correction on the local to check the contour and the height. That's a big question, and my answer is always the same. What would you do when you operate ptosis in a child? It's the same thing. You just rely on what you know. And always when you have to correct upper lid retraction on the local, the patients are under sedation because they're very agitated. That we all know these thyroid patients are a nightmare. So it doesn't change that much to do it under general anesthesia. And you have basic rules. So up to 2-3 millimeters, I would do a Muellerectomy for a posterior approach, and that's very easy. And I just cut the lateral part of I remove all the Mueller's muscle and I cut the lateral part to make it drop a little bit more laterally. And when you do a blepharotomy, what I had when I do it on the general, usually I can have a flat contour, but the contour is quite good if you just preserve a bridge of conjunctiva. So basically that's it. And for radiotherapy, there are reports that is useful in the active phase of the disease. It improves, and also it improves because when you do radiotherapy, you avoid post-decompression enlargement of the muscles. So there are the studies that describe that the muscles might enlarge after decompression. If you do radiotherapy, this doesn't happen. Also, it is more effective if you do it with IV steroids. There are reports. You don't have to do a big dose. Of course, it's contraindicated if patients are younger than 35. And also if they have diabetic retinopathy, but that happens for any kind of radiotherapy. So there is, I know there were several reports by the American Academy saying, oh, it's not effective, or with a double-blind study, but the more recent studies have determined that it is effective.
Okay, thank you.
Thank you. Any further questions? I'm just quite interested to see how many of our panelists do a combined surgery. I mean, we know Dr. Mohammed. Anybody else does combined instead of stage surgery for thyroid eye disease?
Well, I was just sharing with him that we do see a lot of aponeurotic ptosis along with proptosis. And recently we had published our series of ptosis in thyroid eye disease, where we've also reported reattachment of the muscle along with the fat decompression. So combined surgery is a good goal. It's very patient-centric goal. And when you talk about lid retraction, correction of lid retraction on table, how do you judge it? One good clue is if it is levator, which is fibrosed, on table at the end of your decompression, the eye would still not close. So I would relax the levator until I can get good closure of the eye on table, similar to the other eye. That's a good clue. You might have to do some adjustments post-operatively, but still it's a good start. You get the eyelid down right in the first stage, and patient is really impressed with the correction. You do a decompression with no correction of the eyelid retraction. Sometimes the patient does not even perceive what we did. They feel the eye is just the same.
Thank you. I think we have a question here.
Thank you for the nice presentations. I would like to ask you if you have experience or do you recommend to add the mycophenolate with the steroids as the first treatment for thyroid activity?
Can you make your voice louder? Sorry.
Okay.
Or you can come forward and ask.
I would like to ask if you have experience and you can share it with the mycophenolate protocol for the thyroid. Do you have? No?
We hear an echo, so we can't understand.
Oh yeah, the new Yogogo guidelines and the
Mycophenolate.
Yeah, the new Yogoga guidelines include mycopentolate treatment as part of the thyroid eye treatment. Mycopentolate, I think it's 500 milligram, I believe, for on daily. I think it's in the Yogogo new guidelines, right?
Yes.
Yes, it is in the Yugogo. Yes, I don't have a big experience on that.
Anybody has an experience?
No, I don't use it either, but it's supposed to be a very cost-effective and steroid alternative option. So,
Dr. Habib, do you have any experience? Okay. I have a little bit experience with it, just on a few patients in my center. So I don't have a long-term kind of comparison. Until recently, until the guidelines, I have not used it, but with the guidelines, I've started using in some cases where I don't want to give too much steroids because the new guidelines with the mycopentolate can actually reduce the dose. So we don't have that much kind of experience. Anybody has any experience with mycopentolate? Yeah. So hopefully in the next few months, a year, maybe we'll get more experience with that.
Thank you.
Thank you. Any other questions? I think we will wrap this session because we have a live surgery coming up. It's an exciting session coming up, hopefully very soon. Please be tuned. Thank you very much for your attendance and your attention. And thank you for the panels here. We can have a group picture, please. Thank you.
Thank you for the talk.
Check. 1, 2, check.
Yes, When are you going back, today or tomorrow?
No, tomorrow.
I'm on call, so I may not be there. Yeah.
Usually you don't work on Saturday.
No.
So now the weekend is Saturday and Sunday.
Yeah. Yeah.
But you have changed very recently. Ah, so you were not supposed to post Friday and Saturday.
Before Friday and Saturday.
Ah.
They say business.
Probably for the banks.
Markets and so on. Reasonable because the country is on the
Still, yes, I think it's reasonable for the world, but two traditions are.
they get that.
15 years ago.
The shops.
But I mean,
and so
the
on.
shops. For the big shops.
Exactly the same. Wasted. Didn't change my tickets and everything. So I have
The thing is, the American Academy is nice to be there, or you're just attending the course. But I mean, if you are user experience and you have to get your results. But also for me, it's too much to go to Chicago. That is the simple reason to work. It's not good. To go for 3 days. For 3 days.
it's nice.
Do you have a direct?
Then I
Chicago?
but
You know,
still it's a nightmare.
From Rome, we used to have now, it's not direct flight to
Oh,
Chicago.
You have to go to London or what?
Several options. You either go Rome, Paris, Chicago. Gives the flight.
Far away. Even that's a hard time. Hours, yeah, the number of flights decreased a lot. A lot. Like my service, 2 flights. 1 flight, 2 o'clock. It's very, 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 very uncomfortable. Yeah, yeah.
But we used to have, for example, 7 flights a day to Paris, now 3.
Wow. Wow.
Yeah. 7 from Paris.
Yeah.
So we have a direct flight.
You have to upload it as well. Yes. Yeah, but before there was 3 flights a day. Yeah, but now it is 1 or 2.
One from Abu Dhabi and 2.
Yeah, before the Abu Dhabi was 3. Now and when you say 3, it's full always.
No, it was not full.
No.
The plane was not full.
It's always people are still afraid of that. I was sick when I came back. I was sick. I was sick. I had colds. It wasn't COVID.
The problem is, so 38.
Yeah, to accept it as a cold. No, no, I don't do it.
I think it's a good one. Something big that you just.
They don't read the phone, no. They just they see all these that are reject. So
It's probably, I mean, depends. Yes.
it's all over the world. Yeah. Even I was talking to
People from Spain.
I don't know from US as well.
For the French, possible.
Yeah. That's the language.
Yeah, but I mean, they have the recognition. So first is the problem with the French.
Yeah,
So
yeah.
they are like the British.
Oh, you mean to submit in French?
To submit.
Oh yeah,
They
forget
submit
about
their-
it.
no,
Agree,
But
agree.
even if they try to submit in English.
Of course. Yeah, yeah.
Rubbish, which is.
Agree, agree.
I mean,
I
I
never
live in
considered.
Europe, so I have lots of relationship with the French.
Yeah. Yeah, yeah.
But not everybody knows.
Oh yeah. Some of the speakers, they don't- they us, and they please. Your contact details haven't changed. No. Have you?
I give you my details. So, it's, 971.
It's
You know,
Novo,
you know,
Novo.
Di
Di Novo.
You know what it was.
Yeah, where here? Here or here? Here, okay. دكتور محمد ثانية واحدة احطها لك. لك المايك.
He's only one.
Yeah. So thank you. You adjusted, right? Hmm? Can you push the 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4.
So this is balanced.
Yeah, but we have the burst. The burst. That up here. This is burst. Where is the people? Where is the people? 1, 2, 3, 4. Yes, this is. Yeah, this is cortex. No, I need shop. Where's the shop?
Shop?
Yeah.
Yeah.
Okay, so make it 245, 40, 250. You can make this burst. Burst, yes.
Hello.
And this is 45.
I want to listen for them.
Make this burst.
Can you show there? Show the photo there.
And this is 45.
Please, can you show the there? Yeah, tell him to continue show us. Just I want to check. We wanted to test.
Power how much? 17. Yeah.
Tell him to talk with us. No problem. Anyone to talk.
Power how much?
No, we need only testing.
17.
I care. I want to
What
listen
time?
the voice.
What time is it?
Okay. For Yemen, how we
Done? Yeah. Now let's see.
Good morning, Priya.
We do the light.
Everything is good.
Slide 17.
هنشوف مع هو في هنا فرامل؟
في.
هنشوف مع 1 2 3 4.
دكتور بريا.
1 2 3 4. Yes. 1 2 3 4. 1 2 3 4. عايزين حضرتك تشوف عن استاذ مجدي. سلم ايديك. 1 2 3 4. عايزين حضرتك تشوف عن استاذ مجدي.
Maybe you didn't receive this one. Yeah.
Midway. You have midway, right?
It is a symbol just to show second.
Midway.
Yeah, show them. Someone maybe under your supervision. Okay. I was trying to call you in the morning, so now we'll shift you to the afternoon. Yeah.
وجع؟ آسف. حط لك مسكن جوه العين عشان ما تحسش بوجع جامد. وجع؟
Why the voice here?
حط لك مسكن جوه العين عشان ما تحسش بوجع جامد. شوف عنه حضرتك سمعت.
Yeah, I want you to hear, please. Yeah, we can check. Okay. No, let me know. Okay. Can you give Dr. Ahmed, can I shoot? No, the first one it will be Dr. Baral في أجهزة. Baral أول ناس. Next one it will be. إيه هذا مو أنت. اللي بعده أنت دكتور. دكتور إسلام. هي لا هاي دكتور مودريتور فوق Baral.
شوف عنه حضرتك في 3 نقط. ايوه كده تمام. شوف عنه في 3 نقط. ايوه كده.
خليني عليها 3 نقط.
3 نقط. look at 36 IUP. Look at 36 IUP. كده. ضغطة بسيطة هتحس بيها ثواني وبعدين ضغطة. ضغطة بسيطة هتحس بيها ثواني وبعدين ضغطة.
لا مبعوث. طيب ممكن طيب
دي الضغطة اهي. This shock. Shock no? This shock.
الو الو دكتور هشام.
Don't do too much.
هي هلا فيرستن جلوكوز. بعد ما يخلص لكن هلا اذا هيد مثلا
One, two, three, four. This is I don't know after that. One, two, three, four. What's after 4? I don't know after that. No, 6. Okay. That's after 4. No.
Dr. Hisham, we are hearing you.
What? Is it speaking for somewhere? You pick it from somewhere. Right hand, please. VSS on the corner. This is what? It's what? Our? VSS. I hope this is not the bad one. No? Huh? Analyze. Okay. We just finished our phaco, nearly finished our phaco. Just do a manual IA, and then we rotate the microscope to make the row on our superior approach. It's much more comfortable, especially when you do the right eye. To make the row on our superior approach. Left eye, you can just adjust your hand because you use your right hand, but for the left eye, for the right eye, if you're right-handed, it's better to shift the microscope. Because you use your right hand, but for the left eye, for the right eye. Total how much? في أي وجع في الملكي؟ لا. Nightingale. In all cases, I'm doing polishing, posterior capsular polish. This will reduce this PCO later on. And if you have some cortical matter hidden somewhere, it will just come out. This is the Clarion IL. This is the Clarion. So we fill the opening from here to the nozzle, and then remove this one and tick, and there's an air gas cylinder that will push the lens forward. This is 2.2. Still, we can use good assisted. We just can put the lens with this small. Do radiation aspiration for the viscous. High pressure. Small VSS, please. Small VSS. Just make sure that the wounds are sealed. Refraction, right? Sponge. Yeah, give me traction. شوف تحت كده استاذ مجدي.
Cannot hear properly, so say loud loudly.
Can you get my voice up?
Voice up.
Can we get the tone up rather than? This is a traction 670 vehicle. Can we increase my volume better? Just pull through this with this speaker. We can use this one to pull the eye down. The subconch. Okay. This is allocating adrenaline, just insert subconjunctival for the anesthesia. And if you separate the conjunctiva from the underlying sclera, we just spread it by the back of the wet sponge. Just spread it by the back of the wet sponge. Yes, yes. Can I change the position? Okay, now we'll make, until they prepare this change of position, we'll make the conjunctival incision.
Okay.
يا ايوه وجع استاذ مجدي؟ خلصنا الماء البيضاء.
This same going, no problem.
يا ايوه وجع استاذ مجدي؟ We have to get to the scleral, sclera, and make large dissection, subtenon.
Is it not coordinated?
Give me a wash, please. Can you wash, please? Just make some cautery. Cautery, please. Cautery, please. Make some cautery. 35, is it? 35, make it 35, please. Sponge, please. Sponge, please. Put it 35. Very good. Wash, please. PSS, please. 35, PSS. Now give me a sponge. This mitomycin. Mitomycin sponge, please. Now more. Two more, please. Two more.
Yeah, already here is asking.
So now we'll put the mitomycin subtenon.
Dog is not.
Two minutes, please. 0.5, is it? It's 0.5. We'll make it 2 minutes. until this time, I will just change my position now. Can you move the brake? Can you move the brake, please?
خلاص هو بدأ مستمر يعني هو بدأ مستمر يعني
நான் மைக்கு கொஞ்சம் கீழேயாவது வர மாட்டேன் சொல்லுவாங்க சவுண்ட் ரொம்ப அவர் கத்துறது கேட்குது
So we'll make for 2 minutes. So what what we're doing, we put in mitomycin related. I'm using 0.5 for 2 minutes. This makes slightly this is higher concentration, but in our population it gives actually good long-standing bleb. So you have 45 seconds to go. So you can see that we're using the regular speculum for the traction of the eye. It's 8 minutes. Can you give me a sponge, please? We don't want any of the mitomycin to reach the edge of the conjunctiva because we don't want any leak. 14 seconds. Since we started the procedure, actually the MIGS, the rate of trabeculectomy is becoming very low. We don't do that much. So after removing now the sponge, we have to count them. Then we'll wash with BSS, 4x4. We wash copiously. Cotton again, please. And the marker. This is the part that I'm going to insert. Marker. So this is marked. This is 3 millimeter marker. We'll make it from the blue line here. No, we use this. Yeah. Yeah. This is a single pass rather than the double pass suggested by the manufacturer. 0.12. 0.12. Yes. Just modify it. So we'll just hold and we'll pass the conjunctiva. It's not holding. Why is not holding? So we'll just pass it while seeing the metal luster until we reach the blue line and then change the position and go to the anterior chamber. Here we go. Going back, we have to make like a fringe here for the fin of the procedure.
It sounds not clear.
I don't know.
They are complaining.
Yeah.
You need to raise your sound.
Cannot make it like that from there?
Can you raise the sound because the sound is not clear with the audience?
So this is the procedure flow. Not Dr. Safwan sound. Just put it inside. We just thread it inside the.
Now my sound is clear. My sound is clear, but what can I do with this sound?
Yeah, very low. I don't know why.
Because you put the mic is deep.
Yeah.
Take it, put it, yeah.
Now better?
Yeah, just raise the tone of your sound.
Hardly I can.
I feel that you are fighting with someone.
Yeah, by Dr. Safwan. Okay, so it's not leaky, so we have to give me BSS. We just increase the IOP of the patient. And then we'll check if it's leaky or not. The sponge. Touch, can I change this one? Throw it away. It's not leaking, so we have to inject. Yes, give me the cannula with the cannula. We'll flush the cannula because it's not leaking. We'll flush the cannula. So we'll just put it inside the tube. We'll put it inside the cannula. And then flush it. And then we'll check again. Now it's leaking. Now it's leaking some fluid. Give me a sponge, please. Now you can see it's leaking now. It's getting some fluid now. Yes. Some magnification. Now you can see it's cutting some blood, some echoes. Okay, now 10O, please. 10O. Now we'll suture the tenon separately. And look on the side separately. Where is the needle? There's no needle here. Where are glasses? So we have to, of course, to put this stent under the tenon. Okay, and this is the tenon. This is the tenon. We just suture it. Scissor, please. I think the other half of the needle is here. So it's just a suture. Give me tying, it's not functioning. So, في أي وجع أستاذ مهندس؟ لا ما شاء الله عليك. ربنا يخليك. Give me super blade. Super blade, please. Or this knife. Give me the knife, please. Give me needle. Give me needle. Needle. Needle, please. Give me needle. Yeah. Now we'll suture take the other suture from the other hand. We need to suture the tenon and the contractile separately. So we need to grab the tenon. Yeah. Now we'll suture take the other suture from the other hand. We need to just a regular suturing tenon and like any trap. and the conjunctival septum. So we need to grab the tenon.
No, he tried to
So-
press the tenon before.
Bury the suture. And then we suture the conjunctiva again. Suturing, just a regular suturing procedure, like any trap. It's actually it's in place. So at the end, we shouldn't see the tube. You see here, if you see the tube, you cannot see the tube. If you see the tube, means you are superficial or under the conjunctiva, not under the tenon. So here we cannot see the tube. It's covered by tenon and two layers. No, I don't have a speaker. Earphone.
Dr. Muhammad?
It's actually it's in place. It's in place. So at the end, we shouldn't see the tube. You see here, if you see the tube, you cannot see the tube. If you see the tube, means you are superficial or under the conjunctiva, not under the tenon. So here we cannot see the tube. It's covered by tenon and two layers. No, I don't have a speaker. Earphone. Scissor, please. We'll take a matrix sutures just in case. Just try to bury the suture. Scissor, please. We can remove the sutures later on if it's making some astigmatism, yes. Yeah. Okay. Yeah. Yeah. All right, straight down. Straight down. Big ears. I have big ears. Yes. Yeah. Okay. We can remove the sutures later on. Yeah. If making some astigmatism, yes. Okay. Any question now? Okay. Not here. Yeah. Give me time, please. Time for such. Yeah. All right, straight down. Big ears. I have big ears. Yeah. Okay.
Now, any matrix suture as the normal with any operation of trabeculectomy should be close the conjunctiva
okay.
tightly.
Any question now? Excuse me? Not here. Time. Give me time, please. Time for such. That's very good suture. We don't want the patient to suffer later on. Give me scissor, please.
Dr. Muhammad?
Scissor. شوف حياتك على النور على طول. أستاذ مجدي شوف عليه. Now you can see the tube here. It's in position away from the cornea and away from the iris. Can you put another BSS, please? There it is. Okay. That's very good suture. We don't want the patient to suffer later on. Give me scissor, please. Scissor. Now you can see the tube here. Okay, we're done now. Away from the cornea, away from the iris. Okay. Can you
Okay, please. الحمد لله على السلامة.
antibiotics, and that's it. You don't have to touch the eye. تيجي بري فور few hours هتبقى مزغلله شويه وبعد كده تطلع سلامه ان شاء الله. لا سلامه تعبانه شويه على العيان. لا خالص. حرام ولا ولا خايف؟ حرام ولا خايف على العيان؟ الله يسلمك.
ظبط لك انا كل حاجه.
محمد تسمعني؟ دكتور محمد السلام عليكم. أحد يسمعني؟ No, there is no sound. They are not hearing. They are not hearing. Dr. Muhammad. محمد عندك بطاريات؟ تعطيك هاتي غير هاتي فين؟ Now you put any battery. Marker, drop. Camera.
Hello. Earphone എടുത്തുങ്ങോ. Hello.
Yes, I can hear you, but so this is the marker growth marking we are doing it, and this is the first step that the growth marking stage and 0 and 180 and showing that this is the site where we will do the filtration for the lens. Yeah. Okay, we can, I don't know how we can select the mobile. No. Mark, I don't know.
Hello, hello, hello.
Yeah, now I
Now
can
I
hear
hear
you,
you, but they are hearing you.
Yeah. But we do not hear them. Okay.
No, doctor,
So
keep it inside.
what's here?
No, no, like that, like that. That's it.
Okay, Dr.
Okay,
Muhammad.
Muhammad.
Now you
Now
can
you
hear
can
me.
hear me.
I can
I
hear
can
someone
hear
talking.
someone
Tamam.
talking.
Assalamu alaikum, Dr. Safan, do you hear us?
عليكم السلام.
يعطيك العافية دكتور صفان وموفقين إن شاء الله.
الله يعافيك.
We are hearing you properly, so if you have any
Okay,
summary
good.
or introduction to
Good.
us,
So what I
listening.
did, what I started is the only gross marking, and we are ready. Yeah, okay. And we will start. The case is a fake after a cataract extraction that
Can you look to the screen
having
Dr. Safan,
complication.
to the camera when you are talking?
Yeah, I will just I'm doing an introduction to the case. So a fake with and with a rupture of the posterior capsule.
We call the moderator, please.
And there is a vitreous incarcerated in the wound. The primary wound was at 12 o'clock.
Dr. Safan, can you look to the camera when you are speaking? So we are.
Okay, done. I will speak, but I'm just introducing the case. Anyway, when you are ready or everyone ready, I can start.
Case, please.
Okay. I can start because we need to save the time. We don't have time. Anyone hearing me?
We can hear you, doctor, if you continue.
Okay. So I'm starting. Now, as I said, that this is a fake after a complicated cataract surgery that end up with vitreous incarceration in the primary wound with iris incarcerated in the primary wound, and we don't know whether there is a lens matter encaptured in the ciliary body. So in order to put four flange or use a lens as a secondary implanted lens, we need to clear up all the ciliary body and the zonules. So what I will do is that I will go through and do a vitrectomy first, just to see and look at the ciliary body and whether it's clear or not, because that will affect the centration of the lens. From this point of view, I will use the 3 trocar, and I will leave space for secondary implanting lens using the 4 flange technique. The gross marking is very clear.
So Dr. Safwan, just to clarify, so this is a procedure that you're gonna do a secondary IOL in the right eye of this patient. Do we agree?
Yes.
After a complicated cataract, it's gonna be 4 flange or what type of secondary IOL?
This is a 4 flange.
So
this is a 4 flange. So you will see a 4 flange here. See, I'm going with the trocar a little bit back in a way that I can give a space to.
So this is 2 millimeter.
No, yeah. Still, I didn't do the marking. I just did the gross marking.
If you allow me, I have a question for Dr. Raya and Dr. Ashraf. How much representing the 4 flange of your secondary IOL? Let's say if you have an order of secondary IOL, which one is the top, the second and the third?
For me, the first is glued IOL fixation, the second is Yamane, and third is maybe the flange. I do a glued.
Here, I'm just preparing for the vitrectomy. First,
for me, the secondary IOL is the Yamani, then the Canaprava 2-point fixation, or the third is the 4 flange.
The first is what?
Yamani.
Yamani.
Yes.
So we are not always in a different, we are always a different opinion regarding the it's not so in my hand
no, keep it.
I would prefer always, if there is a good anterior capsule, to put it in the sulcus simply with a 3-piece IOL. This has to be clear for everybody. Don't go for aggressive things unless you really get pushed to do that. If there is no capsular, neither posterior, neither anterior, then at that time I would shift to secondary IOL. Secondary IOL, if it was a baby, I will go for scleral fixation. Most of the time, either Yamani or sutured. I was doing glued a lot in the past, and honestly, I stopped it. I don't know why. Maybe just to try something different. But honestly, I have none of slipped. This is our last discussion of glued IOL. What's amazing, I thought it's the flange which hold the haptics in the tunnel, but honestly, it's not. I think it's the inflammation, it's the fibrosis, it's all the contour that you hold the lens in it, and whenever the lens is inside the eye, any trauma inside the eye, I think it's very stabilized even after the trauma.
In cases, okay.
Now, if someone allows me to interact here on the glued IOL.
Let us not be biased about any technique, because when you do a glued, you are seeing the sclerotomy site where you are making it. You know it exactly, it is 180 degrees. With Yamane, things are good, but the internal entry, you do not know where you're entering. So if you are lucky enough, and if you fall into the line or maybe a little bit here and there, it's fine. But if your internal entry is not 180 degree and there is much more of a deviation, then the problem comes in for decentrations or for tilt of the IOL. So that is one basic thing. But saying that, I would say Yamane is fast. Never to, we cannot deny the fact it's fast. You do not have to do any conjunctival peritomy. You don't need anything. You just go ahead and you make a flange. Flanges are really very good. The only issue is the point of entry inside. Otherwise, it's a wonderful technique.
And the availability of the
CT Lucia lens, yes,
So
that's there.
yes, so you mentioned a point. So we should differentiate between PCR posterior tear. So we can we convert it into a posterior rexus, then put a single piece in the bag, and then retro capture of the optic. Or if you cannot find the posterior capsule, so 3 pieces in the sulcus, then posterior capture of the anterior rexus. But if you don't find any capsule, so as Dr. Safwan going to present, so there is no capsule, so he has an option, either the 4 flange that he is going to do, as the Yamani, the glued IOL intrascleral fixation, or retropupillary artisan, which is still, it's a very good option for a lot of people that it's good in their hands.
Thank you. Dr. Safwan, do you have something to add here, or any step that you want to comment on?
The issues is on glued IOL. The space, yesterday I didn't discuss it with the Priya, but the space that we have from the limbo will be around 0.7 millimeter or less than 1 millimeter. So the patient will end up with the myopia because we need a good length of the haptics to introduce it into the tunnel. Well, in our procedures, whether Yamani or modified Yamani or a 4 flange, we don't have this problem. Okay, so I faced that the pupil is not free. That's why I went to the four trocar. That's what I need, because sometimes I need chandelier light, so I need to see all the issues inside. Now I will try to.
Dr. Safwan, can we ask why you put a 4 sclerotomies in this case?
Trocars.
4 trocars, yes. 4 trocars, why? If there is any posterior surgery for this case?
So they might ask that it's why 4 trocar. This is my technique.
Yes, the question why 4
trocar, just in case of that I'm in need for chandelier light.
So you'll use chandelier.
Now I'm freeing the pupil side. I'm not using the standard chandelier.
Yeah, he's doing vitrectomy from the posterior.
No, we will go to paracentesis. Give me.
So, Dr. Safwan, we're still wondering the 4 trocars you put on. We see you do a posterior vitrectomy through the trocars, but why the other 2? Is it for the thread of the proline suture, or?
I said that this is my technique for vitrectomy because I might be in need for a chandelier light. I don't know what's going on inside because I couldn't see the inside. So that's why I'm in.
Okay, so the
fourth one is for the chandelier light. I'll show you.
Yeah. Excuse us, sometimes we repeat what you said because we don't hear you properly.
Yeah, give me.
So don't get wonder if we repeat what you said or repeat the question one or twice.
Sorry, I don't know. I'm not hearing you well.
I mean, sometimes we ask you more than once because we don't hear your answer. The voice here is not so
okay, sorry,
clear.
I'm very sorry because even for me, I'm not hearing you well. I need micro scissor.
Okay, so we are seeing you doing the vitrectomy.
No, I just need to release the adhesion here. My aim is to prepare my situation for the lens.
Do you hear the answer? Do you hear the voice? I'm asking the audience.
You are not hearing me?
Yeah, I think the audience hearing you, but we in the podium, because of the echo and the speaker around us, we don't hear properly. But at least your message always delivered correctly to the audience.
Use the pressure to 20. I need chopper now. The adhesion is at 12.
So you are using a forceps. It's a retina forceps, actually.
Yeah. And this incarceration of the iris and the vitreous in the primary wound. And we can see that now the pupils start to be, now everything will be, it's released. See, we have a good space. I need T and Y.
We will have some question for you, Dr. Ashraf. If you're gonna do the four-flange, what's your preferred selection way?
The IOL should have 4 haptics, like the Mickey Mouse, either the physiol or the acris. This is good.
So this is very good point.
Yeah.
Why?
Why? Because the four-flange, we are going to pass the proline 5 or 6O from the first haptic to the second. So it's 2 points to bypass like a loop, and the other side it will be another loop.
So you mean it's forgivable regarding the astigmatism that could happen post-op, comparing to the Mickey Mouse ring haptics regular one? Do you agree on that?
Yes.
So one of the advantage is avoiding the astigmatism by using the 4 haptics.
Yes.
And the type you are using, aqueous or physiol, or what type of?
If I'm going to use either the physiol or one from Crystal Lens, the artist, so it has also 4 haptics.
So what about the Russian product you are speaking to it? Yeah. There is a Russian product is gonna come?
Yes, there is a very nice product from Russia. It's not in the market now because of the politics, but they have 2 designs.
Why?
It is a single piece IOL.
And then?
They have, the first design is holes at the knobs of the 2 haptics.
Good method.
The advantage.
Yes, and the other design has knobs, holes at the area of the haptic and the optic junction.
So what do you mean? What's the advantage? To use it for skin fixation?
Yeah, the advantage is you are going to do a 2-point fixation instead of 4-point fixation.
So you mean it's an IOL with haptics, but
IOL
at the same
with-
time with extra holes in a case you want to use it for something.
Yes.
This is very, very smart
Pressure
designing from the
30.
So there is no reason to extrude the lens whenever you have
30.
this or something. Dr. Safani was trying to say
30.
something.
Dr. Safwan, Ashraf Armeya. So now you
Yes,
are
Ashraf.
trying to remove the iris incarcerated in the wound from the previous.
Yeah, I
complicated
removed
case.
it all, but I have here lens matter that I need to remove it because otherwise the lens will be tilt.
Yes. So you are cleaning the area for the second
Yeah,
implantation.
I need to clean.
Either-
The space is very important for me for the stability and prevent of the tilt. Sometimes we are blaming the tilt of the lens by the position but it's not true. Sometimes it's sometimes because of the lens matter that present. So I'm just.
So it's just removing
Fine.
all the cortex and the remnant of the capsule to make it ready for the second implantation
Yes,
and to decrease
exactly,
the post-operative
exactly.
inflammation. Yes.
That's the issue. You need to make everything's ready.
Yeah, I think that is very important because when you're
No,
going in
don't
for a
touch my someone touch my chair. Sorry.
capsular tag or any fibrotic material out there can cause tilt of the intraocular lens. So
Okay,
it
so
is very important to remove that.
Definitely, this is not a usual case, and just show that the drops on the polyp. Sorry,
And for
with
sure
my
you
talk,
are-
I need to continue doing the surgery.
And for sure you are changing the parameters for the occlutome because you are very close to the posterior iris, not to make any trauma to the iris.
For sure, I'm using the Y. You can see. So I'm holding the iris away from my sight in a way that it will be there.
And you are doing a very nice technique with your left hand. You are pushing the iris away from the field to make sure
Yeah.
the view very clean for you.
Sure. I need the iris and the pupil fully free from the underlying lens matter or any fibrotic tissue.
What about Dr. Safwan, the iris hooks? Do you think it's too much to be 4 holes extra in this case, or
first,
you didn't need it?
Here, if you need high iris hook, you need to think about the tunnel that you will do it. Here, it's not a usual cataract. You need a tunnel on both sides. If you are doing a lot of holes and breaks, this will affect the pressure, intraocular pressure. So I don't prefer it.
Okay.
I think this is not an easy case to do in a live surgery. You have taken up a very good challenging case for secondary IOL fixation out here. I think post-operatively, you might even need to reconstruct the superior part of the iris tissue. You might need a pupilloplasty also because there is incarceration of the iris tissue out there.
Now you can see that this area start to be clear and free. We will go to the other side.
We will keep discussing the case, and if you have any comment, Dr. Safwan, please, you can add it during our discussion. So, Dr. Ashraf, you were talking about your preferred 4 flange.
Yes.
You said 4. What type of ruling? 6 or 5?
I use 5 now because because I feel that it takes a long time for degradation.
I changed the trocar because it was 25.
The 6 is easy to manipulate because it's thinner, but the 5, in my hand, it gives a long-term stability and less degradation.
What about you, Dr. Priya?
Now the same maneuver will be done for the other eye.
Yeah.
That's why I have paracentesis from both sides.
It's for the young ophthalmologist to remember: cornea 10, conjunctiva 8, muscle, rectus muscle is 5 or 6, and the scleral buckle is 5. So this is how to make it easy. Other. Can you continue your preferred technique, Dr. Ashraf?
Yes.
So.
In my usually as I said, I go for Yemeni. It makes it's easy for me to finish easily, but sometimes the Yemeni does not go well in all cases.
Fine.
So I feel that Canaprava 2-point or even 4-point fixation, but it depends on the type of IOL you are going to use. So it's not an easy to find a PMMA lens with holes in the haptics. And sometimes there is some designs of PMMA 6mm optic has 2 holes in each haptics. So you can do a 4-point fixation Canaprava with the Prolene, but it is not easily to find these lenses.
Do you put the thread through the whole of the haptics?
Yes.
Inside the eye or outside the eye?
Outside the eye.
Outside the eye.
Why? Because I want to be sure that the flange is perfectly, has no, does not go through the hole. This is very important before you go inside the eye. Secondly, it's not wise to do any cauterization inside the eye. This is second. And if you can bring it out and go to the cautery and do inside, but you are not going to be sure that it is well fitted in the hole. And also not to flip the IOL.
So if you have a lens inside the eye to remove it, and you're gonna open it 5.5 or 6mm, are you still gonna doing the same?
Now, if just interrupting your conversation, I finished the cleaning of the ciliary, and I will go in just to see if there is any lens matter.
Yeah, we see the iris and the eye become more clear now, Dr. Safwan.
Yeah.
Coming up to this point, I would just like to say that the step that Dr. Safwan is doing right now, it's very challenging because you need to keep the iris tissue off the vitrectomy probe, because these eyes this is an aphakic eye. The iris has no support. It's so flabby, and when you're working at a higher setting, there is every possibility to incarcerate the iris tissue into the bore of the vitrectomy probe. So this is actually a very tricky situation. I am constantly observing how he's doing it. He's using a Y hook and he's trying to stretch it a bit, and then it's a very smart move because actually it has to be done that way. because it prevents.
Great, thanks, Priya.
I'm
I'm thanking you for this. But but sometimes we are facing these challenges. So you can see the vitreous, how it's hanging all over. So as Abdullah yesterday, he was talking in the session of secondary IOL. If we will leave this vitreous, we will end up with the vitreous above this secondary IOL lens. Sorry, implantation. So that's why, see, I'm searching for any lens matter in.
So
just to
another
clean it.
point that I would like to add is that whenever a surgeon is operating at this stage, you need to enter the eye and then start the function of the vitrectomy probe. Accidentally, if your vitrectomy probe is on and you enter, you will enter inside, chopping the entire iris tissue inside the eye. So that's one another important surgical point when you are doing this stage. When you enter and when you come out. When you want to come out, you keep the probe. The most important point is the surgeon should always be seeing the port of the vitrectomy. You should know what you are cutting. You cannot just invert it and keep on doing whatever you want to do.
Yeah.
It has to
just
be
make
there.
sure
You
that the
have to
fluid is
see,
clean.
and then you have to
Just
cut
look
it.
at the
So
sides,
that's very
please, if you don't
important.
mind.
And controlling the vacuum and the cut
Absolutely.
speed. Always better to have the high speed, the low vacuum.
The vacuum
to be
and
more
the cutting
secure.
rate. Absolutely.
Some people curve the vitrectomy. Some
put
people
slowly
curve the vitrectomy to make it easier
the metal on.
reaching the anterior part of the eye, which is I tried many times. It's work, but it's get less efficient than what you used to. I think with the friction of the needle inside the probe, make it less efficient, but it's still working. So if I decide one times to curve to remove the
third light
capsule, whatever, I do it at the end of the surgery after
please, quick,
no need for vitrectomy anymore.
Third light.
Dr. Safwan, are you going?
Yes.
Are you going to do a complete vitrectomy with shaving?
No. It's only a core vitrectomy, but just I need to see the periphery because we might have breaks in the site of the incarceration. Now
So you are just going to do a core vitrectomy and leaving the periphery of the vitreous attached.
Yeah. Now the third light is in.
So you do not core vitrectomy only, Dr. Safwan, isn't it? Or you do complete vitrectomy?
Core vitrectomy. Now I'm searching for the retina and the site of the incarceration, whether it's here.
Yes, I'm going to ask Dr. Khalid, if we did a core vitrectomy reaching up to the optic disc like this, the peripheral of the vitreous, you are not afraid that it can cause any PVR in the future?
It's a very good question, actually. You know, there is many schools regarding vitrectomy. Either core vitrectomy, it's enough, and you leave the periphery because you don't want to get closer to it. Sometimes the vitrectomy itself can create holes, and unless become very careful regarding the cut rate.
Sorry that Khalid, you are talking, but here I'm searching for the 12 o'clock retina. If there is any break or any defect, there is nothing. So we can now start our surgery.
So
means
we are
that
seeing
our
fourth flange. As you do, Dr. Safwan, the indentation is very important to clarify the periphery of the retina.
You can see that this, and that's why I'm using this chandelier light. Now I'm ready. I have my marker. And as we said, 2 millimeter. So from here, you can remove this. 2 millimeter and 2 millimeter, and then 2 millimeter.
Dr. Safwan, do you use a tri-MC
again 2 millimeter. Just let me, Dr. Ashraf, and then wash. So here we have 3 dots. Each dot is 2 millimeter and parallel from the limbus. Ready for 2 tunnel. Again, I need the plug.
Yes, yes.
Sometimes the valves of this trocar is not working, so we will be in need for a plug. Again, 2 millimeter.
We are seeing you stain it very well.
Yeah.
Sometimes
it's very
sometimes you
important.
cannot- advice for the audience. Sometimes if you cannot stain, you dry first, then you stain.
Yeah. See, I'm looking for the site exactly that it should be 2 millimeter. So again, this marker is very important. So I will remark it again. Now, as you can see that the main incision was here, so I cannot go there. It's a very thin area. So what I will do is that I select this area, which is upper temporal, to go through in a way that I can implant the lens. Give me. Now the pupil is free, ciliary body is free.
Pupil is very round now.
And
not as before.
yeah, pupil is very round, and that's one of the important issues that we need to create it before doing this fourth lunge.
So this
As
is 2.2.
we said that we are using the 4 eyelets lens. I don't know whether you are seeing. I'm implanting the lens. Putting it in the cartilage. I'm seeing the 4 haptics. Now the 4 haptics is very clear, right? This 4 haptics.
It's a 4 haptic lens.
Yeah, this is from Physio. That's what I like. So I'm supporting the lens from in because today they asked me whether the lens can be folded. For sure. Sure, the lens can be folded. So I'm supporting the lens. To be
Then you
above
try to
the
put
iris.
it above the iris. Maybe this is why you don't put the iris hooks, Dr. Safwan.
Iris what, sorry?
Maybe this is why you don't use the iris hooks, because you're gonna put the IOL above the iris.
Ah, for sure, sure. That's what I'm telling you. Because sometimes the iris hooks can distort the architecture of the pupil. Sure, there is an inflammatory membrane now on the pupil side. So I don't need to enlarge it, because if it's enlarged, I cannot finish the surgery. Method. Now I will correct the position, reduce the pressure to 20.
What would you do differently?
This is not my position, so I need to put it in. So the loop that will be here in front of the 0 and 180. So you can see both. No, more methyl and close the fluid. No, لا تتحرك. لا تتحرك.
You did injecting visco inside before
Yes,
the
methyl
lens.
cellulose. So I can clean it then after that.
It has a very long haptics, which is give a good security in the anterior chamber, actually. Why Physiol, Dr. Safwan?
You can use acryos. But I need four haptics. Give me.
So you prefer visual above aqueous. Do you agree?
You cut it. Okay. Now, there is another issue which is important that we need to discuss. It. Where is this? I want to. The cutting of the suture should be by a blade, not by a scissor, because to maintain the cylinder, the cylinder shape of the tip in a way that it will go through. See, now I will focus on.
Well, I think this is depend on the type of the scissor, maybe. If it's sharp,
No.
it may be the same.
See, now it's cylinder tip. That will go easily through the needle. Otherwise, it will stuck and the surgeon will be inside, try to introduce this stitch inside the eye, and it will be difficult. See. So I prepare the suture. No. I like the trocar because it gives me more stability. Move. Now, again to our marker. That's one, that's second, and this is the third. I'm in the tunnel parallel to the limbus. I reached to the point. Now I'm in here. I will prepare the first eyelets. Now I'm in the first eyelet. It should be free. Now I'm free in the first eyelet. Here the suture.
So, Dr. Safwan, you are holding the needle with the right hand. Someone pushing the thread through?
No, no.
You are the one.
It's my hand. This is my hand, and this. Now, we are in. I need to go to out. We might slip the suture. That can happen. It's not a big issue. See, it was enough. Even if slipped, we have still and enough space to it. Now, I will cauterize this end just to prevent slipping. That's enough. Sometimes because it is 6-0, so I'm putting more. Now, return back to the other end. Give me.
Dr. Safwan, this is 30 gauge needle?
This is a 30 gauge needle. And the suture is 6-0. Again, I will return back to our points. See what's the importance of these points? Here, here, and here. Again, it should be parallel. Now I'm parallel. I reach to the end and in. Give me. I will prepare the second. This is the second eyelet. In. Can you open the fluid a little bit? And close it now. Now, the position of the forceps, the distance from the tip is an important issue, and it will be considered by the surgeon according to his experience. Now, why I'm pushing more? Because just to give my chance of any slipping, that it will take over. So I will have enough amount of suture inside the needle shaft until I have the resistance. So now I'm not. The loop is start to form very slowly, carefully, and then out. Now I have two sides. Now you can see the loop. I will show you again. Here it is. This is the loop. It should be clear. Now clear and on the junction between the two eyelids. I think that it's clear for you, right?
It's very clear, very well done, Dr. Safwan.
Okay. Now we will go to the other side. Give me. Again, holding and seeing the sides. That's our knots, 2 millimeter. The first one, the middle one, and the beginning one here. Now I'm parallel to the bubble should be toward my side. I reach to open the fluid, please. That's all. Close. Now I will prepare the first eyelets here.
There is two types of 30 gauge needle, one with a thin lumen, one with a thick lumen. What type you are using, Dr. Brea?
Hypodermic needle, the one which has a big lumen inside.
I need to remove this bubble.
Dr. Ashansin, is it available easily in Dubai, in Egypt also? Not always.
Not always. You have to be.
If you don't have it, what
Open the
type
fluid.
of gauge you are using?
27.
27.
Give me method.
Dr. Safwan, I have a question for you. If you do not have an
Yes.
iris tissue to support the lens, what would you do differently?
Well, I will go to modified Yamani. The modified Yamani, I can support the leading haptics. Now I will go through to do the second suture. I prepared the suture. If you remember that the Brian Kim, sorry, he create a modified Yamani, and this modified Yamani we can use it in lack of the iris. So you can put the lens and then you can use it. You can any artificial iris or any issues that you need to cover instead of the iris. Now I'm planting the first.
The leading haptic first outside the eye. That's it. The Brian Kim's method.
I didn't hear you. Sorry.
What I understood was you said you would be doing a Brian Kim's method.
The modified Brian Kim, because the leading haptic will be supported. It will be externalized outside.
Yes. So you would pull the leading haptic outside first, and then you would go ahead with the procedure.
Exactly. Exactly.
I think one of the advantage of having the pars plana vitrectomy infusion is pushing everything up, so the chance of dropping the IOL is
Keep it on.
less.
I thought that it's
injecting
on.
the visco at the beginning
This also could be helpful to stabilize the eye, I think.
شوية سامحني الله يخليك. Now, this is the last one. And the tunnel again, parallel. Okay, sorry. We gave him a lot of local anesthesia, but still he's feeling. Now, for sure that, as the Dr. Priya said, that this is not a classical case for, but we might face actually most of the cases that give me method.
Do you change the 30 gauge needle between two sides, or it's still sharp, not blunt?
No, it's the same.
How much?
It's still sharp and it's fine. I don't think so that the needle was the reason, if you think about the needle. Close the fluid, please. Open the fluid. Give me the scissors.
Dr. Safwan, what do you think about Carnivale lens? It can make the things more easier for us if it's available everywhere.
Now he published a paper saying that it's not the stability inside the eye. It's not like the four eyelids. That's recently. He has a course in ISCARS saying that when he introduced that lens, and he made a lot of tests about it. Sorry. Sometimes when you are working, you cannot talk. So I'm sorry for that. Especially when you introduce this.
What is in your opinion, Dr. Ashraf? Which is more stable?
We didn't harvest yet Carnivale in Egypt, but I think once we have it, I think it will be maybe I'm going to. It has a learning curve, but I think
Well, it should be shorter. Maybe I think it's more easier than what you are doing now.
Yes, I think it will be changeable if we have it. I think it will be first or second choice.
Are you afraid of cutting the haptics through the pulling?
Yes, it has a technique, so it has a learning curve. The drawbacks that during handling the haptic, it can be cut. So Carnivale say that when you handle the lens, take it from the stump, not the two haptics. It's better than this to make it easier for you.
You mean from the edge of the...
From the stump, yeah, the lower part, not to the two haptics, the stump of the two haptics.
Yeah, I think it's always like this one, even with the thread. If you want to hold something,
close the fluid.
Always hold it from the tip of the thread, so to withdraw it outside the eye, rather than keeping ahead of the thread that will bother pulling the forceps outside.
You have it in Saudi Arabia or not?
We haven't yet.
Yeah.
That lens, but hopefully it will come.
Yes, because everyone used the lens. Especially the vitreoretinal, they like it so much. Even if you have a retinal surgery after, it gives a stability for the lens.
Well, to be honest, I mean, I would prefer this one till now, unless I try it and get convinced. But the issue is for the retina. Whenever you have a complicated cataract without anterior capsule, and always we like to have something pushing the silicone back. especially if there is a retinal detachment. And in the past, one of the maneuver is putting a thread coming and going for zoom.
Yes.
It's just trying to trust the surface tension of the silicone to
Yes.
be pushed away in its place. I think one of the advantage, and this is why we like scleral fixation more than other type of lens, that it's help us keeping the silicone in the pack whenever the patient has a retinal detachment later on, which could happen if you keep some vitreous, as you said, in the base, if you don't look for any tears. And this will bring us to another question later on. Do you really examine the periphery with every type of lens that you are doing in the scleral fixation? But for me, I like it. I like the scleral fixation more than the artisan, if you talk about the retina issue. So, Dr. Priya, do you do indentation for every scleral fixation?
To be very frank, I do it only if it is complicated with some posterior segment involvement. Otherwise, no, I would say it happens only in 50% of the cases. But it would be ideal from retina point of view to do it for every patient.
Well, I totally agree.
This is the second loop. We can see that now we have the second loop.
So we see Dr. Safwan pulling the last thread outside, and mashallah, everything is good.
Give me forceps.
Calibration of tension is very important at this step, because you need to calibrate the tension of the sutures. Absolutely, that is very much necessary. Although the optic size is quite big, you're not going to have many issues about that. But still, you don't want anything to be floppy inside the eye. You want it to be taut in place, like you said.
Well, I totally agree with you, but
Fluid.
I think with this type of maneuver is much easier than tying the Gore-Tex on one of the haptics. Then you try to pull it to a degree that it's become fair. I think here, when you pull the thread up and down, you are sure it's in a good place. The other side up and down, you are sure it's a good place. I think centralization in this case is much easier than the other type of scleral fixation. What do you think?
Yeah, I think so. And I think Gore-Tex has its own importance. Let's not underestimate Gore-Tex suture, because, whenever you have a little bit of support of the capsular bag, and like you might have.
No, I'm very sorry to interrupt you, but we can see what I'm doing, because I'm centering and pulling the suture to one side. So I finished one side and barred to the sclera, and then I'm pulling the other side. So I'm helping the trailer side and then pulling the leading side. And then see, I'm pushing the trailer and then pulling the leading. In this way,
is dangerous, Dr. Safwan? Are you afraid of
dangerous?
pulling all
Yeah,
the
it's dangerous. If you pull it,
tunnel?
if you pull it in one side, you might end up with a twitching of the lens. Sorry, or an incarcerated of the suture into, or pulling the lens down, and it's not centered. Now I'm ready to push the lens back. I have only those two now, and I will go to push.
Dr. Safwan, how you can ensure that the four haptics are not are well stretched, not kinked under the iris?
We will see now the centration of it.
But why the lens is still above the iris, Dr. Safwan?
Why the lens, sorry?
Still above the iris.
No, now I'm pulling it back. So now it's the lens fully back, but it's decentered.
Okay, so now it's
I will really decentered from the left side. I will release the left side or the nasal side and pulling the right side. Now it's centered. Now I'm ready to cauterize the remaining. Now, as I said, 1 millimeter.
Do you do pre-iodectomy after you finish, Dr. Safwan?
Dry.
Pre-iodectomy?
Sorry, I'm not able to hear you, my dear. I'm sorry.
He's asking about iridotomy for the high IOP post-op.
No need. The distance between the lens and the iris. Give me another. No. Give me.
So half of us agree with you, Dr. Safwan, regarding the iridotomy. I didn't do iridotomy for scleral fixation. Some of our colleagues here are doing. I think there is a setting for the Constellation machine that you can do iridotomy very easily, very delicate. If you can ask the company to fix it for you, it's keep sucking, then one cut. So this is still ourselves who can do it. Yeah, I think.
Now I'm burying the knots, and we can see that.
Because in the other machine you can eat a big piece of
it's
the.
very clear.
Yeah.
See, nothing here.
Otherwise you sludge the pedal just one tap.
Yeah.
So we see the IOL very centered, Dr. Safwan.
Yes.
And just to repeat what you said, you push 1 millimeter inside the eye just for relaxing the thread. Do we agree?
Yeah, I agree.
Very well done, Dr. Safwan. Highly demonstrated. It's a perfect demonstration for flange.
Now we finished all, and just let me getting out, because sometimes when we are getting out, there will be some decentration. So let us go out and see. Fluid 20. Yeah.
So the flange inside the scleral tunnel, not under the conjunctiva. Do you agree, Dr. Safwan?
Yeah, in the scleral, yes, it is in the scleral tunnel. Close the fluid.
Do you
ever it should be in the scleral tunnel. That I'm sure. What you saw me, I'm sure that it's in the scleral tunnel. Now here, see, now that's appeared. Give me.
I have a question for you. Do you ever
one knot? One knot appeared, so I need to bury it. Fluid on.
Fluid on. Consider doing pupil repair in the superior part. Pupilloplasty.
It's in the tunnel, but part of it's appeared.
Photophobia or anything? But
Yeah.
do it for
Now it's fine. Give me. Give me. Close the fluid.
Close that totally. So it
Just let me finish the last stroker.
Very well done, Dr. Safwan.
Most welcome, sir. Off. Now the lens is in the center and the pupil is free. Here, all the damage that happens here, it's free. I just need to do stromal hydration in the site of main incision, my main incision. Here it's
You are using two different types of trokers, Dr. Safwan. Stellaris and Constellation, isn't it?
For the trocar, I'm using 25, but in this case, we have 23. Yani I'm sometimes using 23 and 25. It doesn't matter according to the availability.
So you open 2 packs?
No, according to the availability, because here, when I was in urgent, they gave me directly 25, unfortunately. So they opened 2 packs. Doesn't matter. Now we finished and the surgery is finished. What?
Thank you very much, Dr. Safwan. We will keep discussing the steps and the different opinion here, and you are welcome to share if you're still hearing us. Thank you very much. Applause for Dr. Safwan, if you can, please.
Most welcome.
Thank you. Thank you, Dr. Safwan. Well done.
Most welcome, sir. Most welcome. Most welcome.
Congratulations.
Yes.
So let's go back to the different. So you said you are using 5, and Dr. Preya 6 or 5?
5.
5. Okay. I'm also 5. I cannot oppose you. Anyway, do you really? We was talking about the needle itself. Honestly, I find it hard to find the thin wall 30 gauge needle, and sometimes the haptics of the 3-piece doesn't go through the 30 gauge needle. So in this case, we shift to 26 or 27, whatever available in the wall. The problem of that, we was afraid of having a wider tunnel, so the haptics will slip. It's never happened. This is just worrying me. Have you seen? So this is a very good comment, huh? So the sclera.
Yeah. Now Dr. Ahmed Khashab is coming,
and maybe
he will start his vitrectomy while I'm preparing for the lenticular extraction. So we will go both anterior and posterior.
You are saying something, Dr. Safwan. Can you repeat?
Yes, I'm hearing you.
But we don't hear you just before.
You are not hearing me?
Now we are.
Yeah, okay, done. Tell me.
What is the next
Any
case,
question?
Dr. Safwan? Dr. Safwan, the next case is?
The next case is, it will be 2 cases together. One, Dr. Ahmed Khashab will do a highly complicated retinal detachment. And the other hand, there is a lenticular extraction using the femtosmile Atos. So for me, I will start because I'm ready. And Dr. Ahmed, he needs only a few minutes to start. Only a few minutes. He's the quickest surgeon here in UAE.
Thank you, Dr. Safwan. We will keep the podium
Most
for
welcome,
the second.
So Ahmed, he's here. I think that the camera come here beside me. And Ahmed, he is ready, and see, he's showing his muscles to start. So
excellent surgery by Dr. Safwan. I was attending most of it. Beautiful surgery as usual.
Did you like it?
I loved it.
Oh.
Excellent.
That's good.
MashaAllah.
That's
So
good,
our
mashallah.
case is combined phaco-vitrectomy. She's I think 75 years old female patient.
So we will ask the second
She had
group
correction,
to take the
rheumatology,
podium, please,
retinal
for the
detachment.
retinal
So hopefully we'll
moderator and
show some
panelist.
bimanual
Thank you,
technique.
Dr. Praya. Thank you, Dr.
I will
Ashraf, Dr.
let
Safwan.
Ahmed
All the best.
listen to what you are asking.
We need at least, I think, 2, the
I cannot hear you.
refractive and also the retina at the same time.
Yeah.
Because they are going to work
So
at the
we
same
will
time.
we will start. He will start
Dr.
while
Ahmed
he is starting and prepare
Adi.
his case. I will finish the first Atos.
And Dr. We need Dr. Ayman Midanat. Dr. Ayman, you are here.
Here I'm hearing, but the other one is not. It's not working.
So maybe this one is the battery is gone. The battery is gone.
Maybe just
Dr. Ahmed,
because we need
Dr.
both.
Safwan, who is going to
Now you
start?
put it in the charger.
نعم.
You are going to start with femto smile?
Yeah, lenticular extraction, femto smile.
Okay, so
I will start now. And then I will give it to you. Yeah. Hello, my dear. Take. Where are you? Pick up. So here's 7. Now we are preparing the nomogram. So I think that the camera shows that how we are preparing according to the data that we received from the topography. So the optical zone for this case will be 7, and the transitional zone will be 7.8. The cup will be 100, cup thickness will be 120. The cup diameter will be 8.8, which is 1 millimeter larger from the transitional zone. The manifest refraction for this patient, the right eye minus 6.25, cylinder 0.75, axis 3. That for the right. For the left is minus 6, minus 0.5, axis 6. Both of them, the optical zone, we will make it 7. And the transitional zone will be around 8.8. 7.8, sorry. The cup diameter will be 8.8. Here, we have the ability to make the offset at the middle. It's my experience to divide the offset, which following the pupillary center, to half. So I'm targeting the distance in between the pupil and the geometrical center. And this is my experience. That will be better, because if the visual axis is near to the pupil center, this patient will be happy. And if it is near to the geometrical center, this patient also will be happy. Patient. Patient.
Yeah.
Yeah, your camera, just please bring it a little bit, and you will be away because you need to. Now. Give me. Give me. Sorry for any delay.
Dr. Safwan,
here, yes.
You hear us from the panel?
Sorry.
Can you hear us from here?
Yeah, I'm hearing you very well.
What is the pre-op refraction, if you may?
Sorry, just repeat the question. Come again, please. I'm not hearing anything now.
The pre-op refraction.
Pre-op refraction for the patient, I say it, minus 6.5 for the right, it's minus 6.25 for the right, and for the left was minus 6. Minus here it's minus 6.25, minus 0.753, minus for the right, minus 6 for the left, minus 0.56 left.
So if I may, is there a special indication that you went for smile, or
It is your routine that with a
No, there is no,
-6 you will
there is
elect
no
to go with
indication
such a
that we will go. It's not a, Dr. Ahmed, this is the sound of Ahmed Saadi, right? Who's the surgeon that asking?
Ahmed Saadi.
Yeah,
no,
that's a special voice. That's why I recognize you.
Is this your routine to go with this case, or is it a special case that you decided to go for SMILE?
No, there is no special case. There is no special indication here. The only issues is that this patient doesn't have a high order abrasion over 0.5. That's the only exclusion for me from the SMILE, other than the indication for the LASIK. So if the patient indicated for the LASIK, he will be indicated for a femtosmile. Means that the Bellin-Ambrosio scanning, the scanning, the Corvus scanning, and for the hours serious scanning.
I have no experience with Atos personally, so I'll ask you. Can start, and then we will comment me and the panel.
Yeah, I will just.
As you start.
I need time because we are preparing the entrance of the second patient. Okay, now. Now the machine ready, and we can see that the yellow, green appear here in front in the screen. We will highlight the green cross to start ducking. Okay. Now look at the green. There is a protective site in the machine that's when we are ducking the speed of the ducking. You can see now the green cross. I put it a little bit down. That's measuring the Bell's phenomena for the patient. And I'm now ducking. See? I need a little bit up. Yes. See, reducing the pressure a little bit. Now I reached. Start vacuum. You can see that the green and the yellow almost match, and the laser will start. The laser will start now from in out, not from out in. Only a few seconds. Started. Now from in, this is the posterior. You can imagine the voice and the jam in our theater. Now this is the interior, and then now the edges will come. Now the edge is done, and we finished. Here, we will start the extraction. Now in extraction, no, don't move my hand. I need muscle hook just to remove those eyelashes. I don't like the eyelashes to come in, so just to remove it. Now the edges. And now I'll separate the posterior and then anterior. Here I'm in the posterior. And now I'm searching for the anterior. Here, there's a few tricks too. Now I reach to the edges of the anterior, so you can see.
So Dr. Safwan, what's
Now
your
I'm in the
trick?
anterior. Sorry,
What's your trick
now,
to make sure that you are really in the posterior lip when you go in? Do you have a special trick to make sure
Yeah.
that you are really posterior?
the anterior is shorter than the posterior. See, this is the edge of the posterior, and this is the edge of the anterior. So you can, it's very clear. Here, there's two edges. This one, the edge of the posterior, and this one, the edge of the anterior. Now, I will go to separate. Here, the posterior is separated. I'll go to the anterior now. I'm in the anterior. You can see that the lenticules start to move. And this is the loop of the anterior. Here, I will not go through more manipulation, so I will use my special forceps tying gauge 23. See how nice? Here, holding the lenticule from the origin and anti-clockwise here. And then again, holding from.
Dr. Safwan, I can
And
see
that's
that
it.
your posterior was easier. Do you think this is because of the spot
No,
distance?
no, I just don't need to do more manipulation under. Give me fluid. Just I'll show you.
Looking at your laser parameter, I can see that the spot distance in your posterior cut is 4 microns, and in your
Yeah.
anterior cut is 4.4. And
That's
at least,
right.
me
Because
watching,
the nomogram for the anterior, for me personally, is different than the posterior. Because I found that this nomogram for the anterior is much easier. And here, I just need to open it. Now it's 360. There is no any miss part. See? Now this is the one, if anyone need to see. I just rotate it. See? It's 360. I remove it now, and we finished.
nice. I don't know if Dr. Ahmed Ghanem or Dr. Sandeep Mitra, you have your mics. You can put them on. Yeah.
I don't know whether Dr. Sandeep has any opinion that.
Dr. Safwani, when you choose to put the refraction, the final refraction, do you add or subtract, especially if you have a higher cylinder? I mean, if you have a 2.2 diopter cylinder, do you add or subtract any quarters
Yes,
or something like that?
First,
or you just
I'm
put
using
the final
in my astigmatism. This is I'm using the total corneal power. So I'm using the total corneal power, comparing the total corneal power with the anterior corneal power. If there is any disparity, then I will use the total corneal power. Here, I use the total corneal power. So adding and subtracting, I agree with you, according, especially with against the rule. Here, it's with the rule. So this is not a big, but when we are against the rule, when we have astigmatism, then yes, I follow the total corneal power. Now we are going to the other eye. Done? Some technical issue. We need to overcome it. Okay.
One of the things is if you want to see whether you have gone into the posterior plane or anterior plane is when you are going through the entry and you push the posterior plane, you will have what is called the fish mouth sign. So the posterior lenticule will just open like a fish mouth. And then you just move your spatula and then in the tunnel, and then you will not miss the anterior and posterior plane. If you have gone through the posterior plane, for example, you have what is called the moon sign. So you have a ring, so you can see the spatula lifting the lenticule up, and
I do agree with you if the margin was 3 micron, Sandeep. Here the margin is 0. So that's why I did it in this way. So you need to feel it, Sandeep. You need to come to do it, and then you will see that. If you will go to the posterior first, you might not have the fold. So if you didn't have the fold, then you will end up with, you don't know whether you are in the posterior or in the anterior. That's why I'm saying here in this lenticule, we have a periphery of 0, not 3 micron. What you are talking about, that's right. In Vigimax, you have 3 micron, and that's why do it. No.
Are you going to use the same parameters like the other eye? Because
yes,
I can feel
the same parameter, the same.
Very easy in separating the posterior and the anterior.
Yes, I do agree with you. That's definitely with a lot of changes, and then I found that I'm very happy with this nomogram. I'll repeat again.
How the wetting of the cornea? Do you need to have a good dryness for the cornea and the conjunctiva, or you sometimes need to wet the cornea?
No. You can see that now. It's wet. Look at a little bit or left, a little bit. More left, please. Yes. Now we are. No. So I will stop vacuum and repeat it again. Look at the center and the green cross. Okay.
Some tilting. Maybe the patient is squeezing. Yeah. That's why it's a little bit tilting.
No. Yes.
Now it looks good. Yeah. Now it's good. Now it's better.
I can start. Now I'm starting. Don't move my head. So I'll show you now what Sandeep mean by his comments. So I will go through and I will do as what he said. And I will show you that sometimes it might not happen. Maybe it can, because the thickness of this lenticule is thick, but in the second case, it's thinner. Now the edges will finish. Yeah, we finished.
Focusing was in the center, what's it?
Yeah, but now it's decent. Because you can feel that the corridor or the gap here. Yeah, that's why it's tilting.
So what he meant is that we can go through the posterior, separating it full, and then we might have the folds of the lenticule. Through this fold, we can go through. That's right. Oh, look at the center, please. No, a little bit up. More. Yes. Thank you. Opening the edge. No, please don't move. Going to the posterior. And here I will not go, I will not open the anterior. I will go directly to separate the posterior. See, Sandeep? Till now, I didn't have a fold. See? So I need to go through and now separate the anterior with the other one. So that's why I'm doing it in the beginning, better for me. See, now the fold appeared. And now I'm in the anterior. Here I did it by full manipulation.
Dr. Safwani, you always start with removing the posterior. You don't try to remove
separating
the
the posterior means. That's what you are saying. That's what you mean, sorry. Yeah, always. Don't put fluid because it will not be visible. I need them to see. Yeah, now.
Dr. Safwani, so very nice work. What will you do if you find that you have a missed particle of the lenticule inside? Do you use any stain or you can handle without
I will show you. I will
staining?
show you now. Give me the forceps again. So let us say that I found that here in this corner, according to what I have, a lenticule missed. So I will go in now to that side. Once I press, if there is any remnant, it will appear. The edges of it will appear. See. I'm searching here, here, here. There is no any edges. See? But if there is any edges, it will appear clearly. So this is my technique to identify. Yeah, put the drops. So to identify the remnants. But it's a very good question. Sorry that I forget to discuss it. Yeah, put the drops, my dear. Okay.
You don't have to inject any.
No, I'm not injecting. No, I stopped injecting. I was injecting dexamethasone in the beginning, but now it's not. It's much better for the recovery. I feel that the patient is more having better visual recovery than with injecting, because the edema of the cup second day will prevent the recovery, a quick recovery. Shall we go to the second case?
No.
Thank you.
I just use contact lens if I have a problem with the main one.
No, that's another good question. Yes, I'm using contact lens. First, massaging the cup, removing the fluid, and I'm using the contact lens. Because the contact lens will keep, this is a bandage contact lens with more than 8.5 the diameter.
Okay, Dr. Safwani, just give us your protocol and the treatment, and when you remove the contact lens.
The contact lens removed second day, only 24 hours. Just we have some coughs for the second patient, so we will.
What about if you find any remnants in the pocket? Do you interfere rapidly, or you just wait until to be sure it affects the refraction or not?
Well, let me tell you. First of all, if the cup shows immediately a missed part, then immediately I will react as I show you. But if I'm not sure, even after the removal of this part, then I will take the patient to the anterior OCT, and I'll see. That happened with me once, and I took the patient directly to the anterior OCT, and it was clear. And second day, definitely, we are doing a routine anterior OCT for all our patients.
I think I just have two comments. One is, in case you have lenticular material left and you see it immediately, the best way is you can do a negative stain, just put a drop of Pet-Fort. It will just shine up as a black area island. Or you can take the patient on a slit lamp and then you can see the lenticular remnant.
Exactly.
You can just mark it with
there is a lot of method, Sandeep.
marker. And
You
take the
don't use
patient back to
slit
the
lamp on the machine?
yeah, you can use the slit lamp on the machine or just the
Or
slit
on a
lamp. Yeah, and you can just wash. If you just wash the pocket, the lenticular material comes out instead of going and digging into the stroma. It's very easy. You
No,
just wash it. The lenticular material comes
Sandeep,
out.
I'm
the
saying
other
that
thing
if it is stuck, then I will go to digging. But if it is floating, for sure.
Yeah, if it's stuck, you have to go in. The other
Sure,
thing is that when you are removing the lenticule, it is always better not to dissect both the temporal and the nasal side. You keep one side of the lenticule attached as a counter traction, and then dissect the other side, and then go back to the other side. So in case you don't make a windshield wiper movement, you do about 80%, leave 10% attached on the temporal side, and then come back to the nasal side and then go back again. So your lenticule will not crumple in the center. So it's very easy to do it. I think these are the tips which will help the young ophthalmologists.
I think that,
Dr. Safwan, we really would like to thank you, and we will run some discussion here in the panel because there is lag whenever we talk to you. So we really thank you for this neat surgery. And we will just keep discussing maybe for the next 2 minutes, 3 minutes with the panel. How do they think?
Yeah, we are preparing the second case. Okay, thanks.
Thank you. Thank you, Dr. Safwan.
Most welcome, sir. Most welcome.
Let me ask you something. Do you find that it only depends on the power or the size of the spot? Because I find that with the light iris that I can find, even with a biomechanical indices,
but
I can feel that the dissection is smoother than black color. This is my just personal experience. Do you find something like this?
Yeah, it does happen. One of the things I have realized is whenever you are dissecting, it's always better to go from a point of low resistance to hard resistance. So if you find areas not dissecting, don't just leave it. Go back to an area of low resistance and then go to the high resistance. And you're correct that in light iris, sometimes it's difficult. Again, if you are taking the depth, if you go superficial, the stroma is more compact and then the dissection is difficult. Whereas if you go 130 microns or below that, it's much easier to dissect. So that's another trick. So if you go very higher up, let's say you take 110 microns, 120 microns, it gets more difficult.
Here, doctor, this brings the question. Where do you think the energy in the brown iris goes? Do you think it gets absorbed to the iris? So if it's so, have you seen more uveitis post brown iris when you do smile or less, Dr. Ahmed and Dr.
No, for me, I didn't see it. Fortunately, we have it in Alexandria with Dr. Osama Ibrahim. The machine would gives us up to -14 diopter. So I didn't face until now something. But tell me your experience. No, do you find any anterior uveitis or something?
No, not anterior uveitis, but I have DLK. I have seen DLK after smile. Also, nowadays, the best thing is to decrease the energy level. So instead of increasing to 30 millijoules or more, you actually go down. So if you decrease the energy levels, actually you get much smoother cut. And the newer Visumax, which is 800, it actually cuts it very fast. So I think this machine is also very good.
What is your routine post-operatively to prevent DLKs in SMILE? What do you do differently when we compare it to the femto LASIK, for instance?
I actually wash. So although many people don't do it, but I feel washing of the interface is good. Whether it avoids cells in the interface, I don't know. But in all my cases, I wash. Yeah, and give frequent steroids. And I check the patient.
How frequent is your steroid post-operatively? What's your usual regimen?
I give it very like 5 to 6 times a day.
For how long?
For a week.
A week.
And then stop it. I don't continue after that.
What about you, Dr. Ahmed?
No, I give for 1 week with high frequency, then I just withdrawal for more 3 weeks. I give for 1 month.
You give total for 1 month, and you keep your antibiotics for how long?
For maybe for 1 month also.
1 month.
No, 2 weeks, but I just I like to see the patient for 3 weeks, maybe twice a week. And continuing about your question, washing the conjunctival sac before talking is also one of the way to prevent DLK, because washing in the pocket, I'm not sure about. I mean, I just wash it when I see something abnormal, but I don't used to wash it until I was very careful while doing the dissection.
So in your opinion, doctor, since we touched upon DLK, would you manage DLK post-SMILE differently? Your approach will be different from the usual DLK post-femto, or you will just apply exactly the same rule, depends on the stage and the time when you'll go for washing, when are you going to go for just frequent steroid, when are you going to go for oral steroids? So just can you enlighten us?
The protocol remains the same. So if you see the DLK going from stage 1 to stage 2 to stage 3, so you have to go ahead and remove the cells. So you open the pocket and wash it and give them systemic and topical steroids, because otherwise the flap, in this case also, there will be a lot of inflammation. So you manage the same way.
Thank you.
Thank you.
I would like really to thank the panel, thank the surgeon, and thank you. And we wish Dr. Khashab all the best. Thank you.
Okay, now we're going to move to switch gears and go to retinal surgery with Dr. Ahmed Al-Khashab. May I invite Dr. Kakan and Dr. Dr. Meyer.
Down, a little bit down, down. No, a little bit up.
And Dr. Babiker, yes.
Yes.
Okay. Okay.
Don't move.
Okay, we'll start commenting on the refractive surgery since there's no retina.
Take it. Take it and give it to me. We can switch to him. We can switch to him. We can switch.
English. Okay.
So maybe until we get Khashab, can we have a show of hand of who's in favor of combined phaco-vitrectomy for cataract and retina? Okay, and who is not in favor of combined surgery? Right. Okay, Khashab, can you hear us?
Yes, I can hear you, Ahmed.
Excellent. Can you give us a brief about your case?
It's a traction rhegmatogenous retinal detachment, macula off, dense cataract. She's, I think, 78 or 80 years old, female patient. She cannot understand Arabic or English. That's why she was coughing the hell out. So I managed to finalize the cataract.
So this is a rhegmatogenous detachment or a TRD?
Traction rhegmatogenous.
So it's a rhegmatogenous detachment, yes.
No, it's traction rhegmatogenous.
Oh, it's a combined traction and rhegmatogenous detachment.
Yes, yeah. She's diabetic. So I don't know if you can see the feed from here, the image. I cannot hear you.
No, we're not talking. We were just waiting for your next move.
Yeah. So now I'm inserting the IOL.
Down. Thank you. Just a little bit.
It's a 2.2.
Welcome any questions from the floor. So if you have any questions, please go ahead.
So it is well covered by the rex's edges all around. Maybe the rex's is even smaller a little bit than what I expected.
Significant cataract, or you're anticipating long surgery and the lens will go?
Okay, hydration, please.
Khashab, can you answer a quick question?
Yes, definitely. I'm with you.
So did the patient have a significant cataract, or you were
Yes,
anticipating that the lens is going to get cloudy with a long surgery?
It's 80 years old. Dense cataract. You missed it, but it was, and this is a long tunnel.
So maybe a question to Dr. Kakan here. Do you usually hydrate the wound at this stage, or you don't?
I usually don't hydrate the wound until I complete my vitrectomy. I just prefer to suture the main port and then complete the vitrectomy. At the end of the vitrectomy, I will remove the suture and hydrate, because the hydration will have a little bit edema and visualization may be compromised if you are getting for 1 hour or more hour surgery. So I don't prefer hydration at this stage. I prefer to suture it and then remove the suture at the end of the surgery.
Yes, I am not doing any hydration. I will just put one suture, 10-0 suture. It will be far better for me.
So usually I'm not suturing.
Yes.
That's why I'm hydrating. It's almost as if finished the phacosurgery. Not hydrating too much. And mainly actually the paracentesis.
Again, that's a good point for the floor, is just be wary that hydration may interfere with the view. As Dr. Khashab is saying, just keep it minimal.
And one of you prefer to do combined surgery, or sometimes
there's no air?
unless it is
Open the
cataract, so it will not give you a good visualization for the retina. I like to do it in separate. Yes. I didn't like combined surgery most of the time.
Yeah, I don't like combined surgery unless I have to.
The issue is, one is about the combined surgery. Second is whether you are going to implant the IOL before vitrectomy or after the vitrectomy. So if the cornea is getting cloudy and you have implanted the IOL, you are getting 3 reflection, one from the corneal edema, second from the IOL optic edge, and the third one is the retina. So
some gel on the cornea, please.
You can avoid.
First, let's have a look, and then we'll put the shinde, because we'll return back there.
You can avoid the implantation, the IOL. At the end of the surgery, you can easily implant the IOL if you are not good in seeing the retina during surgery. So anything can be possible. It depends how you got tuned.
But do you want to
Lens is there.
know whether you put some halon in the anterior chamber? No.
Actually, if you put the halon or dispersive anything, you will have a hampered visualization. You wouldn't be able to see the retina clearly. So it should be BSS in the anterior chamber while you are doing aphakic, obviously, vitrectomy at that time.
So this is the beauty of retina. Everything works, and everyone does things differently. Again, to summarize the case, so we have a combined traction rhegmatogenous detachment with cataract. Dr. Khashab went on and removed the lens and put an artificial lens in, and he washed the viscoelastic. And now his attention is given to the posterior segment now. So discussion, yes. We have a mic to the audience here.
When we are planning a combined surgery?
That's a great question. For myself, I use the hydrophobic acrylics with the usual lens, and I try to avoid multifocal IOLs.
I agree.
Yeah, so you can have a look now. This is the image.
Dim the lights a little bit.
This
Can
is
we-
the.
Can we make it less light?
I do not know. Are you seeing what the case now? We are starting the vitrectomy.
We're trying to put the lights off here, Ahmed, a little bit so as not to interfere with your view.
Yeah, can you put the lights off, please? Yeah. Is it better?
Yeah, no, I was talking from our side. I was trying to make a joke.
It's a lot of fumes on the lens. Maybe can you clean it, please?
No. Ahmed, if you have a minute, can you tell us about what viewing system you're using?
What?
Viewing system.
Lens, it's the Resight. Usually with the Safwan here is using the biome, but I'm acquainted to the Resight more. So I put it on the microscope here. So the adjustment is not that perfect. Can you rotate please a little bit?
So you don't like the biome that I'm using?
I didn't try it.
And this is the wide field lens, right?
Really try now. That's not the time.
This seems just this one. No. It is just like traction, I see. Is it true? I see. Yeah, a break there, something. You agree that in such cases, after you're doing core vitrectomy, you attack the central area before you go to the periphery, because you can make a lot of breaks.
Still, I'm removing the vitreous. I'm not trying to tackle at all the membrane now.
Go attack the fibrous tissue. Yes. Makes a lot of problems, especially the accidental breaks, because the retina as arcades is sometimes very delicate. I am just asking my fellows here that if you, in such cases, if you have a fibrous tissue very close to the center, posteriorly, actually at the macula or the disc, after doing core vitrectomy, you have to attack mainly this fibrous tissue by segmentation and removal before you go to a periphery. Because as arcades, sometimes the retina is very delicate, so can make a lot of accidental breaks.
So it's wise to do the segmentation and delamination before doing the PVD.
Yes.
You just do the core vitrectomy, deal with the membranes, and then you can induce the PVD, because the vitreous posterior hyaloid acts as a third hand to hold the retina to fix for your delamination or for segmentation. So if you will do PVD before, it will be no counter force and it will be more floppy and fragile retina than inducing the PVD.
Yes, this idea should be and put in mind for all our young vitreoretinal surgeons, because sometimes if you are not doing such things, you are going to face a lot of problems.
He said you are decentered.
Ahmed, we're slightly decentered here. Are you well centered, like XY? Is it from our side?
Is it better now or?
No, other way.
I'm wondering if the Resight is not like clicking in.
The Resight is not clicking in? Can you,
like if
can
the
you
lens
double
is
check?
decentered slightly, but if I think if you're working fine, that's fine.
They need microscope to center, then they will say get the view center.
Again, through the floor here, the discussion that was going on by the panel was
On the contrary, I love it here, but I am not acquainted to the biome.
Enjoy your time.
The discussion here is whether to try to induce hyaloid separation.
You can see now better, or is it still?
We can see well. We're slightly decentered, but I think if it's fine for you, it's fine. When you have a minute, just let us know about your plan for. Are you going to go and try to separate?
I'm planning a bimanual dissection, but now I'm just releasing the periphery. What is the infusion now? Releasing the vitreous from here, the area of retraction. Okay. Can I have a forceps, please? The problem as well is the patient is moving her head. I cannot really control that. Can
we have echo here, and I think the sound is not the best. So I think it might be best when you speak to us, just speak to us slower, just to, I mean, help circumvent this situation.
No. What, sorry?
What are you planning now?
I'm planning to try to I will put the chandelier and then I will try to move by manual to cut this membrane, but I'm just checking the adhesions.
Right.
It's a weird membrane because the rest of the retina looks fine. This is the vitreous, not the. Okay, can we put the chandelier on?
I think to summarize the situation here to the audience, we're at the stage of Dr. Khashab trying to separate the membrane from the retina to get a dissection plan, and he is planning bimanual dissection.
Can you hear me? Mohammed, can you center your microscope because your image is at the left lower angle of the screens? Can you center your microscope, please?
Is it better now or? The endolight is. Can you increase the endolight and push it down inside more? Yeah. Okay, that's fine. No, a little bit further. Can you have me scissors and forceps, please? Yeah.
Khashab, is it a good time to just stop for a second, if you can?
Yes.
We're significantly decentered, so maybe a suggestion just for the sake of broadcasting here is to just center the microscope from the button there, just like the XY.
Can we recenter the microscope because?
And then
okay.
make sure that the resight is like clicking in, it's not moving like.
Okay.
There's no lateral
can
movement.
Can we recenter the microscope,
That
please?
seem to be interviewing with our view, although it's actually fine for you, if you can.
Yeah, I will.
It's a difficult case and.
Inverter. Where's the inverter? Okay. Okay, let's put the microscope. The resight.
Again, maybe for young surgeons, sometimes what happens with the resight or the viewing system, although
it meant to click in. It's actually not clicking in. There's sometimes wear and tear for the part that prevents it from rotating. So just make sure that the UV site is clicking in every time you use it. And sometimes that actually does not happen.
Is it better?
Much better. Thank you so much.
Can you rotate a little bit? Yeah, okay. Is it bleeding, although I did not touch anything yet?
Yes. Again, to keep summarizing, Dr. Khashab put bimanual chandelier and his, doing bimanual surgeon, he put a chandelier in. Ahmed, what type of chandelier are you using?
The one with Stellaris Elite.
Right.
It's the machine I'm using now. So I put the 4th port. What is the infusion on? Can you increase it a little bit more?
35.
Yeah. Okay. The patient is moving.
So can we have a quick question to the audience? So how many of us do the bimanual with the horizontal cutting scissor, delamination? So can we raise the hand? So how many of us still use the vertical cutting scissor for segmentation? So none. So most of the people are using horizontal cutting scissor with the bimanual with the chandelier. So how many think that the pulling of the retina during the delamination, when you are doing the delamination with the chandelier, harms the inner segment, outer segment junction? What's the functional visual outcomes of these surgeries? Anybody comment? Usman?
I think finding the right plane is the key. Once you get into the right plane, but certainly chandelier assisted bimanual technique gives you a better options to get into the right plane. And that's the key. That's what I've learned, that once you get into the right plane, you're able to dissect properly with minimal damage to the underlying retina. So I think that's the key.
How you prevent the pulling of the retina, because you are using your left hand to holding the membrane. Obviously left hand is pulling the retina. Is there any trick that you have a minimum pull of the retina during delamination?
I think with experience, you learn that, the lesser the pull is, the better. You always feel that you're pulling more, but in my mind, I always try to do it as minimal as possible, and try to get under it. And especially now we have 25 or 27 gauge vitrectomy cutters with the opening of the probe is right at the end. So that acts like an extra pick. So yes, it's tricky. And even with the best of your, effort, still there are iatrogenic breaks. But certainly, I feel that to pull it as less as possible and just to wriggle and try to see if you can get underneath it and cut a little. And also plus the vitrectomy mode has to be different. for my core vitrectomy, I use the 3D mode in the constellation. Whereas when I try to get closer, I use the momentary cutting, which is a different mode with a little bit controlled vacuum. So not as high vacuum as a conventional core vitrectomy.
Okay, thank you, Usman.
Usman, great points. Can I ask you, just to keep the discussion going until Ahmed gets back to us? So do you start in a case like this? I think would be difficult to do it without bimanual because the retina is very mobile. Do you start dissection from the disc out, or you would start from the membranes in?
Well, what I define this type of vitrectomy, I call it a reverse vitrectomy. So I start from the periphery around the aura to cut across, so that first of all, the major traction to be relieved. So once I've done it, then I start in a spiral fashion and keep coming down, 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 and down. And at the same time, I keep looking at the retina, how it's behaving, how the membrane is behaving. Is the retina getting more released or relaxed? And after that, I would always try to use visual enhancing dyes, either membrane blue or triamcinolone, whatever is available, to actually differentiate between the highlight phase and the true membrane, because that's vital, because sometimes they can be mixed. So once I'm there, then the second process of magnified image combined with delamination starts. But I go from the outer edge, then come towards the middle. And I don't pull from the center so I just try to go towards the center, because if you try to pull it away from the center, high chances of iatrogenic breaks.
Thank you. That's very helpful. Tawfiq, and Tawfiq. Maybe let's go Tawfiq, Egypt. I know you do the tri-manual technique. Can you tell us if you think this would be a good technique in this case, and maybe summarize the tri-manual technique for the floor?
Yes, for me, if you do a bimanual vitrectomy, be aware of your left hand, because the break is coming from your left hand, not from your right hand. This is the first point. Because when you are thinking for attacking the membrane, all your concentration is going to the right hand when you go to delaminate the membrane, and forgetting what you are doing in the left hand. The tangential traction or anteroposterior traction that you're doing in the left hand. In such a cases with retinal detachment, I may use the trimanual vitrectomy with the PFC flattening the posterior pole and make like a third hand protecting the retina to going up when I pull it. But also in this technique, if you are not concentrated in your left hand, it's a break will occur, and this is a disaster if it's happened when you're using a trimanual vitrectomy, because you are going to another problem of the PFC under the retina. So any bimanual vitrectomy, when you are working in your both hand, there is two active hands, the one handling the membrane and one attacking the membrane and cut it. Be aware of that handling the membrane and that grasping the membrane, because 90% the break will come from this left hand, not from the right hand. And if you decided to use the BFC.
So now the patient decided to move up. You can clean the lens, please. I agree with Muhammad. It's beautiful to put a PFCL, but with a tear that has traction on it right now and pulling more, I think this is a formula for disaster, allowing the PFCL to go under the retina and creating more problem. I think we need to clean and put some gel more, please.
I think these are all great points. Again, to summarize, so Dr. Tawfiq spoke about the technique where you're flattening the retina with PFCL and then doing bimanual dissection.
And this is also, Dr. Ahmed, this is also a better way in such cases that Dr. Khashab is working, and you use the forceps and the pick, because the sharper edge of the pick can just snap the epicenters. In the scissor, you need to go and searching for this epicenter, and when you cut, you don't know whatever you are cutting the epicenter or you are catching the surface of the retina. And the pick, just you go with the sharper edge of the pick behind the membrane that you are a little bit grasp it up, You can scratch in the epicenters much more, I think, easier a little bit from the scissor if you have the detached retina like this. And also it's the nasal approach. As you all know, that if you have the membrane is going more nasal, that the job is more difficult. If you are the membrane is little bit in the temporal approach, you have a little bit much easier approach for this membrane. And you told me yesterday a perfect idea is that if you have a nasal membrane, you can set temporally or nasally, so you can just go with the nasal membrane much easier.
Good point, Dr. Ababakr.
Yeah, very good ideas.
What would you do in a case like this? Do you buy manual or use PFCL?
By manual, but in such cases like this, I avoid to do any BFC actually, as this state particular. It will go definitely behind the retina. So I will be in trouble unless I remove all the membranes. But actually, idea we have to discuss whether somebody asks you come from out to the disc or from the disc. I think this will be according to the, in BVR usually, we have to start from the peripheral. But in traction and detachment for diabetics and such cases, this one, we should attack the membranes at the disc or the macula first. And we avoid to go to the arcades because the retina in such cases will be very delicate. It will make a lot of some breaks accidentally.
Yes, Tawfiq. One question to the audience. How many of you induce the PVD before delamination? Can you raise the hand? None. So how many of you induce the PVD 100% interaction retinal detachments? Mohammad Tawfiq, do you induce the PVD in every case of traction retinal detachment?
In traction and retinal detachment, like diabetics, it's very difficult sometimes to say I have already removed totally the BVR because it will be stuck to some areas, especially the arcades and the large veins and arteries. So complete BVR in traction and detachment, I think it is one of the challenges. But in BVR, you can do it actually. If you start, especially from the peripheral, you can easily remove it.
Yeah, just a quick comment about the from disc to periphery, periphery to disc dissection. We have to be aware that the retina is thinner towards the periphery. So whenever possible that you can dissect the membrane from the optic disc going out, taking anchor of the retina at the optic disc and making advantage of the thicker retina, which is, I mean, more forgiving for any incident. This would be great rather than going from thinner to backwards. I'm not sure. Do you agree, Dr. Salama?
Yes, yes. I think that's a great point. And I think, again, for the floor here is whether you start in, out, or out, in. And I think there are advantage and disadvantage. And I do like, as Dr. Muhammad is saying, I always start from the disc out. My main reason for this is that there's usually vitreous crisis. And to avoid the vitreous crisis and get in the correct plane early on, if you start from the disc, there's no vitreous crisis in the posterior pole. So you're really in the plane early on. The disadvantage is that you can have significant bleeding early on.
Yes.
So I think that's something to keep in mind. And also the retina is thicker posteriorly. There's less adherence over the macula. So you're in the plane early on.
Also, I like what Dr. Khashab is doing. He's doing kind of peeling in a circumferential way. So going from right to left or something like that is trying to peel this membrane with the least traction on the retina. So it's doing in kind of a circumferential peeling rather than pulling outwards or inwards. So the idea is to find the plane at first, then you do the least traction on the retina while you are peeling this membrane of the retina. Thank you.
Thank you. That's a great comment. Khashab, I can see you're getting some success rates. It's a very difficult case, and you're doing really great.
The bleeding is the one that I'm really concerned about.
I have a question to the audience.
I do not want to have another membrane.
I'm very happy that Dr. Khashab is just ignoring this very minute hemorrhage, because if one actually starts to do a internal cryopexy, will make it worse actually. But if it is clot, he can remove it during, for example, fluid air exchange or something like that in one piece, because by that time it will be clot and it can be easy. Try to avoid cryopexy. I think this is one of the main issues actually. If you have some bleeding from these small accidental breaks or vascularized membranes.
What do you have? I'll take scissor, please.
Dr. Khashab, you are using the cutter for dissecting the membranes?
Some of the membrane, which is excessive, but usually when it is very adherent to the retina like this, I will move back to the scissor.
So do you find any
Can I have
break
another scissor, please?
along these membranes?
I didn't hear. Can you tell me again,
Any
please?
retinal breaks along these membranes?
Yeah, there is. One of them is here. I cannot really show it with the chandelier now, but it is, I can see it hiding behind this membrane. And this was the tear that I've seen before when I was examining the patient, but I don't know if there is another one here underneath this membrane as well or not.
Okay, you carry on. You are doing good. So carry on.
You have a traction retina detachment or a PVR detachment like this with all the standing detachment with a subretinal fluid, sticky or visic subretinal fluid, try to delay aspirating this fluid as much as you can, because this fluid make a little bit the retina underneath the membrane stuff, and with a movement a little bit, small movement. If you aspirate or you have a iatrogenic break, something like this, and the fluid is coming out, don't go for rushing and to aspirate all the viscous fluid underneath this retina, because at that moment the retina will be moving freely, mobile movement, and you will lose the stability of this detached retina a little bit. So if you succeed to attack the membrane before drying or aspirating this fluid, it's much better than to aspirate the fluid better, because in the past what I'm doing first, I go for the break and aspirating this fluid, going the retina to pee back. I feel that it's much easier for me, but it's more difficult to just grasping the retina by your left hand, and the retina is coming easy with you, and it's more difficult if you keep it the fluid, all the fluid underneath the retina.
That's a great tip. Thank you so much, Mohammed. That's a great tip. I think we had a show of hand from Dr. Mohammed here at the back.
Just to the panel, how would you manage bleeding while you are doing such a tough delamination? Would you enlighten us, Dr. Salam, and the rest of the panel? What are your mechanisms to tackle this issue in such tough cases? Sometimes you get bleeding here and there.
Yes, it's. I think it's a great. So to repeat the question again, how do you manage bleeding, especially when it's like significant bleeding? So first, I use anti-VEGF before, and I'm sure that this case received anti-VEGF before. Second, I try to start from the disc outward. That is associated with increased risk of bleeding. But what I do is before doing anything, I put the pressure to 60 Then I work in the first 2 minutes on 60 and I try to get into the plane quickly and then lower the pressure. And then third is to just wait and take my time for the bleeding to stop. But I think that's the problem is bleeding, as Khashab is facing here, and he's doing a great job. But that's what I tend to do, mainly like raising the pressure.
So the thing here is that I prefer to inject anti-VEGF 3 to 5 days before the surgery. It's not a rule that 3 or 5 days. It depends how much vascular tissue you are having. Either it is more fibrous tissue or either it is more vascular. If it is more vascular, then I will wait for 5 days. If it is less vascular but more fibrous, then I will wait for 3 days. And in routine, I do my retinal surgery in diabetic eyes at 30 pressure, not more than 30. Even I prefer to do it at 25 pressure. I don't raise pressure. Obviously, when you have the bleeding, I have two mechanisms. Either I will keep that bleeding holding with my pinching with my forceps. If it is a fibrous tissue, I will pinch it. Second, I can hold the bleeding or oozing vessel. If it is from the fibrous tissue, fibrovascular tissue, I can hold with the low aspiration of the cutter. But I don't prefer to raise the bottle height or intraocular pressure in diabetic eyes. Even if you have a massive bleeding, you can have the air inside and it can get the clotting. But the main is to I pinch with the forceps or with the cutter aspiration. So it may rise, because raising the intraocular pressure during surgery for 5 to 10 minutes or even more in a diabetic eye that is already hand motion vision, you wouldn't get anything good at the end of the surgery from that retina. That's my impression.
I do agree with that rising intraocular pressure would compromise the already compromised vascular. It's a vascular disease, so it could compromise the vasculature to the disc or the rest of the retina. So although working on a very high pressure is really sometimes you have to do this in order to stop that bad tough bleeding during surgery. So yeah.
Do you
So
ask
it's
your
a kind of you
anesthesiologist
customize the pressure.
Hypotensive anesthesia.
Now
for
I
diabetes.
removed most of the membrane, but still I can see that there is a vitreous which is flush here and attached to this part. So I'll put some kinecort just to clean the peripheral vitreous a little bit. Maybe I'll go again to grasp some of the membrane. But it is very adherent to the retina.
Ahmed, you are doing a great job. This is Mohammed Awadallah. Would you prefer to restain again, with dual blue in order to detect any?
Yes, definitely,
membranes?
definitely. But for the time being, I'll just inject kinecort and see how's things going. I need endolight, please.
Raising the bottle, compromising the blood flow, or dealing with a massive bleeding, both are not the best situations. The English describe this as catch-22. You're darned either doing it or not. Khashab, you're doing great. It's really a very tricky case. And I just want to assure you that we'll be thinking of you during lunch.
Thanks a lot.
Right. We'll leave you in peace. Go for lunch and all the best.
Okay, thanks
And
a
you
lot.
can summarize to us when we see about the case. Thank you so much, everyone.
Thank you.
Yes.
Thank you.
As long as we're thinking of him during lunch.
I think they stopped the feed. They stopped the transmission. In the laptop. Can you tell her son to come, please? مش عايز حركة لو سمحت. ما في حاجة، ما في شيء. راسي تعبان؟ طيب حاضر. ما في حركة بس لو سمحت. Can you tell her son to come? Her son is coming? Hmm? I'm getting sound, but I don't know if they are hearing me or not. Okay. حاضر حاضر حاضر. The problem, I do not want to touch while she's moving like that. حاضر ما في حركة يا أمي. ما في حركة لو سمحت.
الله شيء بلي ما بلي صارت جيراننا مودا مودا أنا بس تمود بنتي أما مصر شكرا شكرا كم ساعة كذا
Her head. Yeah, but tell her not to move now. ممكن ما تتحركش بس لان احنا شغالين دحين مش هنقدر نحرك الراس يعني. انا فاهم دلوقتي مش هنقدر نشيل ونبتدي نحرك راسها، فقول لها بس ما تتحركش لو سمحت. انه الحركه تاذي العين. قدامنا نص ساعه ان شاء الله. هي اتحركت كتير قوي في اثناء العمليه. اوكي خلاص ممكن. لا حول ولا قوة. ما في حركة لو سمحتي. المشكله الكلام بيحرك العين، فيعني واي حركه عندي انا بتحرك الشبكيه، فمعلش يعني خليها بس تبقى فاهمه كده ان انا يعني هي اتحركنا من وقت حتى الميه البيضاء، فيعني خليها تستريح شويه وربنا يكرمها يا رب، خليها تنام كانها يعني كاننا نايمين يعني. Can I have a forceps again, please? Okay. Okay, tell me again, please. Mhm. Indolite. Forceps and scissor, please. This forceps. Do you have the disposable scissor? You brought already 25 gauge disposable scissor, huh? Yeah. لا scissor. لا في disposable. Okay. Huh? Can you put saline and gel on the cornea, please? Saline and gel on the cornea, it's very dry. The scissor? No, I want forceps. Let me try it. The scissor, I need the scissor. Okay. This is 23 gauge. Yeah. Scissor, my scissor. Where is the disposable scissor? Why? It's in the pack that I asked for. Lens, please. انت كويس؟ اه
طبعا.
عشان بس يعني الواحد ساعات لما بيبقى شايف دم وكده بيبقى قلقان.
لا.
دي الياف على سطح الشبكيه اللي انا بشيلها، دي الياف تليفيه من على سطح الشبكه. I need flute needle, please. Or Okitone first. What is the infusion on? 25? Okay. need into light and flute needle, please. Charms.
Hello. Hello.
Okay. The infusion is on what? Okay, Tom. Diathermy, please. Diathermy.
But my sound is fine now. So we will start the course, keratoconus state of art. And the first lecture will be a keratoconus suspected silent keratoconus, Dr. Ahmed Mohammed Ghunaim. Dr. Ahmed, he's a professor of ophthalmology from Tanta University. And he will show us what's the silent keratoconus. Please, Dr. Ahmed. We heard about subclinical, or we heard about
maybe I will speak very basic this time because Ambrose, you have another advanced presentation. So
it's coming.
The most debatable term till now, with no widely acceptable criteria for their classification, is the form of thrust keratoconus and the keratoconus suspect. Form of thrust keratoconus is an eye with abnormal anterior sagittal map, with or without abnormal pachymetry map, or a normal eye in which the other eye is a keratoconus. This is very important, the family history or the other eye. But the keratoconus suspect, it's an eye with abnormal anterior sagittal map, with or without abnormal pachymetry, with the other eye, either it's normal or abnormal. Form of thrust is a subclinical disease, and it's not a variant of keratoconus, although clinicians use many other terms such as mild keratoconus, early, silent keratoconus, and subclinical keratoconus. Their exact meanings and applications are less certain. These terms are not universally accepted. The diagnosis of keratoconus is a clinical one that is aided by the tomography, while the diagnosis of form of thrust keratoconus is a tomographic. Two opinions we have. It's a completely normal cornea with neither clinical or tomographic risk factors, but this cornea is able to develop keratoconus when treated by photoablation. Sometimes we just find this case just to hold on. Okay. Or form of thrust is an abnormal cornea, so it's completely normal and will be affected when you do ablation, laser ablation, so you stop doing that. Or it's an abnormal cornea. We will find that the corneal tomography and hysteresis or both are abnormal. That's to say there is a risk of factor, but the case is still not a clinically obvious keratoconus. In history, we said that our presentation is a little bit basic. In 1961 was described as an eye with mild ectasia and irregular astigmatism by Placido Desk, which was not progressive and was found mostly in the other eye of a unilateral keratoconus or in a families with positive history of keratoconus. I think we still consider a positive family history or other eye of keratoconus in another normal eye that I couldn't touch with any type of laser. That's my opinion. In Holiday in 2008 described as when hotspot coincides between tangential anterior curvature map, which is a more accurate than sagittal map, or posterior elevation map with a bit sphere at the reference surface. Holiday described also form of thrust keratoconus when hotspot in the relative pachymetry maps show a thickness of a point in relation to normal thickness of the same point in percentage. If it's above 5 micron, it's 5%, below minus 5%, whatever. Kleiss in 2009 described form of thrust keratoconus at the fellow eye in a unilateral keratoconus, which does not show any clinical findings except for certain topographic changes. This is what we told for the new generation or the undergraduate, an area of localized steepening, mainly inferior, but sometimes maybe central or rarely superior. Inferior superior asymmetry within 1.4 to up to less than 2 diopters. Keratometry value above 47, oblique astigmatism above 1.5 diopter. Anterior segment OCT, sometimes we use it. Many authors reported that the upper mid-peripheral superior nether epithelial thinning and opposing sector thickness asymmetry and decrease in the stromal thickness, central and the nasal part in particular, without evident corneal steepening on the corneal topography might be suggestive for form of rust keratoconus. It's not that important, but we have to know about it. Also, several studies presented different corneal epithelial thickness profile analysis or multifactorial regression models based on epithelial thickness measurement, topographical, biomechanical, and or aberrometric data in diagnosis of subclinical keratoconus. For my experience in Corvus ST, I used to depend on it. The dynamic corneal response, or the CBI, corneal biomechanical index, we have shorter applanation A1 first curve, and the A1 velocity, deformation amplitude, and the peak distance are higher. The stiffness parameter at a higher concavity. The Corvus gives a lot of data, more than the Aura. So we can depend on this. We will show one of the examples, how can you diagnose it. Also the Ambrosio relation thickness and the stiffness parameter at first applanation variable were lower in subclinical keratoconus. Also topographic and the biomechanical index, which is a good tool for diagnosis, which is a TBI, differentiate healthy from non-healthy. We can see the stages here. This is the natural ingoing deformation, first applanation, ingoing concavity, highest concavity, the oscillation period, the outgoing concavity, the second applanation, and after the second applanation. These are the snapshots from the machine. And now we can find this is a normal pentacam 4 map refractive with the Ambrosio curve looks normal, but with the corneal biomechanical index, it's about 1 or 90, 0.1. This is a definite subclinical keratoconus. Some authors published that the A2 velocity is the best to diagnose subclinical keratoconus. I said we have a lot of things. The SPA1 had the highest accuracy. Others reported that the ARTH for the Vansegura index is the more significant. This is what I depend on, this index. So the deformation amplitude and the deflection amplitude and the whole eye movement, you can see it. And the amplitude between both of them is what we depend on diagnosis on early keratoconus. Recently, about 100 form frost keratoconus defined at the normal fellow eye, both topographically and tomographically, of unilateral keratoconus. Many of those showed abnormal CBI, while the other examinations of the patient were normal. Objective method, the CBI, corneal biomechanical index, and the BAD-D, Bellin-Ambrosio deviation index, and the TBI, all in one test like this, screening values in comparison to using the artificial intelligence, screening values in comparison to healthy population in green and the keratoconic in red. So you can compare both the pentacam topographic assessment with the corneal biomechanical index, both of them at the same time. This helps you to diagnose the cases with early keratoconus or silent keratoconus. These are the data we can catch from the Corvus ST, the deformation amplitude, the applanation length, corneal velocity. The machine gives us a lot of data about the cornea, and a new theory that the keratoconic corneas have a pathological decrease in the biomechanical properties. So the new theories say that initiating events could be a focal reduction in the biomechanics. This will result in a thinning as a weaker area strains more than the surrounding stronger area. If you have a weak area in the cornea, the strain will be concentrated about this area, even if it is small. That can be obvious while doing the biomechanical examination or corneal biomechanical examination. Focal reduction, the elastic modules generates greater deformation for the same load, which lead to increased curvatures. So we can hear from this curve, we can see this is the healthy, it's less than 1, it's mainly 1, and it increases when it changes in the elastic modules and the biomechanical keratoconus, and we have tomographic keratoconus, then we have topographic keratoconus, and we have the clinically manifest by slit lamp keratoconus. So we can see the curve, it's very obvious that how is increasing when you finally diagnose clinically, topographically, and tomographic and corneal biomechanically the keratoconus. Conclusion, CBI, corneal biomechanical index for keratoconus diagnosis was shown to be highly sensitive and specific alone to separate healthy from ectatic eyes. CBI might be an additional help to diagnose ectasia at a stage where tomography and topography are normal. Thank you very much.
Great, thank Dr. Ahmed. Just one comment, please, if you don't mind.
So what's the percentage of variable figure that coming from CBI? Corvus, when you are compare it to the Bell and Ambrosio, definitely you know that the Corvus, or the audience, they need to know that the Corvus is a machine, depending, as you said, that biomechanics of the cornea, and connected to the pentacam. So it depends on the topography of the pentacam. For bad, it's coming Bell and Ambrosio, it's coming from the pentacam. But for the CBI and TBI, that's the Corvus doing it.
Yes.
My question is that few patients that I had with the normal bad and abnormal CBI and TBI. So I repeat it again. It was variable,
yes,
unfortunately.
That's what I mean. It's exactly the solution, as you say. Repeat the Corvus a lot of time. Don't depend on only one exam. Even maybe not in the same time, but at least it gives you some suspect.
Yeah.
But if you can catch more than normal exam, so go on, don't worry. So that's what I mean. Pentacam is not more stability in frequent exams, but corneal biomechanical index is still an exam, need to be professional in taking data, and as you said, it needs to be repeated a lot of times. That's good.
So that's one of the important points, especially the repeatability. We need the repeatability examination.
Yes. The message I say, Dr. Safwani, is if you find any problem in the CBI, just try, and you have a normal pentacam.
Yeah.
But if I said if I have a normal pentacam and a normal CBI, so it's a normal cornea.
Yeah.
So if you want to have the final results and the final answer of your question, it's a normal cornea or not, just repeat. Maybe not in the same times. Maybe I can give the patient 1 week, 2 weeks, maybe other causes maybe happen, but I'm sure I agree with you that it's a repeatable exam and it's not only decisive.
Now, the second comment is that you agree with me fully that our definition for the frost can be said that the anterior changes, not the posterior changes. Right. We might not get this anterior changes at the time of the examination. We might have only the history, or we might have a suspicion, but there is no posterior change.
Yes, I agree.
So to conclude, foam frost, it should not have a posterior. Once it has a posterior, we will go through another another stage, another issues, which is the subclinical.
I agree
Now that's definitely another page.
Thank you.
Great, thanks, Dr. Ahmed. It was a very nice presentation. So we will go through now to our colleague, Dr. Casino. Renato, the third one. Anyway, yeah, the third one. Casino, he's here. Dr. Casino. Cosimo, sorry. Please. Your lecture. Sorry, Habibi, Cosimo. Sorry. Yeah, this is because of a lot of issues. The lunch, but you're athletes, what you can do. So what Dr. Casimo said, new era of cross-linking. Let us see what we will have in this era.
Thank you for the
most welcome.
And so you can see here the cross-linking innovation spectrum. We started from Dresden Protocol in 2003. I personally introduced the cross-linking in Italy in 2004 after a fellowship in Dresden with Professor Sperl. And then Avidro developed in 2014 the first accelerated protocol with 30 milliwatt and introducing the pulsed light treatment. It was a very good achievement. Now we have also the standardized nomogram 14 corneas treatment. And the new era of cross-linking is represented by the EPION compensated cross-linking strategies with and without iontophoresis, with and without supplemental oxygen, intraoperative supplemental oxygen. Of course, you know, all the machine adapted to this world of change. And we have a lot of machines in the market to do accelerated, pulsed light, high fluence protocols.
Yeah.
But first of all, you know that early screening and diagnosis of ectasia in children is the key of success, because the clinical decision to recommend a cross-linking is based on the early diagnosis to use this procedure as standalone. So you have patients with good spectacles or uncorrected visual acuity, so you can stop the disease or delay the disease progression without needing of refractive procedure or adjunctive procedures. You know, cross-linking is not only oxygen dependent. This is the new. We have at least 3 patterns for cross-linking. We have the oxygen-dependent cross-linking, that is the type 2, that is the most powerful pattern. But we may have cross-linking in low oxygen environment and without oxygen. It is the pathway type 1. And the reaction of cross-linking switch from type 1 to type 2 very quickly in 14 seconds during the treatment and come back. With the pulsed light, we improve the oxygenation of the treatment and we switch the reaction from type 2 to type 1. And there is, of course, a mixed type. The type 1 in low oxygen is based on 2 factors. The concentration of riboflavin, so it is directly proportional to the concentration of riboflavin and to the fluence. We are now in the era of high fluence. This is the novelty. Accelerated, this was the first study of laboratory study that showed for the first time, Ronald Kruger, that 9 milliwatt, 50 milliwatt continuous light and pulsed light achieve the same biomechanical efficacy of the glorious 3 milliwatt Dresden protocol. So it was the start to switch through accelerated. Take a look here. We have a lot of protocols now. So cross-linking today is a subspecialty. We can use in different ways according to clinical case. So we can customize cross-linking and we can combine cross-linking with different techniques. You can see the 9 milliwatt that replaced the Dresden protocol now in Europe, not in the States, not in the United States, where only the Dresden protocol at 3 milliwatt is approved. And we have the pulsed light 18 milliwatt. You can do the cross-linking in 10 minutes, 10 minutes of soaking and 10 minutes of irradiation, 20 minutes instead of 1 hour. Pulsed light 50 milliwatt, 30 milliwatt a vidro with continuous and pulse. Of course, we have the Epion with iontophoresis, riboflavin loading, and without iontophoresis, and with supplemental oxygen and without. The effectiveness of this kind of treatment can be enhanced and has been optimized, adapting fluence, first of all, then adapting riboflavin solution, increasing the concentration, and with enhancers in the solution, and with iontophoresis, of course, adapting the administration of riboflavin, driving the photochemistry in aerobic, oxygen, and anaerobic pathways. These were the first studies that I published on the pulsed light when it was introduced for the first time, demonstrating that the pulsed light induced a significantly deeper stromal demarcation line and when compared with the continuous light. Not only, but we improve the oxygenation and we induce less microstructural damage to the keratocytes. So we have less aids if we use pulsed instead of continuous lights. This was a major review that I published in the ocular surface that demonstrated the different strategy protocol and the impact on keratocytes and the depth of treatments. And this was the first study in clinical showing the study of Kruger that was lab studied. It was the clinical one that showed that 50 milliwatts works like 9 milliwatt and like 3 milliwatt in the same way. This is the study that we conducted together with the 3 schools of cross-linking, Dresden School, Zurich School, and Siena, and also with Ashraf Farmia, that is here, collaborating to this amazing project that finally replaced the Dresden protocol. So you can do now the EP-off using 9 milliwatt instead 3. So you do 10 minutes of irradiation and 10 minutes of soaking, 20 minutes to do an EP-off. This is a great achievement. What's about the thin corneas? Yes, thin corneas. We have 2 standardized protocols now. We have the M nomogram that was published in the International Journal of Keratoconus and Thyroid Disease in 2018 and was awarded in the ESCRS in Paris with the Joseph Collen Prize, and the sub 400 protocol proposed by Sabine Kling and Afezi group. I also participate in that work. Which is the difference? Both are pachymetry guided protocols, but the M protocol gives always 5.4 joule of fluence. So maintain constant the fluence independently from the thickness. You deliver the same energy of the Dresden protocol beyond your thickness, your baseline pachymetry. While the sub 400 is a decreasing fluence protocol. Use always 3 milliwatt, 5.4, and decrease the fluence according to the pachymetry. I will show here. This is the sub 400. If you treat a cornea of 250 microns, you give not 5.4, but you give 1.6 fluence. If you treat a 200 microns cornea, you give 0.72, not 5.4. While if you use this nomogram, that is based, it is a very long-term follow-up, you can treat each ectasia, each pachymetry, changing the UVA power and changing the exposure time, but maintaining constant the fluence. 5.4 in any case, so you don't lose biomechanical effect. This is really, really important if you want to stabilize your activity, because our goal is to stop the disease.
Using different powers.
Yes, you change the power and the time, but you give the same fluence.
Yeah.
This was the first study I did using very high fluences, you know, 7.2, then 10 joule, then 15 joule in EP-off. You can see 3 demarcation lines. So we showed for the first time that cross-linking is not only oxygen dependent, but also fluence dependent. And endothelium was okay in any case, so it's more resistant than we think. And this was a study that I presented in the American Academy of Ophthalmology in 2014. This is the first study I published using Epion customized with 2 fluence, 7.2 and 10. And you can see also in Epion with supplemental oxygen, in this case, with the oxygen mask, oxygen boost goggles, you can have 2 kinds of demarcations. The first is more superficial with 7.2 and the second 10. What's new in the Epion? Epion We are increasing the riboflavin concentration, you know. From 0.1 of the EPOF, we are going to 0.25, 0.22. We are increasing the fluence. This is the era of fluence. The fluence is the most important if we want to improve the efficacy of this kind of treatments. By 30%, 7.2 instead 5.4, but also up to 10 in this moment. We are using the pulsed light and also sometimes the oxygen. I changed the iontophoresis protocol, enhancing the fluence. And you can see there the demarcation line was similar in EPOF. And it was enough to improve the fluence from 5.4 to 7 and to include the pulsed light treatment instead of the continuous light. These were the medium to long-term results published in the Journal of Refractive Surgery in 2020, showing that Iontoplas is known. This protocol is the new iontophoresis, or Iontoplas works. And you can see the demarcation line and the reflectivity of the stroma you can see at OCT. This is the last publication I show you that we share with also with Ashraf. So every one of you knows the advantage. So we are working hard for Epion. We want to improve the Epion because we want to avoid infections, we want to avoid AIDS. Of course, we want to do bilateral simultaneous treatment. We have a lot of advantage doing this. We have a lot of protocol. This is an enhanced protocol without iontophoresis and without supplemental oxygen that works. You can see here, we have the same demarcation line. So we use 7.2 joule of fluence, pulsed light, high room oxygenation, and we did the soaking with the Paracel 1 and Paracel 2 solution, 0.22 and 0.25 from Avidro. So this treatment may achieve the goal also for a preventive use of cross-linking, also informed frust keratoconus, suspected ectasia, and in any case you want to do prophylaxis. This is the article that show you in +1 that the fluence of 10 is the better way to achieve the maximum effect when you work in Epi-on strategies. You can see in the graphic the red circles and the blue triangles, and you can see that increasing the fluence at 10.8, you achieve the maximum strength. These are finite element analysis biomechanical studies that we did in the Politecnico of Milan University this year. So this is a definitive demonstration that we need to work at 10 joule. The ongoing studies, yes, we are studying now. We are testing everything. We are testing with iontophoresis, without iontophoresis, and with oxygen and without oxygen. Another novelty is the chemically boosted solution. In this solution, we have ethylene diamino succinic acid that improve the efficacy. So we can boost also by chemical point of view with the riboflavin solution. Thank you for your attention.
Great, thanks, Dr. Cosimo. Any comment, any question?
No.
From the audience? Okay, great, thanks. So we will go to our colleague, Renato Ambrosio. Unfortunately, he couldn't make it and couldn't come. So Dr. Ashraf will show his presentation that it's recorded with his voice. And let us see. The presentation for Renato Ambrosio is paradiagrams and paradoxics on corneal ectasia.
Hello, I have a hand up. It's not working.
You connected to?
Yeah. It's a video. You want me to put it here? It's a video.
So until we will have, so I have one question to Dr. Kazimo. Dr. Kazimo, you said there's one comment that, for example, the changing the influence, you are using 30 milliwatts to reach, let us say 5.4 in 1 minute. To reach 7.1, you need to increase, you will keep the 30 milliwatt, but increase the time. So that's what I need all the audience to understand, that when we need 10 milliwatt, for example, we are changing the time exposure by fixing the power that we are using. Because here you used 30 milliwatt. For the thin cornea. Yeah, we are talking about the thin cornea. Great, thanks.
We're ready.
Okay, done.
Hello, I am Hannah from Rosie from
Just a voice.
We need audio from here.
No, audio is coming.
Hello, I am Hannah from Rosie from Rio de Janeiro, Brazil, and it's my big pleasure.
The sound is very low.
In the Hello, I am Renato Ambrosio from Rio de Janeiro, Brazil, and it's my big pleasure to participate in the Middle East Ophthalmology meeting with the topic Redefine Foam Fluid Keratoconus. These are my financial disclosures, and I'd like to start with a perspective understanding that keratoconus have evolved tremendously because of refractive surgery. And you can see the number of publications that have on PubMed. We have a huge increase when we had the start of refractive surgery, even incision of refractive surgery, moreover, laser vision correction. So the need for understanding ectasia, and of course, the impact of those technologies for the diagnosis, for clinical treatment, for surgical treatment, have made refractive surgery a huge ally of refractive surgery of ectasia. However, it's also the enemy. Why it's the enemy? Because we have iatrogenic progressive ectasia after procedures related to refractive surgery. Even before laser vision correction, we had incision keratotomy with radial keratotomy and astigmatic keratotomy causing ectasia. But when we talk about LASIK, the first described cases of ectasia were in 1998. Leo Seiler described first 3 cases of progressive ectasia in patients with very high myopia. And a few months later, he published a case of foam fluid keratoconus that had iatrogenic ectasia. And he defined foam fluid keratoconus based on front surface keratometric values with inferior stiffening. Interestingly, those 2 cases allude perfectly to the pathophysiology of ectasia, which is related to biomechanical decompensation, considering corneal resistance, and of course, the impact from the environment. Those are the 2 hit hypotheses described by Dr. McGee on the impact from the environment and also the genetics and the resistance of the cornea. So any cornea may develop ectasia undergoing this cycle of decompensation nicely described by Cynthia Roberts and Vijay Dupes. Interestingly, if you want to have patients to avoid ectasia, start by telling them not to rub the eye. We know that the misinformation makes the patient suffer even more than the disease, and that's the soul of the Violet June campaign. But if you think about eye rubbing, it can aggravate keratoconus or even cause ectasia. Those are not exactly the same thing. Interestingly, when you think about ectasia risk assessment, we have the ectasia risk assessment by Brad Rutherman and colleagues in 2008 that the topographic pattern will be very important for understanding the ectasia risk. But my major concern is that form fruit keratoconus should not be a topometric pattern and should not be an abnormal topometric pattern. Moreover, we'll discuss about definition of form fruit keratoconus. But interestingly, in this very nice work, we had age, which is a surrogate of corneal biomechanics, coming as a very important factor for ectasia risk assessment. Interestingly, in this nice series from Dr. Schauhorn, with over 300,000 LASIK procedures performed in 2007 and 2011, you have cases with normal pattern, even normal tomography, that had ectasia. So if you had the green is the ectasia case, you have 30% of the ectasia cases with normal pattern. Interestingly, there are patients with so-called form fruit keratoconus with abnormal tomography. You see, this patient had a stable LASIK with more than 4 years of follow-up. So interestingly, we need to go for enhancing sensitivity and specificity when you screen for laser vision correction. So what is form fruit keratoconus? First, the form fruit is something that we have from ophthalmology, from the work of Mark Hemsler, that published the form fruits on Javal, and after that with the keratoscopic, with a longitudinal study. And interestingly, a few years later, before then, we had many form fruits in medicine, including form fruit psychosis by Sigmund Freud. So form fruits is an attenuated form of the disease, is a subclinical form of the disease that may progress or not for the form plane, which is the full-blown form of any disease. And Jan Rabinovitz would say that a form fruit keratoconus is a patient with abnormal topography in normal distance correct vision in a patient that had abnormal topography. So this will be the right eye of this patient. Interestingly, in a very nice editorial from 2009, Steve Kleiss would give us the definition of form fruit keratoconus as a fellow eye from patients with asymmetric. And those are the definition that I prefer, the very asymmetric ectasia cases. In a systematic review, Dr. Enriquez and Luis Izquierdo from Peru, they did a very nice work on the literature, reviewing the cases. There is no consensus in the literature. It's also, there is no consensus on the consensus that we had, the global consensus. And so we have an incomplete form of the disease by Amsler, the mild keratoconus by Krashmer, the fellow eye with clinical signs from patients with very symmetric disease, sometimes calling unilateral, by Steve Kleiss. And my humble contribution here is that form fruit should be defined as the cases with high susceptibility for ectasia progression. And we first coined that in the academy in a paper in 2008. Interestingly, that time we were talking about cases like this one that had a relatively normal topography, had LASIK with a residual stromal bed higher than 300, the PTA is lower than 0.4, but the patient developed ectasia. Many people, when they see that they had ectasia, they will say that this little yellow in the Steve Kleiss 1.5 diopter scale will be like a very abnormal sign. But when we do that, we look at the objective ways, we can say that in the Bell and Ambrosia, we have the D score that's in the yellow zone and also an Arcmax that is lower than 400. So this is the cutoff values that we have for ectasia susceptibility. We're not talking about mild keratoconus. This patient had 20/20 plus and distance correct vision prior to LASIK. Interestingly, in the larger series, we have the BAD-D, the version 3, with a cutoff value of 1.5, having a sensitivity of about 60% for the pre-op of LASIK ectasia cases, comparing with a pre-op LASIK stable case of 3,278. So in the IS value, this is very specific because the doctors are very much obeying the rule for curvature. But here you have a very low sensitivity if you look for the abnormality on topography on the IS value. Interestingly, the BADD will give you higher sensitivity, but an advanced tomography pattern detected by AI, very nice work by Bernardo Lopez, we will have the PRFI, the Pentacam Random Forest Index, with a higher sensitivity than the BAD-D. However, we have cases that we need to go beyond that. And our idea is to enhance our understanding looking at biomechanics. So the dynamic shine fluid imaging that we have here, a nice demonstration of keratoconic cornea and a normal thick cornea, you can see the deformation response, and we look at the parameters, the deformation amplitude, we have the velocity, the shape of the disc, and all of this can be combined with the cornea biomechanical index or the Corvis biomechanical index. Very nice work by Paulo and Ricardo Michiguera. So we can separate a softer cornea and a more stiff cornea in this scenario. So we combine with artificial intelligence, with a random forest, with a strategy for cross-validation, live or now cross-validation, and this is what we have in the JRS paper 2017. So we have 94 cases with very normal topography based on a strict criteria, including the fellow eyes that were not operated, 204 keratoconic patients, only one eye randomly selected by these patients and also from 480 normal patients, and we had a very nice separation for the clinical keratoconus and a very relatively good sensitivity for those cases. So what we have here is a surrogate of corneal biomechanical structure. So we have cases like this one, 27 years old, 2015, this is correct vision, normal topography. The tomography is not abnormal, but when we see the TBI is higher than 0.3, and this is abnormal. So we can confirm based on this data that the fellow eye of this mild keratoconic patient that, by the way, had a 20/25, this is correct vision in the fellow eye. This is foam fruits keratoconus is the very asymmetric normal topography eye that we can confirm with advanced analysis. Interestingly, we have cases like this one. This was published in the International Journal of Keratoconus and Thyroid Diseases. We have a normal topography, a normal tomography, and incorrect vision better than 20/20. This patient had a keratoconus pattern in the right eye and had a great result with corneal rings. This patient was transferred by his work to London, and I had Dr. Renstein, Professor Renstein, with his great prolific examination, including epithelial thickness, the Young-Gatinelli score from OBSCAN, all coming normal. And retrospectively, we looked at the tomography data and biomechanical data. This is zero in the unilateral ectasia, not keratoconus. And this patient even came in after a few years for a follow-up. He is still very stable in the right eye. So the global consensus can come with unilateral keratoconus does not exist, but you can have secondary ectasia in any eye due to a purely biomechanical process, and that can be unilateral. Even I can say that.
So I think that we need to finish this because the time is over.
Twin sister, and this is the topography from the placebo, the topometric evaluation from the shine fluid, pretty much the same data, and the TBI is abnormal in the four eyes. And this first twin.
So great thanks for our colleague Renato Ambrosio for this comprehensive review. And now we will ask our colleague, Dr. Ahmed Saadi. Dr. Ahmed Saadi is a consultant ophthalmologist, cornea refractive in Zayed Hospital. He's our colleague and a close friend for me personally. And he will talk about the phakic IOL in keratoconic. He likes phakic IOL a lot. So in this live surgery, from all, I could recognize your voice, Ahmed. Right, Ahmed?
What is that, Doctor? Hi there, good afternoon. Thank you very much for the introduction, Dr. Safwan and the panel. I'd like really to appreciate really the invitation.
Yeah. I said that from all our colleagues, I recognize your voice. It's a very, very unique voice. Yalla Habib.
Okay, so good afternoon. I'd like really to speak about fake intraocular lenses. Yes, I do like them, but no financial. I have no disclosure related to this talk. So keratoconus is a common disease, especially in our region. In a recent paper published by the group in CCAD, they found that the prevalence of Still. It's just changed now, see? Keeps coming, the same thing. But it's okay. No, usually it doesn't show like this. Usually I don't sit it
Fine,
up.
Dr.
See,
Ahmed, because the
view
time.
here, I think it's going there. And my view is the regular view. What I'm supposed to see is going there anyhow. So I'll go back. So I will be speaking about the phakic intraocular lenses in keratoconus. And I declare no financial interest related to the stock. Keratoconus is much commoner than what we think. A study conducted by Cleveland Abu Dhabi group showed that the prevalence of keratoconus in the school boys and girls is about 2.7%, and the form first keratoconus or the suspected keratoconus is close to 20%. So this is really a huge number, and as been mentioned earlier, it's very important to look at this. There are so many, because I've been asked to speak about the phakic IOLs. There are so many treatment options. And when it comes to treatment options, there are those glasses which can be really thick. And when they are thick, people might not like them, or they might not enjoy the vision. Contact lens with different types, whether it's scleral, hybrid, but still people are not enjoying it because of the intolerance. Intrastomal rings is another option. Cross-linking with all of this, as well as phakic IOLs, and finally, deep anterior lamellar keratoplasties. Or we can use a salad of all of this. And when we use the salad of all of this, at this time is where the art of treatment of keratoconus is coming. About a few decades ago, there was one option, contact lens, then PKP. Then all of this development came down the road over the last 2 decades. So unfortunately, there is no size that fits all, including all these procedures. We have to keep in mind that patients might have irregular astigmatism. They can have a high degree of keratometry, as well as the high order aberrations. So we have to keep in mind whenever we come to decide whether to use phakic IOLs, we have to think about the other parameters that we should keep in consideration, especially the coma. So we should ask our patients whether they are complaining of high order aberrations like double vision or glare, especially the coma and the trefoil. So I'll just introduce the columnar to you. We need to know that the range of this modality it can tackle, and it was designed for myopic eyes. It was not designed for keratoconic eyes. But we are using it now more often to correct those eyes. The range is between -3 and -23, and it can correct astigmatism up to +6 diopters. So coming to manage the power. So when it comes to calculate the power, you need to keep in mind that you are taking the K readings, and the K readings, you can obtain it from different ways. You can obtain it from the autoref, you can obtain it from Scheinflug, or from your any type of topographer, tomographer. Keep in mind that
there are different ways. There is the axial, there is the tangential. So there are some errors that can come into the scene here. Adding to that, the posterior corneal power, which is altered in keratoconus. In addition to that, you need to provide the information, and the true formula that we are using, it's not really disclosed fully. We know that it's a modified vertex formula, but the calculator remains owned by STAR. And I tried my best really to find out exactly how does this work. It is modified vertex, or that's all the answer I was able to search, or even reaching that out of the count. Now we go to the sizing, which is another issue when it comes to the sizing. So the sizing takes in consideration the AC depth. It takes in consideration white to white. And the definition of white to white, we know that the cornea or the eye has different white to white vertically compared to horizontally. This is number one. The second thing is the AC depth. When it comes to white, what would be the best modality to measure it? That's the question which is causing most of the explantation. So if you do have a white to white, if you are measuring it by caliper, there is an error always. If you are using your orb scan or some of the tomographer which can provide white to white, it's another shortcoming. The other thing, some people have used the biometry or the B-scan or the UBM as compared to the anterior segment OCT. And they did not show much difference to see the sulcus to sulcus, keeping in mind that there are some anatomical variabilities. Others tried to use the visible iris. So there are still, I think there is more work need to be done regarding the sizes and the sizing. And then the plan comes as such. And we all know that a rotation of 1 degree can result in 3% reduction in your cell. So a 33-degree rotation will negate everything you've done. And again, you need to utilize a very good alignment for those surgeries. Here is the introduction. All what I need to say that in keratoconus, you can direct it. The most important two things to do is the direction of your wound. Don't overfill when you inject, and keep the pressure on your lens while it's going in, so it does not flip. So how effective is the TICL in keratoconus? In keratoconus TICL, Imara and his group, they achieved about 74% of the target refractive error at 6 months. So in keratoconus, it's less effective. On the right hand, I'm showing Dorodgar. This is a publication of which was prospective study, but was not randomized, showed that almost 100% of the patient saw 20/50 or better after keratoconus. But yet we know that to achieve 20/20 needs to be kept in mind, and the quality. So keratoconus TICL, the one I use briefly, is this. So if the patient is seeing better than 612 and the patient is having the following: K reading less than 55, AC depth 2.8 endothelial, CCT is more than 400, ECC more than 2,000, then this patient, and he is tolerating his high order operations, he's not complaining, then this patient can go for cornea cross-linking, and 6 months later, you can do the TICL. For those who are not seeing really 612 or better, then you can look into them as two groups: candidates for wavefront or topo-guided plus cross-linking, whether simultaneous or sequential. If you have good result, then you can proceed. If the vision is 20/40, then you can go for TICL. Those who have bad results, they end up going either to DALC or going backward toward their scleral contact lens. If the patient was not a good candidate for wavefront guided or topo guided, then you can consider ICR, intrastromal corneal rings. And if they get good result, then you can implant the TICL which we have done frequently after cross-linking them. If it was a bad result, again, they will go to deep anterior lamellar keratoplasty. And this is what I practice. This is there was also a big series came from Saudi Arabia looking at the outcome for the phakic IOLs in keratoconus and non-keratoconus. And overall, they showed a big improvement, almost an excellent improvement, more than 95% of the target refraction in the non-keratoconus eye, while in the keratoconus eye, most of the patients improved, but still there was some residual, and the numbers are shown. The causes of ICL explantation, I want just to bring to your attention that the volt was the most common, the high volt or low volt. Everybody speaks about a volt of 250 microns to 750 microns, but you have to keep in mind, anything below 150, you have to explant because it will cause cataract. If it's less than 150, don't do it, just explant it with something else. And keep in mind that the cataract will develop, and as well as the refraction. In keratoconus, there are more refractive surprises compared to non-keratoconus. So the take-home messages, fake IOLs, Vizan talking about, are effective and safe in keratoconus, can be used as single method of treatment or can be mixed with other options to achieve visual rehabilitation in keratoconus. High order aberrations might be an issue despite the refractive result. And the most common cause of explantation is the volt due to sizing issues. Better method for precise sizing is still to be found. Thank you very much, and I'm ready to answer any question.
Thanks, Dr. Ahmed. And I have one comment, a comprehensive presentation, but there is one comment that we need to say. What's the sharp cut for your side or your opinion that we need to implant an ICL for a keratoconic patient? After what, or what's the time after the stability of the
for me, 6
cornea?
months.
Cross-linking or sorry?
For me, 6 months.
Wow, 6 months.
Yes, I wait 6 months. If the patient is stable, I go with it. Yeah.
Okay.
Especially, I personally don't practice epi-on. In these patients, I always practice epi-off.
Yeah, no, we are talking about classical epi-off.
Yeah, epi-off. Yeah.
Epi-off and 6 months.
6 months.
Now I'm waiting for 1 year, and I have patient of regression after 1 year.
Well, I agree. The chance for any cross-linking, we know that cross-linking is successful in 93% of the patients if we follow them up to 7 years. 7% will still regress.
Especially
But
for the
my chance-
low age. Those with from 20 to 25, they have a higher chance.
Well, I think I agree with you. There might be some people who would like to wait longer. And this is but I'm not aware that there is a very strong evidence that it might change, but it's a very valid point. I take your
second
point.
question is that what you will do
for
you have a patient, you wait for 1 year, it was very stable, patient very happy with the glasses, with the spectacles, you decide to do an ICL and you did it, and after 1 year or 2 years he returned back to you with a regression.
I did ICL already.
Yeah, for sure, ICL in 1 year. 1 year stability, patient was very happy.
Still, okay, so you have to cross-link them again. And these patients, you'll keep following them up closely, especially at the first 2 years. Though I think I will cross-link them again. I will not explant them definitely, unless it's causing high pressure, cataract, or high volt. And because I'm quite confident that this patient has improved a good amount. So cross-linking again is advisable. You can recross-link them, especially what is your definition of progression? Are you talking about one diopter of care reading? Are you talking about change in cornea and corneal thickness, or are you talking about change in a Poussier float?
You know,
so it depends how
I'm following a lot of protocols. So all the nomograms that you are thinking about it's there. It's change, thickness, thinning, K reading more than 2.5 diopter, and the astigmatism changes and the visual acuity changes.
But what is your start point? Is your start point you are comparing today with the pre-cross-linking, or are you comparing it with the day of when you implanted, when you thought they were stable? So again, here
patient have from 6 months regularly every 6 months. So every 6 months
Where
we
is
are
your
reading,
start point?
and
You
there
are
is a
comparing to
review
what?
for the last 1 year start changes. And this
Understand,
changes.
but the changes, are you what is your, so the changes, the one, let's say you hit those numbers, when did you hit them compared to when you implanted? Or because after your wound, you create wound of 3.2. So you might induce astigmatism. Again, your anterior float might change.
I understand that. So we have a record on a Excel sheet showing all the data from the start to the end.
Whatever it is at that time, I'll do cross-linking. If the patient is progressing, I'll do cross-linking.
So I did. And what I aimed, flattening.
Flattening. Well, flattening is expected in some.
Exactly.
There are
so
enough
here
reports.
I shift the story to hyperopic shift.
Yeah, I see.
Yeah.
Then you have
So
to
now the question is that my decision is then definitely we did a thorough examination. We are doing a thorough examination, especially when there is a shift. The shift, especially in post cross-linking, it might be related to the lens. And that shift, myopic or hyperopic, and that was what I'm expecting. It was corneal changes that's right, flattening, but the cataract that we have it as a posterior subcapsular cataract, it was the one. So definitely we solved the problem here. The decision is very clear. So the cataract solved the problem. So,
yeah, then
but I do agree fully with you with that. This is the strategy, how we are following the patient after the ICL. Great, thanks. Sorry.
Yeah. Take the history, take the stage from you did the cross-linking for the patient. So it's an epithelial on or off? Off. So at least the first 3 months to the epithelium to return to normal. So we are not going to rely on the pentacam in the first 3 months. So it's only 3 months for 6 months. So you are going to do a pentacam after 3 months, actually after 3 months, and epithelial mapping for sure to detect that the epithelium is already refashioning again. So if we wait for another 6 months to do another pentacam epithelial mapping, it's okay. To do a ICL, before the ICL, do you try hard contact lens or contact lens first to make sure that the patient with the contact lens is going to see better, or you go directly for the ICL?
Well, for the patients, definitely, I don't jump to TICLs. I mentioned earlier, patients might be intolerant to contact lens. They might see excellent. We all know that anybody with irregular surface, they will never have a good quality of vision like they do with hard contact lens. So this is always, I'm talking about now beyond this, whether the patient is intolerant or the glasses are too thick. So definitely contact lens comes earlier before the decision of going for ICL. Once we go to the ICL, then I know that I have exhausted my conservative measures. Would be that's why I've mentioned that those would be.
I mean, if the patient see well with the contact lens, so you are going to with the ICL.
One indication might be this, definitely. Other indication, even glasses. Some people are intolerating their glasses because they have a high astigmatism of 6 diopters or anisocoria, anisometropia, all of those. But this is not my first choice.
So great, thanks, Dr. Ahmed.
Thank you.
And we will go to Dr. Ashraf Armiya, our colleague Ashraf Armiya, and he will talk about the cataract that we talk about it. Cataract surgery in keratoconic patient. That's a little bit challenging, Dr. Ashraf.
Yeah.
Do you think, Dr. Ashraf, if patient get better with the hard contact lens, hard vision, a better vision with the hard contact lens, he will have the same vision in ICL?
Yeah, this was the aim of my question, Dr. Ahmed. So if
I will take time from him, not from your side. Yes, please.
If it's hard contact lens fitting good and the patient going to see good, so the retinal image will be okay. So I'm going for ICL. But if he tried the hard contact lens and the vision was not improved, so he's not going to improve with even the ICL.
Yeah.
This is the aim of my question. Yes.
That's right.
Yes. This
But
is-
we
yes.
but we
This is
need to
what
know
I-
one fact that the hard contact lens vision, the vision that obtained by hard contact lens will improve all the high order abrasions, everything. So that will not be the vision that you will gain it when we will put the ICL.
Yes, this is
That's totally different. Well, that's what I'm saying. The vision in the glasses that you have is the same vision that you'll have it. Especially here, we can correct the high astigmatism.
Yes.
Yeah. Yes, please.
Before I start this presentation, it's a debatable presentation, and what I'm going to say is going to be debatable forever.
No, we need to know
Yes,
your
from
experience,
the
Dr.
start,
Ashraf.
Dr. Safwan
Your
will be-
experience, my
So,
dear.
Because
You
every
are
time I
you
do a
are the
presentation on
expert.
this issue, it is a debatable presentation, okay? So I don't have any financial disclosure, but these are my company that I'm consultant or speaker to them. So if we look, we are going to find that although nearly all patients will eventually develop visually significant cataract, this trend to occur in younger age in patients with keratoconus compared to the general population. And this was approved by this study, it was in 2017. And the cataract surgery in patients with keratoconus is challenging due to the difficulties associated with the interpreting keratometry readings, determining the amount of astigmatism, measuring the axial lens, and thus obtaining the accurate IOL and the effective lens position. So if we think about corneal ectasia, which is keratoconus is a part of corneal ectasia or a steep cornea, so it's a progressive steepening. So progressive corneal ectasia leading to myopia, irregular astigmatism, wide range of case values in a small area, and this leads to changes in the AC, which makes more difficult to calculate the effective lens position. This is the problem in keratoconus. So again, corneal ectasia, keratoconus part of corneal ectasia, post-refractive surgery ectasia, it's part of corneal ectasia. They are resemble each other, and so the IOL calculation, we will think in all different corneal ectasia as only one entity. So if we are looking for stability before you are doing cataract for keratoconus, should calculate the lens when we are confident with a corneal stability. Never calculate a lens in a fluctuating cornea. Advise patients about the small risk of corneal decompensation, which can happen in these corneas because this is not a normal corneas with ectatic progression after surgery. Corneal ectasia is progressing, so you might want to cross-link the patient after cataract. And the rule, to rule out the progressing ectasia, we recommend to perform at least 3 corneal tomography 3 to 6 months apart from each other. I stay from 1.5 years to up to 2 years before I do any cataract or even phakic IOL. At least 2 years, because the effect of cross-linking can continue up to 2 years, and some papers said up to 7 to 10 years. So the challenging in this is IOL calculation and the intraoperative tips. This is what I'm going to highlight. Challenging in biometry, 3 basic measures are included in all different formulas: axial lens, corneal power, and estimated lens position. So the steeper cornea and the off-centered apex make it difficult to obtain an accurate biometric readings. Why? Because the ectatic eyes have higher axial lens and deeper anterior chamber, this making the effective lens position harder to estimate. And as the apex is off-center, it might be not the visual axis. So this means that the corneal case measures at the apex of the cornea might not be the true case that you are going to calculate your IOL. So we have to decide what optical zone we are going to use. And this is the aim of the pinhole pupilloplasty that innovated by Amar Arprea to decrease the pupil as much as you can, so you can overcome all these challenges. And allows, and always keep in mind that there is no specific rule to decide how large this zone can be. So this very nice study, it was at the American Academy at the 2017, and the results, it was using the different formulas and using the IQ from Alcon, and they calculated that the overall, the Ballet Universal 2 formula had the lowest prediction error for the 2 IOL they were using, and you are comparing all different formulas in this study. But another study was perfectly show that the patient with keratoconus has this very nice scheme if you want to take your decision. So patient with keratoconus, it was 2019, and they put this very nice diagram. If you have a history of corrected distant visual, good, so should look for the manifest. If the manifest and the topographic axis equally, so go for cataract surgery and toric IOL. If the manifest is not with the topographic axis, go for cataract with monofocal, and you can enhance later on with the toric ICL if it needed. If the history of low corrected visual acuity, so you should regularize the cornea because this is an irregular cornea by the ICR, then do the cataract surgery monofocal, and you can enhance by the toric ICL if needed. And the advanced ectasia, so it's no need to do cataract only. You should change the cornea because this is not a normal cornea. So phacoemulsification with implantation of toric IOL has shown to be safe by this last publication, 2016, and also benefit from this treatment, but it should be a regular astigmatism. I'm going to, so this study, it was in 2020, and they used multiple IOLs and different formulas, but in this study, they were using a new formula, which is the Kane formula, and used with different IOLs, and this is how they calculated the different, with the different IOLs, and found that calculated by this Kane formula, and this is the calculator formula by the Kane formula. But to use this, you should put in your mind this table. If it's stage 1, don't adjust choosing the refractive power of your patient. If it's stage 2, make the post-operative refraction from minus 0.75 to 1.5 diopters. If it's stage 3, go for more myopia from -2 up to -3 to nearly reach your predicted target. So in this very study, it was 2020, the last study about cataract with keratoconus, they said that the Kane keratoconus formula with the most accurate formula in this series. After the Kane formula, you can go for SRKT, but the Kane, then the SRKT giving the best results post-operatively. And if you want to calculate the astigmatism for cataract surgery in keratoconus, you should go at least for 2 either the Cassini, Keraton, Lenstar, Pentacam, at least 2. But in this study, they compare the 4 in this study, and there is a significant correlation between the total corneal astigmatism and the ACA, whereas the posterior corneal anterior corneal astigmatism, whereas the posterior corneal astigmatism can be predicted from the anterior corneal astigmatism measurement only. And also in this study, they concluded that that the posterior corneal astigmatism can be variable in eyes with keratoconus and correlates with the total corneal astigmatism. I'm going to pass this also. So, high astigmatism or regular astigmatism, whatever you are going to do, you are going to leave an astigmatism. So they thought that if they put the monofocal or at least part of the astigmatism, they put the IOL, then they put the pinhole IOLs to decrease their post-operative astigmatism, or to make the patient does not complain of the residual astigmatism, by this way or by the pinhole pupilleplasty, which I don't have this IOL in Egypt, but I do a pinhole pupilleplasty in all my cataract patients with keratoconus. The results are very good. I'm going to highlight some intraoperative tips in cataract with keratoconus. You should know that early keratoconus, it's normal cataract, but in severe keratoconus, steeper meridian, with a steeper meridian, the postable cornea scar can be troublesome. So when you choose where to go with your keratome, you should be away from the cone first. And the cataract main incision site should be planned during the preoperative examination on the slit lamp. You are going superior, upper temporal, or temporal. Very important to choose before the operation. Also, in the presence of cornea scarring, which is common in advanced keratoconus, the main incision should be placed 90 degrees apart from the scar. And also, well-constructed two-step sclerocorneal incision is advisable to reduce the risk of post-operative wound leak. And for me, I take a suture, even if I'm going for 2.2, I take a suture. Because this is a fluctuating cornea. Very small trick that in steep keratoconus or advanced keratoconus, if you put a viscoelastic on the cornea, it will go to regularize the view, enhance the view system for you. And this is what I'm said, the EMC. After marking the corneal incision, even in good read reflex, use staining of the capsule, because also you are going to find that there is a different reflection of the capsule. Staining make it more easy for you. So my take-home message, in keratoconic eyes, optimizing the IOL power calculation is certainly a vital importance to improvement of the surgical outcome. And in keratoconus can cause multiple sources of keratometric and biometric errors, especially in severe cases. To obtain the best outcome, surgeon must take an extra time to address the complexities of the cornea, utilize the best technology available, and make careful of pre-operative measurement, adjusting the refractive target based on the calculation made with multiple formulas, best scan formula nowadays. In keratoconic eyes, optimizing the IOL power calculation is certainly a vital importance. Keratoconus can cause multiple sources of keratometric. Okay, sorry. And just, I want to highlight this book. It was a huge work between me and Cosmo and 38 international speakers from East to West, give everything about keratoconus. And we put a title for this book. It was Current and Future State of Art. I hope everyone can get this book. Thank you so much.
Great, thanks, Dr. Ashraf. It was a comprehensive, interesting lecture and presentation for cataract and keratoconic. So great, thanks for you. Now we all know that this formula is working, but still, yeah. So always we are advising the patient and asking them that there is no a key for a 6/6 or an improvement of the vision in an unusual way. There is a high order of patients that we will not cover it, and there is a lot of surprises. Now, when we are saying the grade 3 to change the residual refractive from -2 to -3, just to overcome the hyperopic shift, and believe me, still we have a hyperopic shift. Anyway, we need to go to the last speaker, Dr. Kazimo, and he will talk about the things that having a lot of debate. The PRK cross-linking up to date. So when anyone talking about the PRK and cross-linking, especially the spontaneous, simultaneous, whatever you need to say it, or the sequential, the debate started. So you can see that one saying that no, it's sequential, and the other will say no, that the spontaneous is. So let us see, Kazimo, what will say.
Yes, I stopped the video because we have.
And you don't know what I prefer.
You want to see the video? This is for an homage to Dubai. Okay.
He did it for me. Okay.
I don't know if. Okay. If you can have the volume of the video.
Just the volume of the video.
The volume.
I think that he need to connect it.
Works. We have no difference to answer to between free if the sequential or postponed. So, cross-linking has paved the way to combine BTK or PRK corneal remodeling for these keratoconic patients. This treatment started about 15 years ago. We have more long-term data published in the literature, so it is not a novelty. The novelty is how to do the best way. Where we are, the indication, where cross-linking meets corneal remodeling with laser. We are in stage 2 general patients who has intolerant to contact lens and want to improve their visual acuity with spectacles correction. It is important, this is not refractive surgery, it is therapeutic surgery. Okay, we don't want to remove spectacles. We want to improve spectacle corrected visual acuity, improving the quality of vision, regularize the corneal shape, reducing the corneal aberration, reducing the nocturnal fluctuations that these patients have with spectacles, consuming the small amount of tissue, giving a chance also for a new contact lens refitting, avoiding or postponing donor corneal graft. A lot of literature. John Canellopoulos started together with George Kimionis, first studies. Yes. But this was a very good flow chart from George Kimionis published in the Journal of Cataract, a Journal of Refractive Surgery. And you can see that if we have a stable or stabilized keratoconus, or we want to stabilize keratoconus and to include also TPRK or PRK, we need first to prescribe to our patient contact lens. If patient doesn't tolerate, we can check if this technique is indicated. Take a look to long-term results. These are the 10 years outcomes. And the 10 years outcomes showed no adverse events, no complications, a gain in corrected distance visual acuity more than 2 lines, and uncorrected visual acuity in 45%. Despite these results, you can see how many protocols we have. The Athens protocol, the Cretan protocol, the CCR, the Topoliink from Israel, CCR Tel Aviv protocol, so the Sterix protocol we have published. So what I mean, there are some common points. 50 microns of stromal ablation generally in all the studies. Optical zones from 5.5 to 6.5. the minimum corneal thickness 435 average, from 300 to 450. Generally not in pediatrics, but patients, not pediatric patients, okay? Stage 2 and 3 borderline.
But actually that's the study was saying.
Take a look to this. We have a gain of average 2.3 lines. But take a look to the cross-linking protocols, each different. So we need a global consensus and guidelines, okay? To answer to your question, if indicated, even patients already cross-linked can be treated with topography-guided or wave-guided excimer laser ablation. So you can do simultaneously or sequentially. We don't have significant difference in this group of patients. You know that you don't use the Dresden protocol in this treatment, no Dresden protocol. You need accelerated protocols, pulsed light protocols to avoid and minimize AIDS. Which was the complication? The complication for the full anterior regularization was the overcorrection. In the literature, the overcorrection was reported, but thanks to ray tracing, finally, we can calculate the posterior surface, so we can avoid this kind of complication. I showed you this slide yesterday to show that if you regularize in full the anterior surface without taking into account the posterior contribution, you go in overcorrection. If you take into account the posterior contribution, you eliminate the small amount of coma to compensate the posterior surface, and you don't go in overcorrection.
Here, there's one important thing that the
Yes.
that they were against the treatment. They are just using that hyper or overcorrection because of the flattening, not because of the overcorrection.
Yes. If you take a look to these maps, this is the anterior retracing map, but if you can see the posterior, you need to regularize on only the small amount of surface. And you can perform this transepithelially. These are our studies. We have the paper in press. And these are the results using the ray tracing technology. You can see the pre and the post. The ray tracing is superior to all the other platforms, actually, to achieve the best spectacle corrected visual acuity and also the uncorrected. You can see the gain is 3.5 Snellen lines and corrected is 4.3. You can see here, we gain more than 4 lines in about 70% of treated patients in correct distance visual acuity, in about 40% of patients for uncorrected visual acuity. We don't have any line loss. We gain 3 lines or 4. This is really important. These are all the data. You can see the Kmax reduction, the median pupillary power reduction. These are the two groups, sequential and simultaneous. Of course, you can see we have no statistically significant difference between these two groups, so you can do both. These are some clinical cases. You can see the pre and the post-operative point spread function. This, you can see the retraced ablation. Again, another case, the pre-op on your right and the post-op on your left. Take a look to the point spread function. It's amazing. Take a look to this. But I want to show you, we have stability in the long-term follow-up. This is a 4-year follow-up, and you can see the minimum corneal thickness. But I want to show, in particular, the posterior corneal surface, the posterior elevation that I use as criteria to establish if these patients are stable or not. Take a look to the posterior surface. These are all long-term follow-up. So another important thing, don't use mitomycin. No mitomycin in these cases after cross-linking, because you increase the probability of AIDS, don't reduce the probability of AIDS. And this was brilliantly demonstrated by Shadi Awad. So these are the indications. Thank you. Thank you very much.
Great, thanks, Cosimo. So here to summarize, sorry, yeah, please. Yeah, we can. So to summarize that the use of the laser and the cross-linking still debatable whether it's a simultaneous or a sequential, but there's two important facts raised with the advancements of the technology for the tomography, that the total corneal power reduce all the consumptions of the tissue that we were using it to treat the anterior instead of the total corneal power, and the use of the mitomycin C was not a correct use because it was one of the causes of the haze or increase the haze, because one of the important issues is that hyperopic shift and the haze of the cornea.
Yes, because you stop the myofibroblast to come into the state of keratocytes and to clear the collagen.
Exactly. So great thanks. So great thanks for everyone. And we will end up this session to allow for the next session to become. Thank you.
If then we will pull two. Yes, hello. After a big line. Hello, hello. Good evening, dear colleagues. We will start move now from refractive to little bit posterior area. I think there is the superior. I think surgeon, they are vitreoretinal surgeon, the most superior people in ophthalmology, right? Dr. Awadallah, I know you like this because they can do everything. They can go for glaucoma, they can go for refractive, they can do anything. But cornea, they cannot go to do vitreoretinal anyway. أكيد صح يا دكتور محمد. Okay, thank you very much. I would like to thank the co-moderators with me here, Dr. Nadeem Al-Hussein, Dr. Osman Mahmoud, and I would like to invite Danish with us, Big Boss, our guest of speaker, Dr. Danish. And our speaker is the first one, it will be Crystal Meyer. Yes, so today it's my best surgical video. We'll have a 4-minute presentation, then we'll have a 4-minute for discussions.
So, okay. Thank you very much. So I will start by a video that actually I got last night because I really got a shock. My fellow sent me this video because he had an Osidex implant that was fallen into the anterior chamber, and I was not there. And I recommended him a maneuver that we did a year ago, and I want to show you this in advance. So it's just a 30-second video. You see, can we elevate the tone? If there's a tone also available. So he's, and you would hear his Austrian accent. So this patient, he just talked to the ladies to look up and to look down. And you see how he can manipulate the Osidex implant. So there was an opening in the iris at 11 o'clock, and you can see how he was positioning it here. So this was already close. I was amazed when I saw this last night, and you can see that he's manipulating the Osidex to the hole. Now you see he's at the edge, and now you see that within 30 seconds, it's again in the vitreous cavity. So he was lucky that, that this implant was at the posterior pole. But now I want to start with actually my video, but I think that was really worth to show you at this time. So this was also an emergency case I did with my fellow a couple of months ago in Davos. So he was a constructing worker for the ski slopes, and he got a foreign body into his eye. What I noticed that there was really a very tiny opening in the cornea and in the anterior capsule. So my fellow said, well, let me do the phaco. And I said, oh, it would be a pity if we really would damage the anterior capsule. So I got reminded of my fellowship when I was at Duke with Cindy Toes, and there the vitreoretinal surgeons, they performed cataract surgery from the posterior part, so they removed the lens. So my goal was in this eye to maintain the anterior capsule, so when you later have to inject silicone into the vitreous cavity, that you have a plane, a cleavage plane between the anterior and posterior pole, and you don't have silicone oil that's coming anterior. So you see very nicely the anterior capsule is still in place. You see the huge rupture in the posterior part. So I assume that the foreign body came to the cornea, to the anterior capsule, and then it started spinning in the lens. And luckily, it also went to one, not into the center of the macula. This was a young patient, and we started vitrectomy, so it was really difficult also to detach the vitreous from the retinal surface. So I used a pick to release it. I don't know why it's not so sharp in this case. And there you see, so luckily at the arcade, there was the fallen body in the retina and in the sclera. And after I did a meticulous cleaning of the periphery, because I think this is very important, especially in young patients, we added 360 laser just to secure it. And before I extracted the foreign body, as Ferenc Kuhn taught me, we applied laser around the foreign body. Also to avoid bleedings, we added now some Decaline to seal the posterior pole, and then we removed the interocular foreign body. Initially, we tried to also to remove it to the anterior part, so in order not to dilate the sclerotomy, but this was too difficult. And so when this happened to my fellow and it fell down we want to avoid it in the second place. And we removed it to one of the sclerotomy, we enlarged it. And afterwards, I injected silicone oil into the vitreous cavity just to be on the safe side in this patient. He was a young patient, and I was fearing a PVR reaction because this was a huge trauma that was going through the retina, through the choroid, deep into the sclera. The silicone oil was filled up to the anterior capsule, and by the end, we even were able to implant an IOL into the quote sulcus, because the posterior capsule was still, it was a young patient, so it was a very stable situation, and we were able to, as you can see here now, to implant an IOL. We were capable to do an IOL master prior to surgery in this eye, and we also can compare it in the calculation with the fellow eye. So this really went well. And my major concern was that he would develop PVR in the postoperative period. So this was 8 weeks afterwards. You see some scar formation, basically on the anterior capsule, on the opening towards the anterior segment. We didn't have any prolapse of silicone into the anterior chamber. And what I also learned from my chairman, Peter Kroll, that it's quite easy in these eyes to remove the silicone oil by just making one sclerotomy to aspirate the silicone oil, and you can use anterior chamber maintainer for the infusion. After we removed the silicone oil, we also added additional laser and an ILM peeling because we saw that after surgery, yes, there was a good vitreous detachment achieved, but still there was some mild epiretinal membrane formation in place. And to be on the safe side, we also removed this after the silicone oil removal. And so here I show you the OCT prior to the OCT, the oil injection, the oil aspiration, 8 weeks after surgery in the horizontal OCT. And this was 4 months after the silicone oil removal in this young patient. We were able to achieve a vision of 20/50. Thank you very much.
Hi, thank you very much for such a lovely video and certainly very challenging cases. I just noticed that I might be wrong. You put the silicone oil first, then you put the intraocular lens. Is that right?
Yes.
I mean, why is that? Because normally it's not so easy, and normally you put the lens in first.
I know. It was quite a stable. Well, you know, if you put in the silicone, you already have a tunnel that may be difficult. And in this case, the capsule, the anterior chamber was so stable. I mean, otherwise I would have done it in the opposite direction. You can also do it, but I mean, we never had silicone oil in the anterior chamber because it was just a tiny opening. I don't know.
And what was the strength of the silicone oil? Centi-Stoke, was it 1,000? 5,000.
Now we'll go for the next case. And thank you so much. Our next case will be presented by Dr. Amar Farid.
Good afternoon, everyone. Thank you, Dr. Amri, for inviting me for this meeting. Today, I'm going to speak about one case. It's okay? So this is a female patient, age 42 years old. She's diabetic. She presented with decreased vision. It's not stable. Okay. She presented with decreased vision in both eyes. She's diabetic since 20 years. She is now controlled. She had cataract surgery in both eyes. She had vitrectomy in the left eye since 1 year ago. And she has a counting finger 1 meter in the right eye and hand motion in the left eye. The pressure was okay. Anterior segment was unremarkable. This is the examination of the right eye. As you can see, there was an epiretinal membrane with traction retinal attachment in the right eye. Left eye, this is after surgery. She has also an epiretinal membrane with hemorrhage and a big hole in the retina. As you can see, this was under silicone oil. So I decided to make a surgery for her to fix the left eye first. It's quite a long surgery. Started with the removal of the silicone oil, then trying to remove the PVR and the epiretinal membranes from over the retina. There was still some silicone oil under this big hole, and it was sucked through this hole. As you can see, this is the second wave of removal of the silicone oil. Then we're starting to remove the epiretinal membranes. As you can see, there was extensive epiretinal membranes all over the retina, extending to the far periphery of the retina. I make it quite fast because it's a long surgery. But as you can see, we're trying to remove the epiretinal membranes step by step and very meticulous, and we don't take your time in these cases to remove all of these membranes because it is done before, so you are not sure what's left from the vitreous before. Then the second step after this was to do some trimming of the left vitreous in the periphery. As you can see, there is still some vitreous in the peripheral area. And also searched for, the decision was made to to start using both hand or to use my bimanual technique to remove some of the membranes, attach it to the hole and attach it to the subretinal areas as well. Trying to clear all the PVR from the surface of the retina. There was also some subretinal membranes as well, and then it was a trial to make for air fluid exchange to try to put the retina back in place, as you will see now. This was the trial, but as you can see here, there is some air under the retina. It means that the retina is too short that you cannot put it back. So I decided to make first the ILM peeling, and after we will make the posterior for the inferior retinectomy. So I started to put the stain and then do the ILM peeling. It took quite some time also because the retina was detached, but it was managed at the end. In these cases, of course, it's very important to do the ILM peeling because they're expecting if you left it, you will have more and more PVR after and more epiretinal membranes. Then the next step was to do the retinectomy. So through the hole, extended the hole a little bit, and we continued to do retinectomy to the inferior half of the retina to release every traction in the retina and put it back. As you can see, the retinectomy now is completed. Then you put some PFC to put the retina back in place the edge was cleared from any rolled edges. The retina now is stable in place with no traction over it. Then endo laser was done to the retina. And of course, we have to use silicone oil in these cases. So silicone oil 5000 was used in this case. The retina now, or the lab is back in place.
To him this one because that one he is moving his
And silicone oil at the end of the surgery. So this is 2 weeks after the surgery. The vision improved actually to 0.2 for this patient. And 6 weeks after the surgery, there was fine a little bit of epiretinal membrane. I think you're hearing me. Okay, do you hear me now? All right. So the vision improved a little bit to 0.3, and this is the OCT. You can see also that there is thin retina, but the vision was okay. This is here after 1 year from the surgery, and the silicone oil was removed, and the patient with the vision completed to be good to 0.3, and with the stable BDR. Thank you so much. Yeah.
Removal of the silicone oil. Did you remove the residual membrane which was there at the posterior?
Yes, I removed this membrane at the time of the removal of the silicone oil, but luckily when you do this, the eye limb peeling was very important. Otherwise, this membrane would come over the macula. So it's a very important step in these cases to remove to do the eye limb peeling, of course.
Yeah, and I think true stability only comes when you remove that membrane and remove the silicone oil.
Yeah.
Till that time, you're not sure whether you're stable or you're not stable. It could detach again unless
Yes.
you remove that membrane.
Yes, I removed it as well.
Great case.
Yeah, thank you so much. Thank you.
You did most of this work under air, including the eye limb peeling?
No, under fluid. All
Because
of it
there was
under
air,
fluid.
or you put it back again.
No, under fluid. All of it
The
was under
retinectomy
fluid.
was under air.
Yes, the retrorective was under fluid. No, I went back, of course.
Okay.
It was just a trial to do air fluid exchange to check if the retina will go back in place or no. But when we found the air going under the retina, I went back to fluid and then continue the surgery, of course, not under air.
We'll move on to the next video, Dr. Hassan Bahrani. Dr. Hassan.
Sorry about the typo mistake. So how do I move forward? It's a video. So this is a case of, it's a family actually of multiple patients of same family. So this patient presented in 2021. He underwent a multiple session of laser retinopexy for multiple retinal capillary hemangiomas. Actually, all of them resolved except for this very large one. And so he had a macula threatening TRD. And what I did for this patient, he's a 13-year-old patient. And of course, in these cases, you have to make sure you have to delineate and remove all the hyaloid. Was presented with this very tight fibrotic membrane over the retinal capillary hemangioma. And I was wondering that I have to remove this capsule for the retina too. But then while I was doing that, I encountered this very severe fetal vessel hemorrhage. So then I kind of thought maybe it's better just to dissect around it, shave the vitreous hyaloid. I cauterized the fetal vessel in this case. And then I went on lasering the retinal capillary hemangioma and being conservative in the first case. And then while lasering, those fetal vessels are very prone to bleeding. So anyways, we cauterized this again, and I was able to achieve good hemostasis with this patient. And that was the end of this first case. And I injected some anti-VEGF. But post-operatively, he came back with vitreous hemorrhage and inferior RD. So I had to go back again. Obviously, it bled from the same fetal vessel. This time I had to kind of make sure that I do, I guess, more aggressive management, peeling the ILM, fovea sparing ILM membrane peeling. And when I checked the case, there was no way this retina was going to be flat with just leaving it that way. So I cauterized all the feeder vessel, and I went at the edge of the feeder vessel, and I decided this time that I needed to do retinectomy to flatten this retina. So I went around it, and there was very thick viscous subretinal fluid underneath this obviously chronic retinal detachment. And then I proceeded with end retinectomy of this retinal capillary hemangioma. I think the first surgery was helpful in making sure that I have limited bleeding intraoperatively in the second case. There was a lot of subretinal fibrosis, subretinal bands. Here I got another bleeder this time. Of course, you have to do everything with similar to your regular retinectomy cases, making sure you have to shave all the interior retina, all the hyaloid. I think I paid too much attention to this area and maybe didn't take too much attention to the nasal retina. So silicone oil, of course, in this case, and he did actually quite well. And then so he was healing quite well. And then on his silicone oil removal case, I noticed a nasal RD. So I did a barricade laser retinopexy, and I proceeded with. So that was kind of good because centrally he was fine. This pathology was peripheral, and I proceeded with just making sure I peel all the, and I always peel before I do any retinectomy, because sometimes you see the membrane here is extending beyond the retinal detachment area. And at this point, I decided, of course, to do the retinectomy to this area. It was a stable, RD. And then I also did chorioretinectomy. And I have a lot of experience doing a lot of foreign body cases and doing chorioretinectomy, and they just do so wonderful, actually. So in this case, I went ahead and I did the chorioretinectomy. This is just a very extensive fibrotic membrane. I will also shave this RPE or residual pigments, which is the scaffold for possible future PVR formation. So this is the chorioretinectomy. And the wonderful thing that the retina was stable, so I didn't have to worry about that. And a fluid air exchange, silicone oil, of course. He did have some cataract, posterior subcapsular cataract, but thank God my work was perfectly at this point. So I think he's doing very well, actually. Thank you.
That was a great video, very aggressive surgery. And that's actually the problem with these angiomas, because they have a lot of anterior traction. So would you consider an alternative of putting a buckle in the first space and doing cryo of that area? Because after you've removed the traction, first of all, it's difficult to remove that traction completely, but it's, as you said, it's more extensive than it looks. It's sometimes on the sides, it's a lot more than it looks, and that's why it can take time to settle. But putting a buckle in that entire quadrant can actually, and then doing cryo for that lesion can actually help you to get a more lasting.
Very good point. Actually, when I was intraoperatively, the second case, I was thinking about that because I saw a lot of fluid, and then, you know, it was a little bit posterior, to be honest. It was not a peripheral retinal capillary hemangioma. It was a little bit close to the posterior pole, maybe at the edge of the posterior pole. So I think it's a call that can go both ways. It's a call that can go both ways. Having a buckle, I think I do a lot of buckles, so I'm prone to do buckles. And maybe if in this case, I wouldn't, you know, I have a 240 buckle. So maybe a 276 tire buckle would have worked amazingly for this case. So retrospectively looking at this, that probably would have been the best option, a 276 with a 240 band. Yeah.
Thank you, Dr. Hassan. This is very, very nice surgery, actually. We have do not bad number of those cases. And what we notice is the patient, the surgery is difficult, but the issue is the PVR post-op. And what surprised me is the PVR came even after buckling. So I start doing what he proposed of start with the buckle. Then the PVR came a lot. So I get obligated to do what you do at the end. What we should understand is buckle can help on compressing the retina, but it will not close the von Wipple disease or the retinal hemangioma that you have it. So either you have cryotherapy, as you said, and this will bring us back to the more BVR later on. And this is what happened in some of our cases. One of the suggestions is to have a black therapy from behind. So it will cause shrinkage and atrophy and ischemia. The other option is like some Turkish people do. They suture the feeding vessel. Yes. Yeah, but and we have tried that also. And suturing is wonderful surgically, but the issue is when you close a vessel, there will be congestion in the area behind it, so you can get the bleeding behind. This is why, if you make me choice, I will choose cautery rather than suturing, because cautery, it closes the vessel, but if the pressure increases, it can leak a little bit somewhere else. When you do suture, you are really closing a very wonderful vessel that can have congestion and leakage beyond. There is some also study show that, and some case report show that there is a chemosis post-op whenever you do buckling for those cases. And you will get surprised. You will get surprised in some cases when you dissect to do the buckle, that the vessel abnormality is not only inside the retina, it's around outside. It's around outside. And I think this is maybe why how we can explain the BVR and the inflammation post-op. Some of the case reports show that you can have like an ecchymosis post-op, and this will bother the patient a lot. But it was wonderful, Dr. Hassan. Thank you.
Thank you. That was very interesting.
Yeah, I welcome the next speaker, Dr. Saad Wahib.
Okay. Okay, so I'm going to take you off the younger patients. This is, I call this the unfortunate patient, and you'll see why in a few seconds. This was a 50-year-old healthy female who is a regular patient of mine. She came to see me with floaters and flashes in her right eye of 1 week duration. She had, same patient, she had an RD surgery done by me 12 years ago. And she was doing very well in this eye. She's otherwise medically healthy. Her vision at that stage was 20/30 in the right eye, the eye that she's complaining of. The left eye, this is the eye that we have done 12 years ago. Anterior chamber was normal. She had left pseudophakia, normal IOP, and at that stage, she has an acute PVD with a vitreous bleed in that eye. and the other eye was very stable. So I told her that this is a PVD, she needs to wait, we will observe it, her retina looks good. She comes back after a week with a dense vitreous hemorrhage in the same eye, but the B scan showed no RD. After 2 weeks, the blood started to clear, she was very happy, but then a week later, she came with drop of vision, hand motion vision, and a macula of retinal detachment. So, as you would expect, we decided to go for surgery. You can see here the old vitreous hemorrhage inferiorly, and she had a macula on supratemporal detachment with a nasal horseshoe tear, just a usual standard phakic RD that you would usually do. So we did the usual. We flattened the case, and I think I used SF6 gas, and for the just sake of time, I'm just gonna continue. So you can see the supranasal single hole. There was an area that looked suspicious inferiorly that I laser. I don't routinely do 360 unless I have a suspicion. So she did very well. Vision improved. Gas was starting to disappear. The bubble disappeared. Her vision came back to 20/60. She was really happy. But then on the 5th week, she came back to me with the disturbed vision. And then when I looked at her, she had a macular hole. So I reviewed all the videos and I looked through them, but I couldn't see anything. She had a reasonably large 600 micron hole. Her vision dropped to 2200. She was not really very happy because she was comparing it to the other eye. And I said to her, listen, it's rare, it does happen, and sometimes it relates to tangential traction or some macular cyst happening, but it's gonna need surgery. So we decided we were gonna go for surgery. I took her back. We did, the usual again. I put some triamcinolone to make sure I'm not missing any vitreous, and the vitreous was very clear. And we did, the usual. And in a second, you'll see that I stained, and I usually restain. And I did an envelope, macula sparing envelope technique, which went very smooth with her. Restaining is key in these cases. So the usual, you restain. I'm doing the inverted envelope to try to cover the area, and everything went fine. I have a good technician. I usually take an OCT within a couple of days after the surgery, and I put air in her case, and the hole looked closed. And everything was going in the right direction. She kept face down for maybe 2 or 3 days, and we were going in the right direction. But then she came back on the 15th day post-op again with some blurriness of vision and discomfort. I looked at her. She had a hazy vitreous, a lot of cells. I wasn't sure if this is infection or vitreous hemorrhage. I told her to come back after a few hours, and it was a full-blown endophthalmitis with, not, fibrin and massive AC reaction. So since the fact that she had 2 vitrectomies before, I decided to tab and inject and give her a steroid. She did extremely well, and the condition stabilized. She's 3 months post-op. The hole is unfortunately open again, and it's much bigger, but her condition is stable. Her vision is 2200. And at that stage, I asked myself what to do, because I started to become very suspicious of such a patient. So I asked a very good friend of mine, and he said, you send her to your best friend. Don't touch her. And then she's a good friend, a patient herself is a good friend. She kept on coming to me, and we were talking about it. And then I was co-managing a patient with another senior friend of mine who said, why don't you consider a temporal flap? It might work. So I brought the patient, I discussed it with her, I told her, and she took some time. She came back to me. She said, I'll let you do the surgery under one condition: do not video my surgery. Somebody told me that it's the video that caused all of that. So I said, fine. I did not video her surgery. And to my surprise, she's done very well. And alhamdulillah, she's stable until today with a vision of, I don't think her vision is going to improve much around than that, but really every now and then you will encounter these patients, very unfortunate patients, but I think there's always a way to deal with them. Thank you very much.
Thank you so much. It's a It's a wonderful case and very eventful. The most importantly, how you managed it. Okay, so my first question, when there was a vitreous hemorrhage, did you induce PVD?
So did I what?
Did you induce PVD on the first surgery?
Did I use what, sorry? I'm sorry, I can't hear you. Oh, yes, yes. I mean, in her case, I think it was partially detached already. But yes, I mean, you do the, I didn't show the whole video because this, I mean, this way, I think the interesting point here is not the surgery. I mean, these are routine cases, but the consequence of events that happened, I couldn't, I mean, it has been reported, macular hole post, primary vitrectomy for retinal detachment, but it's just rare. I haven't seen a case like this.
Yeah, neither me I have seen in my cases. The next question that when you did an ILM pill when you plugged your macular hole, the first surgery, did you selectively just plugged it from the nasal side because you still had an ILM flap on your temporal side when you do the second surgery?
Oh yeah, oh yeah. I don't do big ILMs. I'm always worried that I might have to come back. So I do usually a limited envelope technique. So what I did in the last surgery is I went really temporal and I started the flap temporally and I brought it. I made sure the distance is long enough so it will cover. That's the idea behind the temporal flap, because you start at the periphery and you bring the flap, you make sure you have the right distance, otherwise it won't reach. Okay, but I don't do an extended ILM, not in the primary surgery. Some surgeons go arcade to arcade. I don't, because I'm worried it might come back. That's why.
Yeah, wonderful case. Difficult to explain why you had a macular hole on the first go, which is 0.3%.
Yeah, I agree.
Sorry, just a comment, going back a little bit, do you think when the patient presented with significant loss of vision with vitreous hemorrhage, although the retina was attached on the B scan, you should have intervened then? Because nowadays, the concept of intervening early in case of PVD or partial PVD related vitreous hemorrhage is more dominant than waiting for the retinal detachment to occur. So if you have intervened at that point where there was a significant vitreous hemorrhage without retinal detachment, the things might have been different.
Well, if you look at the timing, she didn't give me a lot of time. I mean, initially she was improving, and then she came with this, and we waited only for 2 weeks. I mean, the hemorrhage disappeared quickly, but the thing is that when it disappeared, she detached immediately. When I saw her, originally she was macula on. She had a supranasal temporal, but the macula was on. Would I have intervened earlier when the vitreous hemorrhage was there? I don't usually operate within 2 weeks. I like to wait a little bit because most of the times they clear and then you can see the tear and you laser it. I did tell her that in the presence of vitreous hemorrhage and a PVD, there's a very high chance of a retinal break, given the history of her other eye. So I was expecting this, but yeah, I don't know if going early would have helped.
How did the end off resolve? What did you do for the end off?
What did I use for what?
For the endophthalmitis. For the endophthalmitis, you said the patient...
just antibiotics, inject. I did not do a vitrectomy, just tap and inject.
And then you waited for this to resolve. It resolved with just an injection.
Yes, yes. Ahmed, you had a question.
It's a great case. Just a quick comment. Sometimes it becomes a social embarrassment, taking the patient back and back to the operating room. For example, this example, and also like vitreous hemorrhage or vitreous cavity hemorrhage rebleed in diabetics. One technique which works is air fluid exchange, or in this case would be a air fluid gas exchange in the clinic, like C3F8. And I had a couple of cases that closed with just putting gas in the eye. It's just something to save the social embarrassment.
Yeah, she didn't give me time. She kept on coming with problems. So I hope she stays stable.
Retrospectively, everything is possible. I think we do what you think is good for our patients and ourselves. So may I invite our next speaker, Dr. Thanasis to deliver his lecture, and we are all eager to hear you, sir.
I would like to thank you for letting me be here. It's really a pleasure. The thing that I would like to share with you is how to transfer this knowledge that you all distribute, and to show you a selection of videos later after that presentation that is done by fellows, that they selected pieces of nice didactic tricks and tips, that's the next thing we do. So we decided in Thessaloniki, which is a small port north of Greece, to do something like training people with different aspects, like complicated cataract surgery. And the guy you see in the middle is Carlevale. So Carlevale is bringing 50 lenses. We bring 50 people, and Carlevale teaches himself how to put a Carlevale lens. The next thing is you see the setup that we need to have. Not to be different than any operation theater. You need to have a microscope that is down there with wheels and everything to imitate exactly the name of the theater. And this is how many machines you need to have. That's a torque, that is constellation, that's everything to imitate exactly what they want to do in the theater so they can have the same setup. The thing that people don't understand why we do that is because of the social economics. If you see this, you say, we have to be democratic. Everybody's going to do one exercise. Please jump on the tree. So it's not the situation for everybody. If you have machines, if you have technology, if you have everything. Social economics are very important for each country, how to regulate his correct way of doing things. And the other thing is how to introduce technology, the new technology, to people who don't have access to the new technology. Because the new technology happens from the representative. The representative can show you the ingenuity, not the well-known guy who knows how to do it, the doctor. You see Ahmed from Canada, he's teaching us how to make complications easy. And this is the trick of the whole wet lab. No pig eyes anymore. You cannot make a vitrectomy wet lab with pig eyes because there is no viewing. You cannot do an ILM. You cannot do retinal detachment. So we have these bionic eyes, which are reusable, and you can do all these things together. And also introducing the new technology of ingenuity, because with ingenuity, the combination of ILM, of retinal detachment, is much easier. So we had 5 ingenuity systems while doing it. And this is how we transfer knowledge from generation to generation. And this is the setup we have. This is the setup of the theater. And this is the Huxrite new system to train people. And the next one is going to be between July 3 and 7 in Thessaloniki. So the next thing I would like to show that some of the people here that I had with me made a selection of my previous videos. Don't save. And that was it. And this selection of a previous video were done so I can speed them up to have a didactic issue. For example, sorry, I have to go back. This is a case that we have a giant tear. I always believe when you have a true giant tear, you have to do the cataract. You have a clear lens here. So I do a clear lens extraction because on the periphery, you cannot work for a giant tear with a lens in your way. And you can see that's the didactic point of this. You don't do vitrectomy in the peripheral. Sorry? Oh. Sorry. I was so absorbed with what I was seeing that I didn't see the result. It's playing here. So I'll come to each one of you with the laptop and I'll show it separately. What is? It's crazy because the last one, I tried to avoid to upload it. Which one? Yeah, you have to go back. I don't see, now I don't see my video. But you see it, it's much better. Can you, I don't see anything here. But here you can see, it's confusing, but I'll try to do it. You can see when you have a giant tear, how to put perfluorocarbon fluid while you're using another fluid needle to remove to have the current of the flap to go back. So there's our tricks and tips. Now I cannot control my presentation, which is horrible because I thought I can control and go forward and backward because I cannot control my presentation anymore. And next time I will not bring an apple for the presentation. I brought this. Horrible. You're not going to enjoy that. Okay, let me stop. Let me show you here. You have a bullous detachment. And in bullous detachment, one thing we can do is to empty the bullous detachment by doing vitrectomy at the hole by using scleral depression. So if we have both hands and a light, extra light, you can go and suck all the fluid by doing scleral depression because you remove all the tension of all the floppy retina is now under your scleral depression and it's not moving. You immobilize the retina this way so you can remove all the fluid and you can see all the, and this is just diathermy. And I don't know what to say now. I have to stop. I have a few more, the normal drop nucleus that you use by manually, because I cannot go faster. Can you do something about it? It's my laptop. Is it? Now I can see it, you cannot see it. I have to stop here because I respect your time. Oh, there it is. This is that you don't want to leave anybody without a treatment. This is a patient that has two eyes and one eye have the projection was not certain that he can have any vision. After 6 months of retinal detachment, they say you cannot have any result and they gave up for the patient. So we did the retinal detachment, although he has no actually perception of light. And we did all the retinal detachment. And we used scleral depressor again. This was a horrible eye when I see it. But when we did that, at the end, we used silicone oil and did the cataract and everything. Just to tell you the story, now we're using a new system that everybody can use that. Med1 is making an infusion cannula. You can use silicone oil, 5,700 to do the injection. So this trick and tip you can have an infusion that can inject silicone oil. And you can do it by manually, in the same time, removing perfluorocarbon, injecting silicone oil, and flattening the retina at the same time. But with this system, the infusion, the silicone oil infusion of MED1, you can see that you can put pressures like 60 to 70, not millimeters, but you can see how strong it can be. We're pressing, and the 5,700 is sticky there. And if you close the lumen, it still doesn't go off. This is the problem, the infusion. These are the new tricks and tips that we have and involve all the time. I'm sorry to stop here. I cannot go on because I have so many small things that I needed to go fast to show you one after the other because I made a connection of that. But this is what I see, nothing in my laptop. And this is diabetic. But never mind, the last one. Can anybody from there can do it faster? Can do it for me faster? No, because you don't have the presentation. I'm stuck. Can we stop here? Sorry, I don't want to spend more of your time. Okay, thank you very much. The idea was that it's another story to give a lecture. It's another story to do surgery and to train somebody. It's another story to tell people to go to the internet to see what's going on. And another story for a teacher to say all the tricks and tips you cannot find in the internet. So this is another issue of teaching people. Thank you very much for accepting me.
Thank you. Yeah, may I request Dr. Ahmed Al-Barki to present his case?
Thank you. Hi, Dr. Thank you, Dr. Muhammad, for inviting me for this meeting. Can you play the video, please? Just a little introduction, that's it. A few seconds. My case is about trauma case, actually. Dated suspense only, not more than this. So it was a challenging case, at least for me. Trauma, very big trauma. Male patient, global resection, very big, I will show it now. And the primary repair was done. And as you see here, how big the laceration extended both sides of the sclera. And on the nasal side, extended like more 7 meters. So B scan was done. This was done 2 months later after the surgery. And you can almost close funnel there. And you see the cornea now, this is the best cornea we can have. So that one of the challenge here is the poor visualization. We'll go inside, there is no place to put the infusion. So we with AOC maintainer. I tried to go with the parsiplana, but there is no access. You can see a lot of blood behind the iris. So I do what you can say, paracentesis vitrectomy, not parsiplana vitrectomy at this stage, because I need to go from the paracentesis side port with the vitrectomy probe, trying to release the blood behind the iris, give access to the infusion. So later on, I can do the vitrectomy through the parsiplana. As you see here, when you go inside, you find like a salad of tissue. It's vitreous, blood clots. You don't know where exactly you are, poor visualization, but you start to try, I've tried to very peripherally try to remove the blood clot as gently as I can, because in my back mind, there is a closed funnel detachment there. So definitely I will do retinectomy in this case, but I don't want to do it accidentally. I hoped can I do it intentionally. So I start to very peripherally make sure this is a blood, because sometimes with this long duration cases, the retina could be there. So I like to digging superficial, so starting from anterior or behind the iris and going back, trying to find the plane at any time, and then it can start. So as you can see here, just trying to remove the blood as much as I can, very gently. It takes longer time with me, so maybe 30 minutes or later or more than that, I can now visualize the retina there. And you can see how it's stretched and very difficult. Now there is a space to put the infusion in normal position now. So I go, was subretinal blood, which is expected because of the massive trauma. We are expecting that. The good thing that we don't have choroidal hemorrhage in this case. I remove the blood. Already there is some retinectomy was done. Complete the vitreous peripherally, trying to get more part of the retina to visualize. There is just a blood clot behind the retina. I removed that. And while doing that, I discovered there is an incarceration on the side. As I showed you the very picture, there was a big nasal wound. So during suturing the initial circular wound, there was retinal incarceration, was expected in such kind of difficult case. So the only reason or the only way now to do 360-degree retinectomy, we cannot do that at there is a site where is the incarceration there, perfluorocarbon to flatten the retina. And for sure, it's expected because of the long duration, retina was stretched and fibrosed. So you do peripheral vitrectomy and you find that you have small retina there, but still we can do that. So after that, we put in air, and with the back flush needle, I'm trying to flatten the peripheral retina as much as I can. I want to get more retina as much as I can. And after that, put silicone oil. I cannot do laser under air because of the visualization, because poor cornea and air, it's make difficult. So I do the laser under silicone oil and do a 360-degree around the remaining retina in this case, into laser all around. And now then we can have flat retina. Let's say part of the retina for sure. It's not the whole retina, but this is what you can do that. So we have intraoperative OCT. So I want to make sure that the retinas or macula is on. So fortunately, I was lucky that the macula was on intraoperatively. I just put some viscoelastic because this patient is aphakic to prevent the migration of the silicone oil. And that's the end of my case. Thank you so much.
Thank you, Dr. Ahmed, and congratulations for your new company, Retina.
I cannot hear you well, by the way. Sorry for this.
You can hear me?
You need to come here. Yeah, the echo is not good. Yes.
Yeah. Okay. I said congratulations for your company.
I thought you were asking question. Okay, thank you. Thank you.
And congratulations for the surgery because it's so bad case. I have a question for you. Did this patient have a contraction on the edges of the retina which you have cut later on?
Come again, sorry, I cannot remove the mask. Let me talk.
The retina reflected after some time?
After the surgery, after the follow-up, you mean? Yeah, the follow. Actually, the retina, it's remaining there. It's very small. And actually, I keep following up for 6 months because of insurance issue, I cannot see him again. But during the 6 months, everything was okay. So, but I am expected, this is a good point, to be retracted because it's very bad retina. You can see it during even if you look at while doing retinectomy, there is no bleeding. I didn't need to use diathermy. The retina was very, ischemic and rigid. So I am expecting to get more contraction. So
Yeah, most of the time when you have a chronic funnel or post-trauma, and especially on your nasal side, if you see the retina becomes thickened and they don't open up. And you might see during the surgery, you see the laser effect. The laser actually doesn't affect and cause a chorioretinal adhesions.
Yes.
Those are the edges we try to contract later and pull the retina, especially in your case. But it's very good that 6 months is doing well. Congratulations.
Thank you. Thank you.
I invite Dr. Mohammed for his unexpected culprit.
Thank you, Dr. Muhammad Al-Amri, for this kind invitation. So I will go quick through 2 videos. The first case is a 55-year-old male with diminution of vision of 3 months. He has poorly controlled diabetes mellitus, and the vision in the left eye is counting finger 50 centimeters. Basically, it's cataract in the left eye with dense diabetic vitreous hemorrhage with no details. I did B scan of the left eye to discern whether there is a retinal detachment or not. So just vitreous hemorrhage, no retinal hemorrhage. It was just straightforward vitreous hemorrhage case. We went for surgery. I thought it's a walk in the park. We are doing just diabetic vitreous hemorrhage. Started the case, as we can see here. Again, I cannot control the video. Anyway, as you can see, I started after doing core vitrectomy. I started to see this swelling, this rounded swelling at the superior arcade with the edge encroaching upon the fovea. So I just wanted to stop here and ask the panelists, what do you think of this swelling? Sorry for this.
Yeah,
it's a dome-shaped swelling.
Yeah.
You know, just discovered. It's not appearing on B scan pre-operatively. Okay.
It looks
Sorry,
like
but I have no control on the video from here.
Yeah.
So I started to think what this could be, and we have all those bad thoughts of this swelling, what could be. Here, after completing vitrectomy, I just wanted to, yes, there is a fibrovascular stalk on this area, a diabetic fibrovascular stalk on this area. I cannot stop the video.
No, it's a traction. I think it's a. No.
So, yeah. Yes, here I tried, after I finished vitrectomy, I tried to pull on this. There is a hole over there. Can you see this hole? There is a little bit. It's a perforation by the peripalpar needle. Thank you, doctor. Thank you. So it was I tried even to do laser around this hole, is not taking laser, increasing the power of the laser, is not responding. So all this is all this mold is a kind of fluid under the retina. I tried to during the fluid air exchange to drain from it. It's just subretinal, subchoroidal, and I just surround it with laser, doing the rest of surgery. This is the fluid air exchange, and macula is not affected. This is, I put silicone oil just to give it, and here this, after 5 days, we can see disappearance of the whole thing and my laser marks over there. So it is a perforation with the peripalpar injection. We'll just stop here. Yes. Yes, I don't have this cannula. I could find it. So this is an unexpected thing. Just I thought it is just an easy case, diabetic vitreous hemorrhage, and it is an in-house. Our anesthesiologist, very much experienced in peripalpar injection. Thank God it was away from the fovea, so it ends up that the vision was excellent post-operative. And I'm preparing to remove the silicone soon, inshallah.
Was there the hemorrhage on the first post-op day after phaco?
I did phaco and vitrectomy. So the first post-operative day, this is one. The second case, this is the second case. This is my second case. This is referred from outside 1 month after phaco, 1 month after phaco. And she's telling me, I don't see with this eye after surgery. She has dense vitreous hemorrhage in the left eye, and the B scan again shows vitreous hemorrhage and no retinal detachment. Here I saw the IOL. The IOL is in place. Excellent surgery. There is a corneal opacity, central corneal opacity bilateral. And in this case, I suspected it is a perforation. So this is the picture. You can see here the corneal opacity. Not sure if it is playing. Yes. As you can see here, the anterior segment is an excellent surgery. IOL in place, well-centered, posterior capsule is intact, and very dense vitreous hemorrhage. So one month after. So I went to do first I did with the microscope, then I went inside removing this very dense vitreous hemorrhage. And I remind you that the B scan of this patient showed no retinal detachment, just a very dense vitreous hemorrhage. And here you can see, this is the rest. I'm trying to remove the rest of the, and here I started to discern one linear tear, and next to it, there is a small round tear. So there are two tears, one linear, this is the linear perforation, and one round small perforation next to it with subretinal hemorrhage, again away from the fovea, luckily away there. There is no retinal detachment, however, and this is another case of, and it is not a retrobulbar, it's a peribulbar. So I completed the rest of the vitrectomy and put silicone oil. Unfortunately, this patient vision didn't improve. So here is a kind of comparison of between two cases. The first case is an in-house peripulbar injection, no retinal detachment, and it is extramacular tear. And I did immediate pars plana vitrectomy, immediate. Whether the anesthesiologist did inadvertent injection or not, I did immediate visual acuity improved. The second case, external, unknown, could be retrobulbar or peripulbar. I know the center where they are using peripulbar mostly. No retinal detachment, extramacular. There was 1 month delay in pars plana vitrectomy, and vision didn't improve significantly. So I suspect that there is a chemical toxicity to the retina after injection. Anyway, this is the points to consider. We have to consider the perforation. We have always to maintain a high index of suspicion of globe perforation. Peripulbar anesthesia incidence of globe perforation is 1/16,000, while retropulbar injection is 1/10,000. So peripulbar is not very safe, rather than, so because many people believe that peripulbar has no complication or perforation is less. No, you can get perforation. These are the predisposing factors we are all aware of: high axial length, posterior staphyloma, uncooperative patient, deep set eye, multiple attempts at entry, and inexperienced surgeon. And you can get all kinds of complication. And the intraocular injection of the anesthesia can cause both chemical and mechanical. So if you keep injecting, there is a report of globe perforation, globe rupture. Suspect another tear. 40% of eyes had more than one retinal tear. 70% of eyes with attached retina at the time of perforation achieve good prognosis, and the presence of retinal detachment most probably develop PVR, and this is associated with less favorable prognosis. Thank you very much.
Did you do the OCT of the patient to see why the OCT, fluorescein angiography, to see why the vision did not improve?
I suspect because there was no retinal detachment. The two tears are away from the fovea. I suspect chemical injury or chemical.
Yes, so that would show up in either there'll be disc pallor.
Sorry?
Either there will be disc pallor or there'll be some effect on the macula.
Effect on the macula or
So
the
did
optic
you do
nerve?
the OCT?
Not sure.
Because the other important thing, and I think that's for everybody to know who gives the peribulbar, people have a tendency to move the needle to see whether it's inside. But actually, that's when this kind of linear tear occurs.
Yeah, and the second case showed that the surgeon or the anesthesiologist has went one time, then retracted the needle and went with the other time.
Yes.
In this way, it did one linear tear, and the other.
The second time is when.
And the second time where he injected through this small perforation. This is what I suspect.
And just a quick comment also for the peribulbars. One of the anesthetists I worked with, he raised a very good point. He said, normally when we ask the patient to look up when they're injecting, they tend to look towards their forehead. If they look towards their forehead, the optic nerve and the fovea becomes more closer to the track of the needle. So it's very important to make sure that you ask the patient not to look up, but to look straight.
And my point that many people take the peripulbar injection lightly, and they think since they are injecting outside the cone, it's safe. So you have to look for signs of perforation, especially when you are going with the needle and the cornea starts to move towards you. If the patient feels pain, if there is some pressure while you are injecting, you have to suspect, you have to stop, not to inject. Just go out and try some other place for anesthesia or postpone or whatever. Thank you very much.
So we welcome our next speaker, Dr. Abdullah Al-Khatani, for his lecture on innovation during pandemic.
Thank you very much, audience and chair, for this chance of presentation. Can we have the video? So, yeah, so during pandemic, as you know, there was a supply chain problem. So we cannot have everything we want. So what we missed first is the things we use it rarely, which is the diamond or a scraper or funnel loop. So I decided to build my own things to scratch the cortex of the vitreous of it. So it's just a ring, you cut it, the thinnest possible, then you take third of it, then you scratch the retina with it. So you can remove the cortex of the remnant of the cortex from this area. The advantage of it is the curvature. So third of the ring could be very, very fitting for that. As you know, we get the friction either by the curvature or by the harsh surface as diamond dusted silicone tip. So I here try to remove another case, which a remnant of the cortex. And sometimes it's very fragile. It doesn't go as a one piece. It's very difficult to suck it closer to the retina with the vitrectomy. So I try to remove it with the forceps as much as I can, but at the end, I fail to do it. So I rebuild my silicone tip. See, I try to scratch here even, rather than grasping. So you cut a ring, the thinnest possible. Then the ring it's the tube that came for the Ventur through the Constellation packs, actually. There is a tube came with it. You just cut a ring of it and take third of it. Sometimes if you hold the forceps and this doesn't go as this one, you just slice it with a blade parallel to the tip of the forceps to make it the thinnest as you want. The length is dependent on how flexibility you want to do it. If you take half of the ring or more than third, it will be more flexible. If you want it to be a little bit hard, you can take third and less. You grasp it with the forceps, then you push it inside. And actually you can do the same like what we did before in scratching the remnant of the cortex, or even though opening the flap of the eye limb, if you decide to open the flap of the eye limb, like what we do here, for example. So we are removing this part, remnant of a cortex, PVD, which is a very important for the surgery of the posterior pole, and flap already prepared for you, so you can peel it with the forceps. So it's cheap from nothing, but they always said need is the mother of invention. Whenever you need something, your brain will work. This is why John Murphy said, don't say yes for every request from your son, huh? Just say no sometimes, will make him think. So I think the advantage of this one is cheap, easy to build. Disadvantage is you can leave it, you can drop it inside the eye, then you can take it out by a forceps.
So beautiful issue. Success of a surgery, especially in high myopes, depends on your removing this layer of the vitreoscheisis. And what I found in my hands, the most effective method is to use a diamond dusted scratcher. with the diamond dustage, because sometimes this will be a whole layer. Sometimes it will come piecemeal. If you use a forceps, it tears it off. So you don't get the edge. You'll get a little bit of edge, you'll lose the rest. But if you use a diamond dusted scratcher, you can keep on extending it to the periphery and comes in.
Oh, definitely. The one which is more easy to use is the finished
Yes.
loop. Finished
You don't
loop
even need a new
is wonderful
scratcher.
thing.
An old one will do.
We didn't have it much. Actually, the first and the last finished loop I used it was on a life surgery. So we try whatever we have. But
just another little trick, old trick in this situation, you can use your flute needle with a blunt end attached to the vacuum, just the vacuum, and with the high vacuum, you can slide across on the surface of the retina safely, and it will engage the layer of the vitreous.
you talk about the small gauge things.
Sorry?
Small gauge things, you mean?
Yeah, flute needle. Flute needle with the blunt end, with the...
What do you mean flute needle? What type of needle?
Nowadays in the 25 or 27, we have got the back. We got the back flash.
You see the speaker here. I was wondering why Saad is going there. Huh? Speaker here is not very clear, actually.
No, it's back flash.
Yeah, back flush.
Back flash.
This is true. You have to have the back. Yeah.
Yeah, soft tape. Yeah, you know the same thing. What
Actually,
you did, you can make it into a brush. Previously, we used to have a silicone tape brush.
I will tell you things. With this, we have tried also the silicone tip. In most of the time, we remove it. I hate tip. I hate it. But if you decide to use it, this is also very good. The problem of it, it doesn't have neither the curvature of what we do, so you scratch like a hook, neither have the harsh surface to do a friction to rub it with. It's like a vacuum cleaner. So if you put a high vacuum. Yeah, with high vacuum and you hold the retina, you will create a hole. So this is what makes me afraid of. Yeah. Yeah. The diamond is the frequently used. But to be honest, we didn't use those material much. I mean, during the heavy OR, you just finish whatever you. Yeah.
And it's the most effective in the back.
Sure.
I'm sorry. I just want to congratulate you about new ideas all the time. And the thing is, if I had the chance, I have a small video of 1 minute to show you how we do that in very rough cases, and we call hydrolifting. This hydrolifting is just, I don't know, the microphones are not very good.
No, we hear you. We hear you properly. Don't worry.
Yes.
I hear you.
You take the flute needle, you connect it with a syringe, and very slowly you inject, very slowly, because the current of a 25 gauge when it hits the retina is very strong, so it's multiplied by the lumen. So very slowly you just drop some fluid, throw fluid at the edges of this cortical attachment, very hard cortical attachment, and it becomes a turbulent thing, a turbulent area where it's lifting.
It's mean they agree on what you suggest.
Already this big posterior hyaloid, the top posterior hyaloid, and it's going to lift so much that you can actually suck it out. The problem with this cortical hyaloid that I spent so much time trying to do, you cannot catch it.
Yeah.
And if you catch it, it's become friable. And the other problem with the diamond duster, because with the late discussion of that, the diamond duster also immobilize the pigment epithelium. If you mobilize the pigment epithelium while scratching, you think it's safe. But while scratching the pigment epithelium, you make small peripheral black spots in your central. Not important for the vision so much, but it's removing the pigment epithelium. And I don't like so much tunnel scraper, and even tunnel has removed the tunnel scraper. It's better for membranes, but nest is fantastic.
It's fantastic.
But the cost.
And the availability, it's not always available, huh? At least in our.
450, 500 euro is something you cannot use second time. I'm using the finesse, the same finesse, but it's amount.
Sterilizing.
Then I cannot speak anymore.
No. Just say
I'm using it again.
Of course. But you bring a very good idea of how we can create the PVD. Sometimes unless we go deep perpendicular to the optics and reach a good lowering area and leave a little time for the fluid to create the turbulence, to open the plant at that place, then it will become very easier to pull it. Sometimes if you go deep, because the cortex, it's not a gel, it's a layer of gel actually. It's a lot of layer. This is why we see the cortex remnant. But whatever you see, just a while, this was at the COVID-19 and the lockdown and everything.
So much of the subject, because from life surgery, when you go to life surgery and you give somebody to do vitrectomy, hemorrhage vitrectomy, that's the easiest thing for a person. And then they stuck to this cortical attachment, and they start sweating. They don't know what to do because they get something easy. They stuck. And I categorize this, and I can slide. There are 6 or 7 kinds of attachments that they have. You can do a lot of vitrectomies if you use general. You'll find there's a baby attachment like embryo, taking the diffuse attachment, which is all around. But all these things can be overcome if you let the fluid go a little bit at the edges to create the current. The turbulent current at the edges to lift it up. And I call it like hydrolysis. This is very slowly. No. Next.
Okay, thank you very much. We can move to the next speaker, Dr. Bakr Bahaj. He will give our talk.
Thank you, Dr. Muhammad, for inviting me to this very nice meeting. I will take you again to trauma, but this time is type 1, a blunt trauma, non-violent. And my case is a 17-year-old lady who sustained a trauma. It is a non-violent, very light. This one? No, this one, okay. Yeah. No, you start it. It will be continuous now. You start the video? Yes. Yes, it is a blunt non-violence trauma. She is a lady of 17 years old. She sustained a trauma. She came to my clinic after 7 days of her trauma. She's coming from a distance, actually. Many surgeons, I think they saw her, but because of, they think it's a bad prognosis, they sent her to my clinic. She had a history of congenital glaucoma, congenital glaucoma she had when she is 14 years old. When she is 14 days old. On both eyes, she has a remarkable axial myopia on both eyes. Her vision in the sound eye is 618 with myopic correction. This eye, actually, when she came, it is only perception of light. And the pressure is so unrecordable, it is just 0. We brought her to clinic. This is video will just the primary repair. The sutures are almost as you see here. It is I did barotomy, and fortunately we classified her as zone 1. Zone is almost circumferential, extend from 530 up to 1030. We suture her with 60 vicryl. It is about 9 sutures, interrupted suture. The ideal thing in primary repair is to maintain a firm pressure and to maintain AC with good firm pressure. And here we close our peritomy. And we actually do a lot of, we start by giving her a subtenon injection of steroid. And she passed her post-operative uneventfully. And for that, she had a vitreous hemorrhage. You brought her after 4 weeks for secondary surgery, planning to do a lensectomy because of a lot of adhesions and synecdoche. I start with 2 pores only. Then I remove most of the cataract lens and iris synecdoche and a lot of things to visualize the retina first. At this stage, we classify as type 1 apparent trauma with rupture, non-violence, as I said, zone 1. And because the vision is only perception, it's a grade 4. And she has a positive afferent pupillary defect. Then I put my second third cannula, pars plana, to complete the vitreous hemorrhage. As usual, unfortunately, the retina is almost, but you can see the myopic degenerative changes. We remove our cannula and we put also another injection of steroids. She came about 1 month ago. We advised her to go to contact lens for her pseudophakia. And she regained a good vision. Till now, the retina is on. This is also to say that although when we start to seeing her, it looks very bad prognosis. But if you go directly to repair and you wait for the nature to come and can do secondary surgery, removing the vitreous, and this is her value. Thank you very much.
Thank you very much, Dr. Bakr. Very excellent surgery. Certainly very, very challenging. So in these kind of cases, as you rightly, waited for 4 weeks, what is the optimal time you think to intervene in case that the retina on the B scan remains attached? So what is the optimal time?
As I said, her post-operatively went very eventually because then I do it just for to relieve some of congestion of the eye and to make it quiet and not to do surgery in a congested eye with a lot of inflammation and these things. It is.
Yeah, thank you. No, post-trauma, I think you need to wait until the posterior vitreous detachment occurs, then probably you can go in and operate.
Posterior vitreous detachment, she has already had
post-trauma, immediate, you
BVD,
go,
yes.
Or otherwise, within 2 weeks, you can go in. Within 2 weeks.
2 weeks, actually, she is staying far away, actually. She came from more than 200 kilometers. So she has to return back home and they have to gain some money to come back for the surgery, second surgery.
Good job.
Last time I saw her, she had a contact lens and she had a very good vision. Thank you. Subat, this is my mentor, actually. I'm very glad this meeting to see Dr. Subat after a long time.
Yeah, thanks, Abu Khair. He was our first fellow from Sudan, so I'm really proud. I think the way you sutured that, I was so happy because you sutured with the Jovanovic technique without incarcerating the vitreous. But only one thing is there, that if that vitreous hemorrhage is attached to a corneal wound, then we should go early because the corneal wound contracts and it causes a detachment earlier than the vitreous adherent at the vitreous wound. And this is what Ferdinand Kuhn and other trauma society members have taught us, that if it is attached to the cornea and you have vitreous hemorrhage and attached retina, go early. If it is attached to the sclera, you can still wait because that doesn't contract like the corneal wound contracts. So excellent surgery and great work.
I want to say that with such bad prognosis, sometimes we give it to the residents or the resident to do it. I think it should be done by the senior vitreoretinal surgeon in such cases.
Okay, thanks. Okay. We move on with the next speaker.
Thank you. Thank
Dr.
you.
Muhammad Naeem.
Well, thank you for having me here, and it's an honor and privilege to present to you. These are some of the pearls of the TRD. This is bread and butter of where I come from, Bahrain. So this is a case of 50 years old female. She was a known case of diabetes, hypertension, hyperlipidemia. They were uncontrolled, and status post she had left eye combined surgery for TRD. And these are the credentials. You can see in the right eye is the eye that I'm going to operate on. It's the hand motion. She had significant cataract, poorly dilating pupil, and no NVIs, luckily. But in the left eye, where she presented to me, surgery was done somewhere else, and she had, unfortunately, no perception of light. She was pseudophakic, the IOL is in place. She had afferent pupillate defect and florid NVIs all in the anterior segment. These are the pictures of the left eye, 1 month apart. Still the vision maintained, no PL, and she had a lot of membranes underneath the silicone oil, and there was no scope of rescuing this eye. So this sort of scenario just puts extra pressure at the back of your mind, because now you're dealing with a middle-aged female with a uniocular circumstance. Can we just have the video, please? Okay, so it's a combined surgery. Just before the surgery, I given this patient intravitreal bevacizumab, because in my experience, when you provide them with the injection, it sort of reduces the intra bleed, and it reduces the time of the surgery, and then you use less endothermy, less amount of inflammation. I had to use retractors because the pupil was non-dilating, and sometimes even I start them in this retractors. You have to be very sure that in diabetics, they tend to have post-operative exudative membranes. So I tackle that at the end of the surgery by giving them subtenon Kinacort. So this is some tips that you need to do if you're dealing with the combined surgery. So this was my first glimpse of the retina. You see the whole retina was detached. And usually I start my vitrectomy in such cases in the mid periphery, because that's the only place where you have the scaffold. So retina is a little bit, gives you some space to make the vitrectomy, co-vitrectomy. And then I go for the peripheral vitrectomy. And if the peripheral retina is attached, then I do the PRP before engaging the central membrane. Now this is the high resolution. First, I try to find all over from the 360-degree, a place where I have a scaffold, I have a space to engage and start doing my segmentation. My aim is to go and find the optic nerve. Here, as you can see, I'm just guessing where would be my macula and optic nerve. And unfortunately or fortunately, the groove that I had was just above the macula. So I had to be very sure. The moment I realized that I'm dealing with the fovea region, I just increased my cut rate to the maximum and the lower vacuum, because on the macula, I don't want to induce any holes. So in that region, you have to just do that. And then you do, what I do usually is radial membranectomy. From the optic nerve, you go into different directions. This way you minimize the chances of inducing posterior pole breaks, because you want, the retina is taut, but still it has a resistance. So you want that retina to have resistance. And now I just have a look at the edge where the membrane ends, and you have the peripheral retina starting. That's the area where usually the retina is extremely thin, and you have to be very careful dealing with that area. But I use that break in my advantage because I had a subretinal blood. So I use that break to just aspire the retinal blood, which I would have done retinotomy to remove that blood, because epiretinal blood is all right, because I don't like to leave subretinal blood, because it just somehow oozes back to the macula. And then you just, any island of the membrane that you find is extremely thin and very strongly adherent, you just leave it to the end, because you don't want to induce breaks in the beginning of your surgery. You just leave it to the end, and you can always come back to them later and deal with them after you have put the heavy liquid. And this is usually the technique I use. I just use certain settings and try to peel off the membrane. I use my cutter here. The reason I use 23 gauge, because I was anticipating that I might be putting 5,000 silicone oil. And the second, because of the thick membranes, the cutter is very effective, 23 gauge. And then a certain stage, I I use forceps because there are schools which tell you that for TRD, the use of forceps is forbidden. I don't believe in that. It's just you should know that when to use them and how to use them. And you need to be very careful. When you're pulling the membranes, you have to look at the retina and you just know where to stop before inducing any breaks. So this is what I've done here. And the moment you have made a groove or we have made enough space for your cutter to be introduced and do the remaining of the cutter. So this is what has happened. So then you just remove the rest of the job. If you see here, there's bleeding because this case is like very uncontrolled diabetic and previously so many injections and no laser has been done. But giving the pre-op bevacizumab helps you control a lot of bleeding together with the, sometimes you just need to raise the air fluid level. So the moment you finish up cutting these membranes just with using the cutter, you will feel these are the edges that you have to be very careful, which is at the end of the membrane and beginning of the peripheral retina. Then I just use the PFCL because now I'm going to deal with an inferior area of the epiretinal, the fibrovascular membrane that I found it to be extremely adherent and very thin. So you had to go very carefully there, and already I induced one break there, and I think they're going to be one more. So I was lucky enough to get away with this case with just 2 iatrogenic breaks. And I used those breaks in my advantage, and they were quite away from the center of the macula. So I was not worried about them. And then only in this part, I worked centripetally instead of going all the way radially toward the peripheral. So at the end, it's just in my favor. I did the fluid air exchange and I removed the PFCL. And later you'll see, here, what I do, my technique is that I put IOL before doing the air fluid exchange. I don't complete my, because somehow I don't feel comfortable doing the peripheral vitrectomy with the edge of the optic. It somehow gives me diffraction when I'm focusing. So this is just the way I'm comfortable doing it. There are people who do the phaco and they put the IOL in the beginning and then they do the posterior segment, but I'm just very comfortable in this approach. So just before the air fluid exchange, I have done the IOL insertion, viscoelastic removal. I'm done with the anterior segment. So again, back to the posterior segment because the same machine that I'm going to use, the Centurion, the Constellation, sorry. So the first thing I'm going to do, I have 2 heterogenics break. I'm going to secure them. Before I jump on my laser anywhere else, I'm going to make sure my 2 breaks are totally flat and well lasered. After doing that, now I have enough time to go and play around in the peripheral part of the retina because it needs very good laser. Because initially when the patient was not properly controlled, she did not have PRP, so that makes my job. So she will gonna need a lot of laser. So then I put 1000 silicone oil because case didn't require 5000 in my opinion. And I just sutured it, and just make sure when you suture, you tighten them very well using the 2 forceps, because otherwise you don't want to end up with subconjunctival silicone oil bubbles. So this is one thing that you keep in mind. And the post-operatively, you will see I followed her up now about 3 months, but I have the visual acuity. It started from counter finger on the first day. It improved on the 5th day. Only thing you will see that there are clots of the pre-retinal hemorrhages. That with time, which changes color because of the deoxygenated, and eventually it will get absorbed in the silicone oil. So the main idea is that your fovea has to be on and your retina has to be flat and your breaks have to be flat. And you have done good peripheral shaving. The moment you have done that, I think I mentioned all these spurs during my presentation. Only the last thing that I would like to emphasize that dealing with the mononuclear patient, it puts an exert pressure psychologically on you, but you should not leave and never give up on the patient because patient's hope is attached to your hope. And thank you for being a wonderful audience. Thank you.
Yeah, thank you, Dr. Mohammed Naeem. This is a wonderful case, and actually it's a difficult case with a broad-based traction. Okay, it's a broad-based traction almost going up to the equator. So I would just tell the salient point, which I felt was good, is that you made some island of removing the traction. You've made islands of those fibrous proliferations. And while you're pulling and doing the dissection with your cutter, you were radial and towards the retina rather than pulling it, because these areas are so ischemic. So when you pull and you dissect, you might cause a linear tear. Okay, and in your case, periphery, in the periphery, because it was a chronic detachment, you see the retina in the periphery is very thin, and that's the edge between the fibrous proliferations and the non-fibrous area, which is thin. That's the area difficult to dissect, and that's the area you may create multiple breaks. So a job well done, but some may even argue, so why not use a bimanual technique? So I would say, whichever you are comfortable in doing that works good in your hands and the endpoint is met, and that is the criteria. So whichever works good for you. And you have done a good job. Thank you.
Thank you for your comments. Regarding the bimanual, usually I refer to it when I'm stuck. So we use PFCL when it's needed and then the second stage. But in this scenario, not always after COVID, we have a good enough supply of all the consumables. So that's one thing that affects your decision.
It's a great job. It was a tough case. 2 tips. You had a stage when you had the temporal, the nasal periphery of that membrane visible. That's the easiest point to use to to separate out the membrane from the retina. So if at that stage, if you use a forceps to just come circumferentially along the edge of the membrane, you'll find it works very easily to separate the membrane. As Nazimul said, bimanual, and I would say specifically when you got the detachment in the superior area, that's the best time to shift to a bimanual. That would help. And one last tip, when you were talking about getting the plane, I found that if I use a 25 gauge sharp needle, the MVR, and use it to make a cut in the central area, there's always some space there, and you can easily create a plane between the underlying retina and this membrane, and then you can separate it out further, and then you can cut it further.
Well, thank you so much for your both points. Regarding the first one, I already tried that, but because the surgery was 2 hours, I had to make it in 5 minutes. I didn't mention all the tricks. And second, I'm usually a little bit reluctant in using the needles because I got these valve trokers. So the moment I'm going to use the needles, I'm going to lose that quality of the valve. So I sometimes, while later on I'm going to need, so in combined cases, I use that when I'm left with no other resources. Those are lovely tips. Thank you so much.
Okay. May I welcome Dr. Mohammed Tawfiq?
I will present a case of combined traction and remedial detachment diabetic after injecting this eye 2 days before the surgery with anti-VEGF. I started working with the case by doing what's called vitrorexis, separating the anterior vitreous from the submembrane. And when I complete the job of vitrorexis, I put a bubble of PSC to act as a third hand supporting the retina when I'm working by manually to attack the membrane by a forceps in left hand and the scissors in right hand. And this is the point of trimanual vitrectomy, as I call the trimanual vitrectomy, because the PFC now act as a third hand supporting the retina, that's a detached retina, and help me to have a gentle traction by the left hand over the membrane and go with the scissor to cut the epicenter. And we have also here a small tip. When you go with this such a curved blunt scissor, make a dissection of the membrane rather than cutting the membrane to decrease the incidence of bleeding from cutting the membrane with the scissor. So if you go with the scissor closed like this and searching for the epicenters, if you are succeed to cut the epicenter by dissection, not by cutting, it's okay. If you feel that it's a stucky epicenter, go ahead and cut it. This technique help you to decrease the incidence of bleeding when you are doing, when you are working under the membrane. And another thing here, the PFC make the bleeding as less, like a hemostatic effect of the bleeders. So if you have a bleeding after cutting the epicenters or the blood vessels, it's helping the bleeding to a little bit hemostatic. As you can see, we are approaching over the disc and there is a sum of bleeding, and also it's a little bit controlled. So again, when you gently traction by left hand, go clothing the forceps, the scissor underneath, and try to search for epicenters while you are clothing the scissor to cut it. So if you are fail to cut with the scissor closed, open it and cut it. So that most of the job is done while the scissor is closed. And this type of the scissor, the tip of the scissor is blunt. So you don't feel when you are going underneath the membrane to injure the surface of the retina. And also see how beauty the BFC supporting the retina while you are grasping with the left hand. If you are not using this technique, you need to use a very gentle maneuver by your left hand because the retina is detached, and when you are just separating or gentle pressure on the surface of the retina by the fibrovascular membrane, the retina is welcoming with you, and we don't have such a beautiful support when you are working on such a membrane. And again, we are starting in the lower part. I close the forceps, the scissor, and go also by a blunt dissecting of the membrane, trying to decrease the attacking of the membrane by cutting the membrane, not by dissecting it. I will a little bit moving the video for sake of time. Now I succeed to remove the membrane and the one membrane, and again the one membrane, and I remove it by the cutter, remove the rest of the membrane like this. And this is also another point. You didn't need to remove the BFC if you need to decide to remove the ILM. Inject the stain under the BFC and also remove the ILM under the BFC. And all this time, the hemostatic effect of the BFC and the supporting effect of the BFC help you to finish the posterior ball job and complete the anterior job also, like vitreous indentation and vitreous shaving. Leave this bubble at the end of the surgery and remove it after you finish the surgery. Thank you.
Excellent, beautiful work. Really liked it, and a super trick. Just quick question to ask that how much vitrectomy was done before you when you introduced the heavy liquid, or you started with the heavy?
We start with what?
How much vitrectomy you had completed before you put in the heavy liquid?
Oh, the technique of trimanual vitrectomy. How much the technique? No, I don't have the exact number.
You've done the vitrectomy. You did the vitrectomy.
How much the vitrectomy? So I complete the vitrorexis, separating the posterior membrane 360, totally 360 from attachment of this membrane to the anterior vitreous. Because if you are putting the BFC and there is still connections of this membrane with the anterior vitreous, the job is difficult here because we need a free anterior edge of the membrane 360. So with attacking the membrane in all the clock hours is a free anterior edge. So it must be complete 360 vitrectomy, separating all the membrane from the anterior vitreous.
Very good.
Dr. Ahmed.
That's a great case, well done. Just a very quick comment. Usually when you cut, you're crushing the vessels, so actually bleeding should be less. Blunt dissection, you're avulsing the vessels, so bleeding should be more. But I mean, it's beautifully in your hand, but I just want to stress on this point that crushing the vessels while cutting actually decreases bleeding.
When you cut, decrease the bleeding?
Because you're crushing the vessel with the scissor, so it decreases bleeding.
Yes.
Yeah, I mean, blunting is easier to find the epicenter, but that's like more avulsing the vessel. But again, what works in your hand is beautiful. Thank you so much.
Thank you.
Do you ever use a spatula?
Yes. Yes.
Would you prefer using spatula than rubbing with the
I think that's all fine. I mean, he makes it really look very easy. It's fantastic. But I was trying to stress that when you cut with the scissors, you're actually crushing the vessels, so bleeding should be less.
Last question I want to ask you. Is there a limitation to this technique?
Yes.
I mean, the limitation in the sense what Mohammed Naeem has shown that case. Will you use the same technique to do that case?
No, no.
It's a limitation if you have a obvious break when you are doing this surgery. I tend to do the regular bimanual surgery. First thing. The second thing, if the membrane is a little bit smaller membrane, you don't need to do this job. Make it if you are failing to separate the posterior membrane from the anterior vitreous, I would never do this PFC, because if you have a shortening retina and you are not separating the membrane and freeze the posterior pole from the vitreous, when you put the PFA pupil, the retina will be shortening and will not flat posterior. So it's not as a mandatory for all the fibrovascular membrane.
Thank you. So I welcome our next speaker, Dr. Ahmed, please.
Hello. So I would like to share with you my plan for extreme closed funnel cases. So this is a plan. That means it should be reproducible. That's why I put it into words for you. So this was a trauma case, 10 years old. He had a repair a month ago. I usually use 2 chandeliers in these cases so as to illuminate the upper and the inner side of the retina. And then I first remove the anterior PVR or the flaps to get on with this job. Then I let loose the retina if it's vertically tense upwards so as to be able to work, because if it's vertically up, I cannot work properly. That is, if I choose to attack the retina from outside of the closed funnel, not from inside. But I chose here to work from outside first because I saw the napkin ring and the thick PVR outside of the cone, so I chose to do it from outside. If it's attached all over and it's a closed hole, it's a closed funnel, so I start from the center. Then I use a double forceps technique to remove the PVR and shear open the peripheral contracted edges of the closed funnel so as to open it, so as to get access into the funnel to remove the PVR, especially this stalk of PVR attached to the disc. And if you remove this stalk, the closed funnel will open up a little bit. So after opening up a little bit, I inject a bubble of PFC so as to stabilize the retina and go trim the contracted edges. I have to trim the contracted edges because I have tried to leave them and laser over them, but they always contract more and lead to detachment after that. So I shear them open, I trim them by the cutter, and I do diathermy over them, but I freshen up these edges. Then I reposition the retina at the right rotation and put some PFC, not so much so as not to topple over the retina. And if it's still contracted, I do multiple radial cuts to increase the circumference. These usually increase the circumference of the retina. If you do a radial cut, this increased circumference increase the retinal circular circumference, and it can flatten. I use as much as I can radial cuts as much as needed. Then I stain all over the retina under the PFC to see if there is still PVR left. And I usually do the ILM, not for the sake of the ILM, but to make sure that the PVR is removed from over the retinal surface. And that's usually it. I do the laser barrage, and I put silicone, and then I use the dual option of the injection aspiration to remove the rest of the PFC, and that's it. Thank you. Any questions?
Yeah, wonderful case.
Thank you.
and very beautifully delivered. I feel that if you can keep a hinge of the retina to one side, then possibly you can avoid post-operative cyclotorsion, because sometimes your macula may be a little bit torsion down or up. Okay, so keeping at one hinge, and while you open up, you put the bubble of TFO.
You mean if there is a part of the retina, just one or two clock hours,
yes,
you leave it?
keep it. No,
if there
just for the posterior one to sit. After that, you remove it for it.
You cut it.
Okay.
Yes, of course. That's a good,
Yeah,
a very good point.
because-
But sometimes this hinge makes the retina still upwards and
Yes.
and prevents it from going flat.
Yeah, that's why only to get the macula right in place, because many times.
That's a good idea.
Yeah,
I'll put it in the plan.
Yeah, so many times you have to use a long soft tip to shaft the retina to move, because that's what we used to do translocation.
Yes.
Okay, we used to have a lot of problems,
Very nice
which
idea.
we gave up. Okay,
Thank you.
so I think you did a very wonderful job.
Thank you.
And well done.
Thank
Thank you. Mohammed, you have a last word about the case?
Thank you very much, Dr. Ahmad. Thank you for all of you. We are sorry to keep you until this time, but I think everyone sitting here, they are enjoying what they are seeing and discussion. We are going to meet at 9 o'clock for gala dinner for a speaker. It will be in the swimming pool, just here near to our ballrooms outside. Yeah, if someone wants to swim like Dr. Osman, he can come. Thank you very much, and see you tomorrow, inshallah. There is an early morning for Arabic, those they want to attend Al-Qahwa, very interesting sessions, and tomorrow it will be, I think, medical or surgical, Dr. Muhammad, tomorrow. Yeah, so see you tomorrow. Thank you very much. Thanks a lot. Good night. Bye-bye.
Not come in the evening at night.
Yeah.
I'm going out with my cousin sister.